And as you can see, there was a significant improvement. There was a months between the two treatment arms. So once again, it's an effective agent in the second line setting, however, was not addressing the question after failure of CDK. Okay, so we cannot generalize these data to those who failed CDK4/6 in the first line setting. Not only this, I mean, this kind of like combination have been also entertained in the first line setting in a single arm study, as you can see, with a median progression-free survival of almost 22 months. So it's quite similar to the CDK4/6 progression-free survival. It was like around 27 months for CDK4/6. Here it was 22 months. So it's not head-to-head comparison, so we cannot make these data as solid. But if you look into the toxicity profile of everolimus and the marginal benefit when it comes to the first line setting, so we still prefer to stick to CDK4/6 inhibitor in the first line setting. So also you have to consider the financial toxicity of this treatment. The cost 1 month of everolimus in our like currencies around 15,600 Saudi riyal. So it's an expensive medication, plus it's very toxic and is not as good as CDK4/6 inhibitor in the first line setting. So we have to be careful with that. So interestingly about everolimus, there was an analysis of those patients who have been treated with this agent, and they have stratified those patients according to the PIK3CA mutation. And regardless of the PIK3CA mutation, the everolimus was effective. So even those patients who have wild type PIK3CA and those who have mutant, they derive benefit in comparison to the control arm. So this is something good about everolimus, that you don't have to test for PIK3CA mutation. So you might argue that all these data have been presented without having patients who failed CDK4/6 inhibitor in the first line. So do we have any data to support using everolimus in the second line post CDK4/6? Once again, we have small kind of studies. One of them is this study, which included 33 patients, and they have been treated with exemestane everolimus in the second line setting after CDK4/6 inhibitor, and there was a durable kind of response to these agents. And as you can see, the progression-free survival was around 5.7 months versus 4 months for those who had prior CDK4/6 versus those who did not, which means that this kind of combination of everolimus exemestane is effective in both groups. There was another study by Mayo Clinic people, those who failed CDK4/6 inhibitor in the first line setting or second line setting, they have been switched to different kind of agents, like either single agent endocrine therapy or other biological treatments. It was found that exemestane everolimus provided the best kind of treatment benefit, with a median to treatment failure of about 13.2 months, which is really significant after having 1 or 2 lines of endocrine therapy that included CDK4/6 in these lines of treatment. There was also another Italian study, it's called the EverMet study. Once again, uses everolimus plus exemestane as a first line or subsequent line. And those who failed CDK4/6 inhibitor in the first line, who have been switched to exemestane, everolimus, they had a progression-free survival that's significant, and that's similar to those who did not have inhibitor in the first line setting. So all of these data, despite the fact that they are small data, we cannot make it as a level 1 evidence, but it does like tell us that this kind of combination is effective even for those who failed first line CDK4/6 inhibitor. Of course, mucositis stomatitis is the most scary kind of side effect with this kind of treatment, everolimus. So you have to be careful. For those who uses everolimus on day-to-day basis, they are really expert on managing these like side effects like steroids, mouthwash, early intervention, and to educate patient about their mouth and dental hygiene. Okay, so as I mentioned, endocrine therapy, whether talking about exemestane, everolimus as per Polero 2 is an acceptable option. Also, you can use fulvestrant plus everolimus. You can also use tamoxifen plus everolimus as per the TAMRAD study. So all of these are valid options after failure of CDK4/6 inhibitor. What about PIK3CA mutation? Okay, this is the new star that we just, started to hear about 2 years ago. We started to know about the PIK3CA mutation as per the SOLAR-1 study, which have tested the combination of fulvestrant and alpelisib in those patients who failed the first-line endocrine therapy. Before we go that far, just to tell you that the PIK3CA mutation is a prognostic kind of biomarker. So those who have this kind of mutation, they do worse with regard to response rate, with regard to progression-free survival and overall survival in comparison to those who have wild-type PIK3CA like gene. So this data does tell us that this kind of biomarker is prognostic. It can predict for a worse outcome in these patients. Not only this, it also has a predictive value. How come? In SOLAR-1 study, which was randomizing patients first to those who have failed first-line endocrine therapy, they have been randomized in 2 different cohorts, those who have PIK3CA mutation and those who did not have PIK3CA mutation. And it was found that the benefit was mostly limited to those who have PIK3CA mutation. So it can predict benefit to this kind of agent, which is alpelisib, which is unlike the Polero 2 study, which I presented, that the everolimus is actually active regardless of the PIK3CA mutation. So we have to be careful about these kind of terminologies. How to test for PIK3CA mutation? If you follow the rule of the SOLAR-1 study, they did circulating DNA in the plasma, and if the patient was PIK3CA mutant, they gonna consider him for alpelisib therapy plus fulvestrant. But what if the plasma test was negative? It was found based on retrospective analysis that those who have a plasma negative results, if they do a tumor test, up to 40% of those negative people will be found to be PIK3CA mutant in the tumor sample. So now it's recommended actually to do first the plasma level or the plasma circulating DNA test. And if it's negative, there is a 40% chance that this patient might be positive on the tumor sample testing. So it's better to do it in a stepwise fashion. So this is the SOLAR-1 study that I just mentioned. And as you can see, there were 2 cohorts who have those who have PIK3CA mutation and those who doesn't have this kind of mutation. I'll focus my discussion on this group, the PIK3CA mutant cohort, and they had been randomized to fulvestrant single agent versus fulvestrant plus alpelisib with the primary endpoint of progression-free survival in these patients. As you can see, progression-free survival was significant, almost 5.5 months difference between the 2 treatment arms, 11 versus 5.7 months, with a hazard ratio 0.65 with a significant p-value, as you can see. All of these subgroups of patients from this kind of combination, including those who have visceral metastasis, those who have received prior CDK4/6. Despite that, those who receive CDK4/6, they are around 6 to 7% only of the total population. Response rate has also doubled from 16% to over 35% with the use of alpelisib. Overall survival, there was no significant difference between the 2 treatment arms. like fulvestrant plus alpelisib versus fulvestrant alone. However, if you look into the subgroup analysis, you can see that those who have visceral metastases, they derived like really significant trend towards improved overall survival. So if you have a patient with PIK3CA mutation with visceral metastases, they are the best patients for this kind of combination in the second line setting after failure of first endocrine therapy line. This agent is not completely benign agent. There have been several toxicities that have been described, including skin rash, stomatitis, hyperglycemia. So you have to control these problems, specifically blood sugar, before you start these agents. And of course, these toxicities have affected the continuation of the treatment and the treatment dose or the dosing of this kind of treatment if you don't control these toxicities well. The cost of alpelisib is around, like according to the labeling of this drug, is around 22,300 Saudi riyal. It's expensive medication. So we have to be careful on selecting the best patients who can get that kind of treatment. So the question about CDK4/6 still arising. Should we use this kind of combination after CDK4/6? Because in the SOLAR-1 study, only 7% of patients, they receive CDK4/6, which means 93% of patients did not. So can we generalize the rule to use alpelisib plus fulvestrant after failure of CDK4/6 inhibitor? We don't have solid data. However, there was a phase 2 study, which was presented almost a year ago by Leave's study, using those patients who have this kind of mutation, PIK3CA mutation, after failure of first line, including CDK4/6 inhibitor, they have been randomized to use endocrine therapy, either fulvestrant or aromatase inhibitor plus alpelisib in the second line setting. The primary endpoint was the progression-free survival at 6 months. As you can see, it was around 50.4% using second line alpelisib plus fulvestrant, as you can see here. Remember, in the SOLAR-1 study, this value was around 44%. So once again, it gives us more assurance to alpelisib plus fulvestrant in the second line setting if you have a PIK3CA mutant patients. So this is a standard of care nowadays. If you have a patient, you have to test him for this kind of gene mutation. If it tends to be positive for mutation, then you have to consider this combination. And just to remind you that this drug had been approved by FDA in May 2019, so almost like 2.5 years ago. Okay, so as I mentioned, the next kind of discussion about the AKT inhibitors. Okay, so there was a phase 2 study of FACTION called the FACTION trial using what we call the capivasertib plus fulvestrant. Once again, after failure of first-line aromatase inhibitor that included 140 patients, there have been doubling of progression-free survival and trend towards improved overall survival. This is a phase 2 study. There is a phase 3 study nowadays is going on, but again, is not addressing specifically for those who failed CDK4/6 inhibitor, but is for second line setting. And as you can see, once again, these are the progression-free survival curves. They are really significant. Overall survival, there is
Dr. Ahmed, 2 minutes.
Yes, a strong trend towards improving survival. And this kind of benefit of the AKT inhibitor, once again, is not related to the PIK3CA mutation. So regardless of that, there is a benefit of using this combination. What about HER2 mutation? There have been a study called the Summit basket trial. They did NGS, next generation sequencing, for those who have been hormone receptor positive, HER2 negative, and if they found any kind of HER2 mutation, they have been tested for use of neratinib, which is an anti-HER2 TKI, plus trastuzumab plus fulvestrant. And once again, you can see the response rate is almost 60%, and the progression-free survival was around 8.3 months, which is really impressive. But again, we need more data to support that kind of approach. The last kind of strategy, or before the last, the mutation in the estrogen receptor. We know that during the endocrine therapy management, these kind of gene mutation can arise during the treatment. And we know that this kind of gene mutation might affect the response to endocrine therapy. There have been a very interesting phase 3 BRADA-1 study, which was presented actually in the last ASCO. They found that they included more than 1,000 patients, and they been treated with aromatase inhibitor plus palbociclib just to see the effect of the gene mutation in the estrogen receptor. by doing circulating DNA testing. They found that 3% of patients, they had upfront kind of estrogen receptor mutation, and those, they had worse progression-free survival in comparison to those who did not have this kind of mutation. And as you can see, this is a progression-free survival for those who have estrogen receptor mutation versus those who don't have the mutation. Interestingly, they found that those patients who cleared from this mutation by using palbociclib and aromatase inhibitor, they match their progression-free survival to those who have a wild-type estrogen receptor, which is a good thing. Okay, so you can see those patients who have been cleared from the gene mutation in comparison to those who still have gene mutation. And this is the progression-free survival of those who was cleared from gene mutation in comparison to those who continue to have this kind of gene mutation. So the Olympiad study and the talazoparib in the IMBRCA study, both PARP inhibitors have been used. If the patient has a germline BRCA mutation, you may consider that in the second line setting, which is another kind of option that you may consider in these agents. So I'll come back to these options I mentioned at the beginning of my talk. You have more than 7 options available. Actually, 3 of them, as you can see, are clinically valid in your clinical practice. Endocrine therapy plus everolimus, you don't have a clinical predictor for that. Using PIK3CA mutation for alpelisib plus fulvestrant. PARP inhibitor, you need to do germline mutation for BRCA, you have to test for that. So these are the 3 agents that you can use in the second line setting after failure of CDK4/6 in the first line setting. Remember, chemotherapy is always an option. Okay, even single agent chemotherapy like capecitabine might be as less toxic as any of the endocrine therapy that we use in our clinical practice. So don't forget that. These are the APC guidelines for advanced breast cancer. I like them because they are very practical, even better than the NCCN. So I advise everyone to use them in their clinical practice. So to summarize, aromatase inhibitor plus CDK4/6 inhibitor represent the standard of care for the vast majority of hormone receptor positive, HER2 negative advanced breast cancer. Beyond CDK4/6 inhibitor, we don't have a high level evidence to guide sequencing. However, testing for biomarkers may help to guide, like PIK3CA mutation, germline BRCA mutation. For mutant PIK3CA cases, fulvestrant plus alpelisib may represent the best next option, as per the SOLAR-1 and BYLieve study. For wild type PIK3CA, if you have tested for that, exemestane and everolimus is an option. Other options may include single agent tamoxifen, fulvestrant, PARP inhibitor if you have a germline BRCA mutant, if not previously used. Chemotherapy is always an option, especially if you have a visceral or impending visceral crisis. With that, I would conclude. Thank you so much.
Thank you, Dr. Ahmed. That was a great talk. So I think we'll go to the second speaker. The second speaker is Dr. Sharif Sammani. He's a consultant medical oncologist at King Abdullah Medical City, and he's the head of medical oncology. Dr. Sharif, he will be talking about hormonal receptor positive, HER2 positive breast cancer, biology and therapeutic implications. So please, Dr. Sharif.
Okay, thank you very much, Dr. Abdullah. My task today is to talk about hormonal receptor positive, HER2 positive breast cancer. What about the biology of this category of HER2 positive breast cancer, and what is the therapeutic implication that can be offered for those patients? So before going ahead, I will share with you this real case scenario. This is one of my patients. This is 57 years, postmenopausal female. She presented with right breast cancer. The baseline biopsy is invasive ductal carcinoma, AR 90%, PR 70%, HER2 positive. And baseline staging CT cap showed multiple bilateral lung mets, 5-6 lesions in each side, in addition to 2 liver metastatic lesions. She started with first-line chemotherapy with docetaxel, trastuzumab, pertuzumab. Unfortunately, 2 months after starting therapy, after 4 cycles, in the first evaluation, she had disease progression in the lung and in the primary lesion in the breast. Then, I'm sorry. She was shifted to second-line TDM1. 4 cycles of TDM1 and again disease progression, nowadays in the lung and liver. I took a new biopsy from one of the metastatic lesion. It showed the same phenotype, ER, BR strong positive, HER2 positive plus 3 by immunohistochemistry. This patient received third-line chemo with capecitabine plus labatinib, and unfortunately, after the fourth cycle, again, disease progression in the liver and lung. So this patient is unlikely to respond to further chemotherapy. I shifted this patient to hormonal therapy with letrozole plus trastuzumab, pertuzumab, and in this time, this patient has good partial response after 3 months of therapy, good partial response in the lung, and almost stable disease in the liver. So this is unusual scenario. However, it gives some insights about the differences in the biology of some cases for hormonal receptor positive, HER2 positive breast cancer. So back to the agenda of my talk today, we'll cover 3 main points. The first is the biology of this category of breast cancer, HER2 positive, hormonal receptor positive versus hormonal receptor negative. And then what are the therapeutic outcome, which may be different between hormonal positive versus negative. And then we'll finish with talking about some clinical trials dedicated for HER2 positive, hormonal receptor positive breast cancer. So first, what about the biology? If we look to the molecular subtypes of HER2 positive disease, you can see in this diagram that about half of the patients have HER2 enriched subtype. However, still there is very good fraction, about 44% of patients having luminal signature, either luminal A or B. If we dissect this molecular signature according to hormonal positive versus negative, as you can see in this diagram, you can find a great discrepancy between the 2 categories. In the hormonal negative HER2 positive disease, the majority, about 75%, have HER2 enriched with a few or little percentage of luminal signature. On the other hand, on the left side of the diagram, in hormonal positive disease, only 30% have HER2 enriched, while the great majority have luminal signature, either luminal A or B, about 66% of cases. So we have in the biology and the genetic makeup of this patient a lot of discrepancy between the 2 categories. In addition to this molecular signature, if we look to the signaling pathways running in HER2 positive disease, of course, as you know, there is expression in those patients, overexpression on the HER2 receptor on the surface of the breast cancer cell, but we have certain pathways running in, like the big 3 AKT, RAS, RAF, MEK, and so. But there is still some crosstalk between the ER pathway, ER receptor pathway, and its downstream signaling in the nucleus with other pathways, and it can affect the outcome with anti-HER2 therapy. I will give you an example about the differential effect of one of the key mutation in breast cancer, which is BIC3CA mutation. This mutation is prevalent in about 30 to 40% of HER2 positive disease. And in this exploratory analysis coming from the New ALTO study. New ALTO is a new adjuvant study where patients will receive the chemotherapy plus either trastuzumab alone or labatinib alone or trastuzumab plus labatinib. And the primary endpoint was a pathological complete response. As expected, patients having wild type BIC3CA have more PCR compared to patient having the mutation. Okay, and the difference is statistically significant in this exploratory analysis. But if you look to this category of patients with hormonal receptor positive, there is very little frequency of having PCR in patients having the mutation. And the difference is statistically significant. And the effect of having the mutation here is much more pronounced in hormonal receptor positive compared to hormonal receptor negative patients. So even the same mutation have some preferential or differential, or there is some discrepancy in its effect between the 2 categories of HER2 positive breast cancer, at least in this exploratory analysis. So the conclusion of this first part of the talk is we have 2 heterogeneous diseases, hormonal positive versus negative HER2 positive breast cancer, and we have some different molecular features between the 2 categories. Now we'll move to the second part, which is different therapeutic outcome between the 2 categories. We'll start with the differences in the outcome in the neoadjuvant setting. Again, to the New ALTO study, if we look to the rate of a pathological complete response between hormonal positive versus negative, as we know, there is a much higher rate of pathological complete response in hormonal negative patient compared to positive patient. And this trend or this phenomena is replicated in a lot of clinical trials that address this point. You can see this pooled analysis of many trials. Some received the trastuzumab alone, trastuzumab, labatinib, trastuzumab plus pertuzumab, but the trend is consistent. The rate of PCR is much higher in patients having hormonal receptor negative versus hormonal receptor positive. But the question is, why? Why do we have higher rate of PCR in hormonal negative patients? So to answer this question, we have this nice analysis coming from patients treated with neoadjuvant paclitaxel plus trastuzumab plus or minus labatinib. And they looked for the molecular signature of patients enrolled in this trial. And they found, as you can see in the right side of this diagram, that the rate of achieving PCR is much, much higher in patients having HER2-enriched molecular subtype. And it is almost the double of the patient having a luminal subtype. All are HER2 positive, but the rate of PCR is completely different. And this explains the differential effect of PCR, because as we just mentioned, patients with hormonal receptor negative, the rate of HER2 enriched subtype is much, much higher compared to the patients having hormonal receptor positive disease. And this has been replicated as well in different analyses. This data coming from real-world data of patients treated with chemotherapy plus either trastuzumab or trastuzumab, pertuzumab. Again, the trend is consistent. Patients having HER2-enriched molecular subtype, the rate of PCR is much higher compared to patients having luminal signature and all HER2-positive patients. What about the different therapeutic outcome in the adjuvant setting? I will just present two examples only. The first comes from long-term survival data, long-term follow-up from the HERA trial. HERA trial is an old trial. This trial was conducted more than 20 years, 25 years ago. And those patients were randomized after surgery into either chemotherapy alone or chemotherapy plus 1 year of trastuzumab or chemotherapy plus 2 years of trastuzumab. If you look to the upper part of the diagram, in the hormonal receptor category, you can see the difference in the disease-free survival is not great between the control arm and the patients receiving adjuvant trastuzumab. Of course, adjuvant trastuzumab is better, but the difference is not that much. But if you look to the lower part of the diagram and the hormonal receptor negative, the control arm did much worse compared to patients who received trastuzumab. So those patients actually need trastuzumab. All patients need trastuzumab. Yes, this is a standard of care, but the need of trastuzumab may be more pronounced in hormonal receptor negative. If you look to the right side, even the risk of progression or relapse is much higher in the control arm if they did not receive trastuzumab. Another example from the XNet study. This study enrolled patients with HER2-positive disease after finishing the standard surgery, neoadjuvant or adjuvant chemotherapy, and 1 year of trastuzumab. They were randomized into additional 1 year of neratinib or placebo. You can see here in the hormonal receptor category, positive category, there is about 5% improvement in the invasive disease-free survival, which is a primary endpoint. However, in the hormonal receptor negative, almost no benefit of additional 1 year of neratinib. So there is discrepancy in the outcome according to the hormonal receptor status. And this is an updated analysis confirming the same trend that the outcome is much better in hormonal receptor positive, but almost minimal benefit in hormonal receptor negative patients. So again, we need to ask ourselves, why do we have this different effect even in the adjuvant setting? I think the answer may come if we look to this pattern of relapse between the two categories of HER2-positive disease. If you look to the blue line, the patients with hormonal receptor negative, the trend is that we have a higher risk of relapse in the first 2 years, and then the risk of relapse decreases with time. However, in hormonal receptor positive, the risk of relapse is lower, but it is consistent over years. And the risk of relapse is still more or less the same after 5, 6, and 7 years. So if we give additional anti-HER2 therapy for additional 1 year, it may cover this late relapses that may happen in this category of hormonal receptor positive disease. Okay, now the last part of this talk is about some clinical trials dedicated for HER2 positive hormonal receptor positive disease. We'll start with some neoadjuvant trial. So nowadays, the trend is why we need now to explore the benefit of giving hormonal therapy with anti-HER2 therapy. This is one of the trial called ELISA trial. This is a very nice trial. They give 2 weeks of letrozole and they take another biopsy, interval biopsy after 2 weeks, and they look for the Ki-67 after 2 weeks of therapy. And if there is good drop in the Ki-67 after 2 weeks of letrozole, they classify those as molecular responders, and those patients continue letrozole, but now with Herceptin trastuzumab, bertuzumab. But patient, if not responding well to the with drop of Ki-67, they were shifted to chemotherapy, paclitaxel plus Herceptin bertuzumab. Please look to the rate of PCR, even in patients who are good responder by Ki-67 and maintained on letrozole, Herceptin bertuzumab, the PCR rate is about 20%, but in the chemotherapy group, the PCR rate is 80%. So despite all what we are saying in the neoadjuvant setting, still chemotherapy plus anti-2 is better. This is clear from this analysis. But again, keep in mind that about 20% of patients can achieve PCR with hormonal therapy plus anti-2 alone without any chemotherapy. And this phenomena actually is replicated in different trials. And the message from all this trial is, with hormonal therapy plus anti-2, there is a chance of PCR of about 20 to 30%. But the rate of PCR with chemotherapy is much higher. So another data, interesting data coming from the adapted trial. This is a German trial. They have a certain clinical trial in each subset of breast cancer will focus on HER2-positive hormonal positive. Those patients receive neoadjuvant TDM1 alone, TDM1 plus hormonal therapy, or hormonal therapy plus trastuzumab. As you can see in the left side of this diagram, PCR, of course, is much higher with TDM1. This is clear. But again, we have about 16% PCR with trastuzumab plus hormonal therapy. But an important finding here, as we expect that patients who achieve the PCR, the survival outcome is better. We know that. But important finding here, please look to this part of the diagram. Patients who achieve the PCR with hormonal therapy plus anti-2, the outcome in terms of long-term survival is the same to patients who achieve the PCR with chemotherapy plus anti-HER2. So the message here, if you achieve PCR by whatever treatment, the outcome is the same. Okay. So based on this data, again, before going to that, we have updated analysis from this trial. Some of these patients, after achieving PCR, who received hormonal therapy, in the adjuvant setting, some received additional chemotherapy and some not. And they looked for the survival outcome. There is no difference. So even additional chemotherapy means nothing. So if they achieve PCR even with hormonal therapy alone plus anti-2, that is enough. No benefit from additional chemotherapy. So the next wave of clinical trial that's planned by the German breast group is this design. Patient will receive hormonal therapy plus anti-HER2, trastuzumab, bertuzumab. If they achieve PCR, they will maintain hormonal therapy plus anti-2 in the adjuvant setting. If no PCR, they may go for additional chemotherapy plus anti-2 or TDM1. So by this smart way, you can pick about 20 to 30% who can achieve very good outcome without any kind of chemotherapy, even if they are HER2 positive. Quickly about this adjuvant trial. This is a still running trial called eMonarch here. In this trial, those patients who receive the standard of care, surgery plus adjuvant chemo, anti-HER2, or neoadjuvant chemo, anti-HER2, whatever standard of care. And those patients are randomized into standard of care endocrine therapy or endocrine therapy plus abemaciclib. They want to look for the benefit of the CDK4/6 inhibitor in the adjuvant setting in HER2-positive hormonal receptor-positive patients, and we need to wait for the results of this study. And I will finish by one trial in the metastatic setting of hormonal positive HER2-positive disease. This is a Chinese trial presented in last ASCO this year. And it is a trial in metastatic setting. Patients were randomized between hormonal therapy plus trastuzumab or chemotherapy plus trastuzumab. And the design of this trial is a non-inferiority trial. They want to prove the non-inferiority of hormonal plus anti-HER2 compared to chemo plus anti-HER2. Please remember that they used only trastuzumab. This study was started in 2013 before the approval of bertuzumab. That's why bertuzumab was not used in this study. I will skip this baseline characteristics, which were balanced between the two arms. Now to the primary endpoint. The primary endpoint is the progression-free survival, hazard ratio 0.88. Numerically, the outcome with hormonal therapy plus trastuzumab is better. And the non-inferiority margin is a hazard ratio of 1.35. This margin was not crossed, so we can say that non-inferiority Okay, and the second point, overall survival, the same. Non-inferiority was demonstrated in terms of overall survival. A nice subgroup analysis in this trial when they looked for the disease-free interval from the time of diagnosis till having relapse with metastatic disease. Patients having shorter disease-free interval, chemotherapy seems to be better, but patients with longer disease-free interval, more than 24 months, hormonal therapy seems to be better. That's to say, patient with more indolent behavior, it seems that hormonal therapy is enough for those patients in this subgroup analysis. And this is a conclusion of the authors that non-inferiority with hormonal plus trastuzumab was demonstrated in this trial. So I will conclude with saying that in terms of biology, we have two heterogeneous disease between hormonal receptor positive and hormonal receptor negative patients with different molecular features. And we have some differences in therapeutic outcome. We have higher rate of PCR in hormonal receptor negative, and we have different therapeutic outcome in the adjuvant setting. Please remember the example of neratinib, as we said before, and even the relapse pattern is different, and we have more late relapses with hormonal receptor positive disease. And we have nowadays some clinical trial dedicated for this category of HER2-positive disease. And please remember that in terms of PCR, still chemotherapy is better. However, we need about 20 to 30% PCR with hormonal therapy plus anti-HER2, and we need to pick those patients. And in the metastatic setting nowadays, we have a clinical randomized trial that hormonal therapy in some patients, especially more indolent behavior, hormonal therapy plus anti-HER2 is enough. Thank you very much.
Thank you, Dr. Sharif. Very nice summary. You would think that optimizing hormonal therapy in the adjuvant setting is an issue that is done and dusted, and we know all about it. However, I think the duration of treatment needs to be well optimized, and maybe single agent adjuvant hormonal therapy isn't the standard for the future. And to highlight this talk will be Dr. Nasser Al-Lahloubi, our friend from Egypt, National Cancer Institute of Cairo. He is a professor of medicine and oncology at the NCI. He's going to highlight to us this very important issue and will give us some enlightenment into what's going to happen over the next couple of years. Hello, Dr. Nasser.
Hello. Good morning, everyone. I appreciate with my honor and interest to be part of this very successful annual international conference, Debate in Oncology. And the special thanks are to the chairman and to the organizing committee and for the extraordinary work. So I wish to try to cover these points, making an introduction and rationale to the extended duration of endocrine treatment, and to show what are the present guidelines, updated guidelines, and to make some review for the pivotal trials of extended duration of endocrine therapy after 5 years of adjuvant endocrine therapy. And then the main question of my presentation, how to personalize the duration of the adjuvant hormonal treatment. And I will focus on two things or two issues. The first issue is, do we have prognostic tools to assess the risk of late recurrence, which is after 5 years to 10 years? And do we have a predictive tool for extended adjuvant endocrine therapy beyond the 5 years? In my opinion, the story of hormonal manipulation in breast cancer and the story of estrogen receptor is a never-ending story. And all of us may know that George Bitson in 1896 was the first one to do bilateral ovarectomy for a case of metastatic breast cancer, and she went in a complete remission for 4 years. And later on, maybe 70 years or more later, in 1971, where the tamoxifen is introduced in the therapy of hormone receptor positive breast cancer. And this meta-analysis done by the EPC-TCG in 2011, the follow-up meta-analysis showed that tamoxifen in ER-positive breast cancer significantly reduced the disease recurrence in the first 10 years and reduced the breast cancer mortality by about a third in the first 15 years, and was more effective than 1 or 2 years of adjuvant treatment. As we can see, more than half of breast cancer recurrence and the deaths occur post 5 years of tamoxifen. And this is shown in Dr. Sharif's presentation. The annual risk of recurrence is particularly high in the estrogen receptor positive tumors compared with the estrogen receptor negative tumors, 5.2 between 5 and 8 years and 4.6 between 8 and 12 years. In the same EPC-TCG overview in 2011, the relative risk of recurrence and death were still evident, 0.6 and 0.68 and 0.66, after even stopping the tamoxifen at 5 years due to what's known as the continued carryover effect. What to give, whether tamoxifen or an AI, they divided patients between 2 cohorts. In cohort 1, where the AI was used as initial monotherapy versus tamoxifen, in the attack, and after a median follow-up of 10 years, anastrozole significantly improves the disease-free survival, time of recurrence, distant recurrence, and the contralateral breast cancer. And in the BIG, or the big 198, the letrozole improved significantly 5-year disease-free rate compared with tamoxifen group. And in cohort 2, which used AI and tamoxifen switching strategies, there is also decrease in the recurrence rate with the switching strategy compared with tamoxifen monotherapy. And there is always a statistically significant larger carryover effect for anastrozole compared with tamoxifen in postmenopausal women. Dr. Ban published in the New England Journal of Medicine in 2017 the 20 years risk of breast cancer recurrence in more than 115,000 cases who received endocrine therapy and were followed up for 20 years after stopping endocrine therapy at 5 years. The risk of distant recurrence was strongly correlated with the original tumor and nodal status, with risk ranging from 10 to 40%. This is the 5 year of endocrine therapy patients with a stage 1 disease. The risk of distant recurrence in the period between 5 and 20 years was 13% for node N node, and 20% for N1 to 3, and 34% with 4 to 9 positive nodes. Among the T2 tumors, the risk were 19, 26, and 41 respectively. Although the recurrence continued steadily for 20 years, the predictor of distant recurrence during the 5 to 14 years in women who received 5 years of endocrine therapy were node positive with a relative risk ratio of 2, more than 2 size with a relative risk ratio of 1.7, high grade with a relative risk ratio of 2, and high KI 67. And then moving to the second part of my presentation, which is the guidelines. As we can see here in the guidelines, this is the recent guideline, the most updated from version 8, 2021, speaking about the duration. If we have in premenopausal received tamoxifen for a matter of 5 years, and then if they still premenopausal, you can consider tamoxifen for completion of 10 years, and if they became postmenopausal, we can go for aromatase. And for postmenopausal, for those receiving switching with tamoxifen, continue for AI for a matter of 5 or 6 years, or those who are contraindicated, or there is any absolute or relative contraindication, or they cannot tolerate the AI, they can use the tamoxifen for a matter of 10 years. And this is during the Sengal in 2021, one section actually has been focused on the extending endocrine therapy beyond 5 years. And for node positive, ER positive, for node positive, hormone receptor positive, HER2 negative patients, the majority, 87, considered a prolonged endocrine therapy as indicated. 34 voted for additional 2 to 3 years in addition to the 5 years, and 53% voted for completion of 10 years. And this is the ASCO clinical guidelines recommend that women with node-negative breast cancer are potential candidates for and may be offered extended AI therapy for up to a total of 10 years of adjuvant endocrine therapy based on consideration of the risk using established prognostic factors. And women with node positive should be offered extended endocrine therapy for a total of 10 years of adjuvant endocrine treatment. As none of the studies for endocrine therapy, extended endocrine therapy, have shown improvement in the overall survival with longer duration of AI, the recommendation on extended adjuvant AI therapy should be based on the risk. So how to categorize the risk? This is the point which I'm going to discuss over the coming slides. This is the ESMO clinical practice guidelines for premenopausal tamoxifen for 5 to 10 years, and in patients becoming postmenopausal after the first 5 years of tamoxifen switch to AI. And extended adjuvant therapy should be discussed with all patients except those with very low risk of relapse. And then this is the main issue of my presentation, the pivotal trials. This table, I made it to summarize the results of several randomized trials, suggest that extending adjuvant endocrine therapy beyond 5 years can improve the disease-free survival. We have 3 types of trials. The first category includes the extending tamoxifen for additional 5 years after initial 5 years, like the ATLAS and ATOM. We have addition of 5 years of an AI after 5 years of tamoxifen, like the MA17 and SABB B33 and the ABC SG6A. And we have extending the duration of an AI after initial endocrine therapy, which is mainly an AI. Shown here are the 2 large studies exploring the question of duration of 5 years of tamoxifen, in addition to to complete 10 years as adjuvant endocrine therapy. The first is the ATLAS, which randomized close to 13,000 early breast cancer, ending 5 years of tamoxifen to 5 more years or stop. And the second is the ATOM, which randomized close to 7,000 patients, ending at least 4 years of tamoxifen as an adjuvant to 5 more years of tamoxifen versus not. Extending duration of adjuvant tamoxifen to 10 years was associated with reduction in the mortality after 10 years by 25% with a hazard ratio of 0.75. Here is the MA17, where 5,000 postmenopausal women who had completed a 5 years course of tamoxifen were randomized to 5 years of letrozole or placebo. Letrozole was associated with an improvement in the disease-free survival with compared to placebo, with an improvement in the OS. And women who had been premenopausal at diagnosis experienced significantly greater benefit of extended letrozole in terms of the disease-free survival. And the initial results from MA17R were presented at the plenary session of the ASCO 2016 annual meeting by Dr. Burgos. This phase 3 was designed to assess the effects of extended use of letrozole in postmenopausal women with hormone receptor positive early breast cancer treated with 5 years of an AI as an initial therapy or preceded by 5 years of tamoxifen. The extended letrozole treatment to 10 years has significantly improved the disease-free survival at a median follow-up of 6.3 years, and a lower incidence of contralateral breast was observed in the letrozole-treated group compared with the placebo group. Here we have the NSABB B42 trial with close to 4,000 patients compared 5 years of endocrine therapy, including an AI versus 5 additional years of letrozole. And the NSABB B42 showed a 3% non-significant improvement in the disease-free survival, 84% versus 81%, hazard ratio 0.85, and a significant 28% reduction in the distant recurrence, 3.9 versus 5.8% with a hazard ratio of 0.72. And this is an EBC TCG meta-analysis of individual patients from 12 randomized trials, including close to 25,000 women who has been presented during the San Antonio Breast Cancer Symposium in 2018, which might represent the most reliable possible summary of the available evidence to inform clinicians on the efficacy of extending AI therapy compared with stopping AI after 5 years of endocrine treatment. This meta-analysis showed that extending adjuvant endocrine therapy with an AI beyond 5 years in postmenopausal women with early breast cancer reduces the occurrence of secondary breast cancer, but has no or only a small impact on the distant metastasis-free survival as well as on the overall survival. And the benefit of extended therapy with an AI was restricted to patients at high risk, node-positive, larger tumors, or after initial treatment with 5 years of tamoxifen. Adverse events we should be all aware about are a major problem for compliance over this very long period, and they include bone loss, fractures, arthralgia, cardiovascular symptoms, fatigue, menopausal symptoms. The pooled data from all of these trials, with more than 7,700 in each arm, showed that the extended endocrine therapy with an AI improved the disease-free survival when compared with the control, with a hazard ratio in this pooled analysis of 0.79. In order to evaluate the absolute benefit, the risk of recurrence, especially the late recurrence, need to be assessed, and this is estimated by a combination of tumor extension, tumor biology, age, and patient condition. In addition, gene expression profiling is one helpful additional factor for defining the risk. First one was the clinical treatment score post 5 years, or CTS5, is a late recurrence predictor that includes the tumor size, the number of positive nodes, the histologic grade, age, and the score was developed from the attack data and validated in the big 198 dataset. This is the Kaplan-Meier curves for 5 and 10 years distant recurrence rate for overall population according to the trial, solid lines in the attack and dashed line in the big 198. As we can see, there is a wide separation between curves for low versus intermediate risk, hazard ratio of 2.19, and low versus high risk with a hazard ratio of 5.33. In 2018, Dr. Sistak et al. Presented the comparison of the 6 multi-gene signatures, the Oncotype DX, recurrence scores, the breast cancer index, and the BAM50 Prosigna, risk of recurrence, and the EndoPredict or Epiclin, and the clinical treatment score, and the IHC4 for women with early breast cancer treated with endocrine therapy for 5 years in the attack trial. Only, as we can see in this table, the risk of recurrence, the breast cancer index, and the Epiclin or the EndoPredict provided prognostic information for late recurrence between 5 years and 10 years. And patients with node-negative disease who were classified as low risk for late recurrence by the breast cancer index, the risk of recurrence, and the Epiclin experienced a 3 versus 1 versus 4% recurrence rate, respectively. Individuals classified as high risk experienced a 15, 23, and 15% recurrence, respectively. If they were node negative, and if they were node positive, it's a 36, 25, and 24% risk if they have 1 to 3 positive nodes. The breast cancer index, it combines a 5-gene prognostic molecular grade index with 2 genes predictive biomarker ratio of the HOX-B13 and interleukin 17B receptor, which is H/I. The breast cancer score ranges from 0 to 10 and classifies patients as low or high risk. Data from MA17 and the ATOM trial showed that the breast cancer index was predictive for the benefit from extended adjuvant endocrine therapy in patients with node negative or node positive hormone receptor positive early breast cancer. This is the translational ATOM or trans-ATOM study, is a large-scale validation of the predictive ability of the breast cancer index for extended endocrine therapy benefit. And as we can see, the absolute risk reduction from the extended endocrine therapy for patients with high H/I was 10.2%. This is, as we can see in this table, the risk of recurrence was 27% and 37% for patients treated with 10 and 5 years of tamoxifen respectively, demonstrating a significant absolute benefit of 10.2% for reduction of the risk of recurrence, p-value 0.027. And currently, the only breast cancer index assay reports predict the benefit to extended endocrine therapy independent of the rate of late recurrence. With that, in my own statement, actually, hormone receptor positive breast cancer has a high propensity for late recurrence and might be prevented with longer duration of endocrine therapy. Patients with higher stage disease are at greater risk for late relapses, and even patients with stage 1 disease has a significant risk of recurrence post 5 years. We have shown it's 13%. Current guidelines recommending extending therapy, adjuvant endocrine therapy for patients with node positive, but recommendation for node negative has to be tailored. This has led to the development of various genomic tests to aid the oncologists in further individualizing their approach when it comes to deciding which subpopulation of patients with hormone receptor positive breast cancer may benefit from extending endocrine therapy beyond 5 years. We have several assays that are prognostic for recurrence between year 6 and 9. However, the breast cancer index has been shown to be predictive for extended endocrine therapy in patients who have completed 5 years of tamoxifen. And with that, I stop here and I'm ready to accept any comments or questions.
Thank you, Dr. Nasser. It was great talk and very informative. I think you stay with us. So we will have the discussion at the end of the session, and we are coming to the last talk. So the last talk will be by Dr. Nafisa Abdelhafiz. Dr. Nafisa, she is a consultant medical oncologist at King Abdulaziz Medical City. She will be talking about molecular tools as a guide for adjuvant chemotherapy in hormonal positive HER2 negative breast cancer. So I think Dr. Nafisa, she's joining us from Riyadh, is it?
Assalamu alaikum. Thank you, everyone. Good morning. Thank you, Dr. Sharif and the organizing committee for this kind invitation. And thank you, Dr. Ali, for the kind introduction. Today, my talk is about molecular tools as a guide for adjuvant chemotherapy in hormonal positive HER2 negative breast cancer. So it's not moving, sorry. Just give me 1 second. So we know that for women with early estrogen positive or HER2 negative breast cancer, the mainstay of treatment is adjuvant endocrine therapy. This is well-known information for every one of us, oncologists or non-oncologists. But still, there are some patients who can benefit from chemotherapy. But the magnitude of the benefit of chemotherapy might be very small, and this depends on the baseline risk of recurrence. And this risk of recurrence can be estimated from the biology of the disease, like tumor size, presence or absence of lymph node, grade of the tumor, proliferation index, and other gene expression. So we know that adjuvant chemotherapy can decrease the risk of recurrence, improve overall survival, but the benefit, as I said, in the patient who are having low risk disease might be very small. Therefore, the decision to give chemotherapy should consider the biology of the disease as well as the comorbidity of the patient. The benefit of giving chemo in the adjuvant setting had been discussed and came out from the clinical trial, which was big clinical trial, EBCTC trial, which was a meta-analysis. Thousands of patients had been enrolled in this trial. And in this trial, they conclude that chemotherapy can decrease the risk of recurrence from 47 to 39%, decrease breast cancer mortality from 36 to 29%, and decrease overall mortality from 40 to 35%. So there is a big difference between no chemo and chemotherapy. So compared with no treatment, also the CMF was found to give the same result at 10 years. So improvement in PFS and overall survival. But this not without any side effect. Definitely, we know we have a long list of toxicity, immunosuppression, nausea, vomiting, hair loss for the females, and neuropathy for taxane, cardiotoxicity, and leukemia in rare cases. So very high toxicity profile for very minimal patients who are having early breast cancer, hormonal positive HER2 negative disease. So many risk calculators had been developed years ago to define the patient and classify them into low risk and high risk. But in the last 15 years, we saw revolution in this field, and many tests had been introduced to the and given to oncologists to decide upon the using or not to use chemotherapy. So ASCO talking about 5 tests: Oncotype DX, EndoPredict, PAM50, and breast cancer index, and 70 gene, which is a mammoprint. So recurrence scores, this is the first one that we knew and we start to use, well validated. This is Oncotype DX. It's well known to every one of us. It had been validated, and it gave us a good classification of the patient into low risk, intermediate risk, and high risk. It was developed by using 16 genes. These genes are disease-related or tumor-related, and 5 genes were standards or control genes. The sum of this calculation give us RS or recurrence score. So the Oncotype DX had been validated in 2 main big trials. The first trial was B14 study, and B14 showed us that RS continued to be predictor of recurrence independent of patient age or tumor size. And B20, it again showed us that the patient who are having high risk disease, high recurrence score, they will benefit from giving them adjuvant chemotherapy in the adjuvant setting. Now, the RS had been prospectively validated in a big trial, which is the TELEREX trial. And after that, or before that, it had been introduced to and incorporated as a part of NCCN guideline. So the TELEREX trial was a phase 3 randomized trial comparing adjuvant endocrine therapy to adjuvant chemotherapy plus endocrine therapy. Rationale behind that, in the B20 trial, we know that patients were classified into low risk, intermediate risk, and high risk. We knew that patients who are having low risk, we can go ahead and very comfortably giving them endocrine therapy in the adjuvant setting. Patient with high risk, straightforward, they go for chemotherapy followed by endocrine therapy. But we're left with a patient who are in the middle. We don't know exactly what to do with them, how to deal with them. Some of us think that we should have give them the benefit of doubt, give chemo, then followed by hormonal therapy. Some of us think, no, why should I expose them to very toxic medication? So hormonal therapy is enough. So very difficult decision and very tough dilemma in the clinic setting. So this is in a simple way, the design of the trial. So 3 arms. First arm, the low risk, they went ahead and give them a hormonal therapy. Those patients who are having RS less than 11, patients who are having recurrence score 25 and above, they straightforward given chemotherapy. Patient in the middle between 11 and 25 were randomized to hormonal only or hormonal or chemo plus hormonal therapy. So eligibility criteria, node negative patient, ER positive, and HER2 negative. So primary endpoint, invasive disease-free survival. Secondary endpoint were freedom from recurrence of breast cancer or freedom from any recurrence and overall survival. Looking here at the primary endpoint, invasive disease survival, very obviously we can see the two curves, the curve of chemo plus hormonal and the other curve of hormonal therapy, almost the same. They are overlapping each other, no difference. And this is the same for distant relapse-free survival. So the p-value for both, so obviously it was non-inferiority trial. The p-value in both cases was not significant, and the hazard ratio was 1 in both. What about relapse-free interval and overall survival? Again, there was no benefit of adding chemotherapy to hormonal therapy in this group. So, but interesting exploratory analysis, they look at the patient and the subgroup analysis. They found that patients who are having a score, premenopausal patient, and their score between 16 and 25, 20 to 25, they did benefit from chemotherapy. Actually, this was irrespective of the tumor size, presence, disease grade. So all patients at this age did benefit from adding chemotherapy in the adjuvant setting. So in summary, or my conclusion for the TELRX trial, RS 11 to 25, endocrine therapy is non-inferior to chemotherapy. 0 to 10, definitely they don't need chemotherapy. 25 to 100, those patients, they need chemotherapy, and chemotherapy improves their overall survival. So what about the observation that they found the relation between chemotherapy and patient, the benefit? So they found some benefit in the patient who are premenopausal. So we think TELRX is a very good trial, very instrumental trial, and it defined it, because before we don't know when to give and not to give, but it gives us like clear number and clear cutoff number to decide about giving or not to give chemotherapy. So what about the other trial, MINDAC trial, that looked at the same, it had the same design of the TELRX trial, but they look at the patient who are having positive lymph nodes. So patient with early breast cancer, hormonal positive, HER2 negative, but we're having positive lymph nodes 1 to 3. So the other objective of MINDAC trial is to look at the benefit of chemotherapy, and is a chemotherapy related, there is a relation between recurrence score and the benefit from chemotherapy. So they include all patients from 0 to 25. So, sorry, responder trial. The responder trial is like mirror image for the TELRX trial. In the responder, you can see that patients were classified again into low, high risk, but all patients had been enrolled, but patients from score 0 to 14 went ahead for the arm of endocrine therapy, 14 and above up to 25 patient given randomized into 2 groups. The first group received hormonal therapy alone. The second group received chemotherapy followed by hormonal therapy. So when they look at the patient, the whole population of the trial or intention to treat population, there was no difference in invasive disease-free survival between chemotherapy plus endocrine therapy or endocrine therapy alone. There was also no interaction between chemotherapy benefit and the recurrence score. But also this trial gives us a hint that there is some benefit from. Again, they found the same. There was benefit from adding chemotherapy in patients who are premenopausal. So 5 years invasive disease-free survival in postmenopausal women was 92 in both endocrine plus chemotherapy or endocrine therapy alone. So in the premenopausal, there was significant improvement in invasive disease survival in the chemotherapy arm, as I mentioned, but the absolute difference was around from 1 to 5%. So looking at the benefit of adding chemotherapy to premenopausal ladies for a very very small benefit. This is also very challenging question, and we have to think why those patients benefited from addition of chemotherapy. Is it because of chemotherapy, or maybe because of suppressing their ovarian function by giving chemotherapy? This is another challenging question. So what about the other test, MammaPrint? MammaPrint is a 70 gene test, classified patient into two groups. The first group having good prognosis and the second group having poor prognosis, depending on their prognosis, so at 5 and 10 years. So it is prospectively validated for in patients who are having lymph node negative disease, and there was no difference in adding chemotherapy in a matter of disease metastatic-free survival. Recently, the MammaPrint had been validated in a very big, large trial, which is a MANDAC trial. This is a prospective trial, phase 3, randomized, and node negative and node positive patients who are having 1 to 3 lymph node positive. So the trial was designed to see the validity or the effect of using MammaPrint to classify patients into high risk or low risk patient. They enrolled around more than 6,000 patients. So this is a schema of the trial. It looks like very complicated, but in a simple way, again, patients who are having, they use MammaPrint plus ChemoPredict. They use like three scores, and they put patient into 3 categories. Yes, the first category, the patients who are having low risk profile, they give them chemotherapy. The patient who are having score, the high score, they give them chemotherapy. Patient in the middle, they divided them. They noticed some discordance between the tests, so they classified them into another 2 groups: patients who are having high clinical profile but low genomic profile, and patients who are having high genomic profile and low genomic profile. So and those patients, each group had been randomized into 2 arms. So arm received chemotherapy plus endocrine, and the other arm received endocrine therapy alone. So looking at this, they look at survival without distant metastasis and disease-free survival and overall survival into these 2 groups. So we can see like 6 graphs here. And in the 6th graph, we can hardly see any difference in the 2 arms, the arm with chemo plus hormonal or the arm of hormonal therapy alone, looking at the 3 objectives. So in median follow-up, the 5 years disease metastatic-free survival rate for whole population or for population with high clinical profile but low genomic profile was 95.1%. So the primary endpoint was achieved in this trial, and with longer follow-up, we know that if you can go back, you can see some difference with the long follow-up. We know the luminal disease, as the time goes, the incidence of recurrence of having disease relapse is high. But the difference was found between with years going. They found the difference in the benefit of chemotherapy in the BFS was like less than 2%. So it's again, this is a minimal benefit at the weight phase. Let us say we are giving for benefit of less than 2%, and the opposite to that, or in the other side, the solution for this to avoid this difference is to give very harmful treatment that can cause febrile neutropenia, septic shock, sometimes admission to ICU, and many of us lost their patient because chemotherapy toxicity. So it is level 1 evidence to use 70 gene signature to avoid chemotherapy in early stage breast cancer. So again, looking back at the group in the right and left side, extreme groups, the patients who are having low risk and patients who are having high risk, it was the same. Those patients with low risk profile genomic and genomic low risk and clinical low risk, they had the best overall survival. And the patients who are having high genomic and high clinical profile, they had the worst overall survival. It was like 90%, while in the other group was more about 97%. So what the ASCO guideline, ASCO said that PNDAC study further provide platform for MammaPrint use. And according to them, it can be used for hormonal positive, HER2 negative disease with either lymph node positive or negative. What is EndoPredict? EndoPredict is again a gene test. It's mainly for patients who are having as I mentioned, early stage breast cancer. I'm talking about early stage breast cancer, hormonal positive, HER2 negative disease. It helps define the risk of breast cancer recurrence, the benefit of chemotherapy, and the benefit of extending hormonal therapy behind 5 years. It's a comprehensive test. They look at 15 genes plus some, so the final score is given after the score from the 12 gene plus some information about the tumor size and nodal status. So the addition of the percentage of risk of recurrence at 10 years, the absolute chemotherapy benefit based on current treatment regimen. Yeah, it gives you a hint about the incidence of recurrence at 5 years. And the good thing about that is not only 10 years, sorry, it gives you evidence of disease recurrence or a hint about disease recurrence, even beyond or behind 10 years, from 5 to 15 years. So it classifies patients into two arms, low risk and high risk. So when the test was used, they found that patients who are having low risk at 10 years or behind 10 years, 95% of patients were alive and disease-free. If you compared it to the other profiles, like or other gene tests, like Oncotype DX, this was the test that saved, like we can say, saved large number of patients from receiving chemotherapy. So it identified around 6% of the patients who are having early disease breast cancer and said that those patients can go without receiving adjuvant chemotherapy.
Dr. Nafisa, 1 minute for the time
Sure.
left.
Prosigna test, this is like 50 gene test, also classifying patient into high risk and low risk patient. It's the recurrence score given from studying 50 gene plus information about the tumor regarding tumor size and proliferation. It classifies patient into 3 categories: low risk, intermediate risk, and high risk. The intermediate, the low risk, the incidence of recurrence at 10 years is less than 10%, intermediate 10 to 20, and high risk more than 20%. Initially, it was validated for postmenopausal lady, but now it can be used for both clinically positive, lymph node positive or negative. It was validated in a very important trial, ABCG trial and ATAC trial, where they involved more than 2,000 patients. So what about the BCI? The BCI is a combination of genomic tests. It is given at the ratio. It's like 3 genomic tests. The first 2 given at the ratio, it's called HI ratio, plus the molecular grade index. The BCI score 5 to 10, patient considered as having high risk of disease recurrence. So those patients, the BCI breast cancer index is mainly concerned for extending the adjuvant endocrine therapy. And this was validated in a very important 3 major trials, MA17 and IGL trial. The patient who are having low risk, they can given hormonal therapy for 5 years only. 5 to 10, we need to extend their treatment to 10 years. NCCN guidelines were initially skeptical about using this test in patients who are having lymph node positive disease, but in the secondary analysis of the 3 trials, they found that the BCI score in the patient who are having node positive disease, still there was improvement in the DFS with adjuvant hormonal therapy only. So now the recommendation of And NCCN is to use BCI test for both hormonal positive and hormonal negative disease. Thank you.
Okay, well, thank you very much for the 4 speakers. I think it was a very rich session. We've been told that we have to reduce the session of discussion to 10 minutes. So we'll open the floor for any questions. You have any question, Dr. Abdullah?
I'll ask Dr. Shehri about his talk. We know that, first of all, thank you very much. It was a very comprehensive talk. We know that after the standard treatment, which is anti-CDK4 and 6 inhibitors now in metastatic breast cancer hormone positive, we have a lot of options, but we are talking about PI3K inhibitor. Now it's coming, and the test for this mutation is being there, like most of the major cancer center, I think they have this test available by way or another. So how do you think about this medication? First of all, do you have any experience in your center with this medication? Second things, what do you think about the toxicity, hyperglycemia, and diarrhea? So how do you think the future for this medication, alpelisib?
Thank you, Dr. Abdullah. I think the data about use of alpelisib in the second-line setting after CDK4/6 inhibition now is more convincing. Once we have the test available, if you have a mutant patient, you can start. I don't have experience myself using this medication, to be honest with you. I'm really thrilled to start using it. With regard to the toxicities, as we mentioned, hyperglycemia is a problem, skin rash, mucositis. For those who have been using everolimus before, probably they are like expert on managing these toxicities. So before starting treatment, you have to control the blood sugar. You have to monitor blood sugar closely, at least in the first 2 months, every 2 weeks, to make sure that your patient blood sugar is under control and to start proper treatment if he was not or she was not on this treatment before. And with regard to the skin rash, it has been actually recommended to start prophylactic antihistamine even before starting this medication, even before the patient start to have any kind of rash to reduce the toxicities. For me, I think the toxicity profile are manageable. And if we monitor our patients like closely, I think we can go through these problems easily.
Yes, I agree with you, Dr. Ahmed. I think getting more experience with this medication is very important. Just in SOLAR-1 clinical trial, phase 3 clinical trial, if you look at the discontinuation of the treatment is more than in BYLieve study. I think the people, they are getting more experience with the medication. I think this is what will happen. So it seems to be a promising medication.
Totally agree with you.
Yeah. So is there any question?
Yeah, any questions from the audience? If not, then I might ask Dr. Nasser a question. Obviously, a very good presentation, Dr. Nasser.
Thank you. We cannot hear anyway.
Sorry, Dr. Nasser?
Yes, but please make the microphone very close because I cannot hear you well, Dr. Gamal.
Yeah.
Yes, please.
Yes, I said I really liked your presentation, and in particular the slide where you presented, I think, 10 studies of extended adjuvant therapy.
Yes, because I used to give this presentation for extended endocrine therapy, you know, as early as 2016 or so. And since that time, we are focusing on the extended endocrine therapy, and I have a good discussion even when the MI-17R has been presented during the plenary of ASCO. I have been involved even in the discussion for this trial. So I'm very, focusing in depth for the extended endocrine therapy trials, more than 10, as you know, and some of them using different schedules, but the main question was AI after an AI. It was usually a problem as regards the compliance issues and patient extending with an AI. And I consider in myself, the AI is a tough drug, and somewhat the compliance issues may be down to 40% after 10 years. So it needs to care for the bone mineral health and to give, as you know, prophylactically or Q6 months something, whether Zometa or Prolia or something, and to keep on vitamin D and calcium all through the treatment period. Yes.
Yeah, absolutely. It's an important issue also. But I would like to ask you about the issue of less than 10 years of extended adjuvant treatment. We know at least 2 or 3 studies have looked at 7 or 8 years, including a study which was presented in ESMO a few days ago. And we have another study in the past that looked at 10 versus 7 years. And I think there is some sort of consensus and understanding that maybe 7 to 8 years might be as good as 10 years. Do you want to just highlight on this issue, Dr. Nasser?
Yes, but 10 years or 7 to 8 years, depending on what you give first. If you give first tamoxifen for 5 years and then 5 years of an AI would be very sufficient. 10 years. But if you started by an AI from the start, then I think, in my opinion, 7 or 8 years are quite enough, instead of just going beyond that for 10 years of an AI. Yes, I agree, Dr. Gamal.
Thank you. I think we might have 2 minutes for any other questions. Do you agree, Dr. Abdullah? Oh, there's an online question. Okay, well, I have bad vision and steam on my glasses. So one of the audience online says he would like to ask Dr. Al-Shahri about the optimal hormonal treatment for a 20 years, for 80 years early breast cancer patient, I assume, and plan for no surgical treatment because of high risk, and the patient, or maybe the patient, refused surgery.
Yes. Thank you, Dr. Najla, for this easy question. For 80 years old, it might be a little bit challenge. Actually, we go, if the patient was refusing, surgery, for whatever reason, because she's high risk or she's not operable patient, then we might go for all the endocrine therapy options that we use in the palliative setting or advanced breast cancer. So we can go, for example, according to the toxicity, we might choose to go for single agent endocrine therapy. If she can tolerate, to go for endocrine therapy plus CDK4/6 inhibition in the first line. And in the second line, once again, we can switch to a single agent endocrine therapy or endocrine therapy plus one of these biological. If PIK3CA mutant, we can go with alpelisib. If not, we can go with everolimus. But however, given that she's 80 years old, I'm pretty sure that she might have a lot of comorbidities. We have to weigh the benefit and risks of using these biological treatments in addition to endocrine therapy. In my own clinical practice, many of those old patients, fragile, I might go with sequential single agent endocrine therapy. I don't know if my colleagues, other colleagues, Dr. Nasser, Dr. Nafisa might have a different opinion about this answer.
Dr. Gamal? Dr. Gamal, may I comment?
Yeah, carry on. Yes, carry on, doctor, yeah.
I need just to mention about the use of alpelisib in patients with big BI3K mutation, and in our population we have close to 20% are diabetics, and we have obesity, which is prevalent in at least in Egypt. It's in 40%. So they are potentially pre-diabetics. And I wish to stress on the use of the antihistaminic, as Dr. Shahri said, and in addition, the metformin. And we need to classify our patients at least into 3 groups: those with hemoglobin 1C below 5.7, and those between 5.7 and 6.5, and those who are over that. And if they are normal, having hemoglobin 1C below the upper limit of normal, just take care. If she is obese or so, you can even start with in addition to the antihistaminic, by the metformin. And those who are partly diabetic between 5.7 and 6.5, you should take care very much of the use of alpelisib in such patients, because we have sometimes the glucose may go up to even 400 or even above 500. And for those patients with above 6.5 or 7, it's better to avoid the alpelisib in such a group because of the potential for the DKA. Dr. Shahri, how do you comment on that?
Having some warning that we have to finish the session. Unfortunately, all good things have to come to an end. I would like to thank Dr. Abdullah, Dr. Ahmed Shahri, Dr. Nafis Abdel Hafid, Dr. Sharif Sammani, and of course, our lovely colleague from Cairo, Dr. Nasser Lahloubi. And we'll see you, inshallah, sometime in person in the near future. Thank you.
Thank you all.
Thank you. Thank you. Thank you very much.
Thank you all.
Yes, we have. Yeah, thank you. So we are coming for the Satellite Symposium. Thank you for Novartis for sponsoring this symposium. So will be talking about the role of PIK3CA inhibitors in advanced hormonal positive breast cancer. Our speaker is Dr. Abul Khair Al-Jahami. Dr. Abul Khair, he is a consultant medical oncologist at King Abdullah Medical City. So please, Dr. Abul Khair.
Bismillah ar-Rahman ar-Rahim. Assalamu alaikum wa rahmatullah. It is my pleasure to be here, and thanks Dr. Abdullah for the nice introduction, and thanks for organizing committee, Dr. Sharif and Dr. Hafid, and again thanks for Novartis for inviting me for this important topic. So I'll talk about BI3K mutation, and Dr. Ahmed Shahri was touched this issue. Before starting, as introduction, you know, BI3K is standing phosphatidyl inositol 3 kinase. But I will give you a hint. I get very difficult to remember it. So to me, BI3K is standing for Principal Investigator number 3 in the kingdom. Just remember it as such. Anyhow, as a background, we'll talk about standard care of ER positive, HER2 negative breast cancer. And as you know, breast cancer is the leading cause of cancer-related death for women. And around 2/3 of metastatic breast cancer will be ER positive, HER2 negative, with median duration of survival of this patient is approximately 42 months. In the first line treatment, as you know, in the advanced setting, we will give in addition to hormonal treatment, CD4/6 inhibitors, but only 39% of those patients will remain progression-free at 2 years and 2 months after initiation this therapy. So we need something else for them, because all of them will be progressed after that. From this cartoon, you know, 30% of ER positive metastatic breast cancer will have de novo resistant to endocrine therapy, with most developing acquired resistant. And my talk will be basically on BI3K inhibitors, which is alpelisib. So the acquired and de novo resistant is well known. And you know, BI3K pathway is very important for production of what is called BIB, which will activate AKT, and then there will be hyperactivation of this one, will lead to a malignant transformation, cancer progression, and also it is involved in the physiology of glucose, and this is important in the side effects. So BI3K in advanced breast cancer, it is a key regulating process like proliferation, metabolism, and survival. And if we talk about targeted therapy, we have from BI3K, we have many isoforms, but the most important for us is the alpha isoform, which is alpelisib, the selective inhibitors of alpha. Previously, we have ban BI3K inhibitors, but actually, like bupralisib, and it has been associated with very huge side effects. So there is a strong rationale for targeting the alpha isoform of BI3K pathway, and this is selectively inhibited by alpelisib. And this, as I said, this pathway is the most frequent mutated pathway in the breast cancer. Up to maybe 40% of ER positive, HER2 negative will be positive mutation for BI3K. And we have alteration and 3 key genes. Will not touch them. We'll concentrate only on BI3K inhibitors. The presence of this mutation in breast cancer has been found to be independently associated with negative prognosis. There is lower overall survival, lower BFS as well. And there is bold analysis of more than 10,000. It shows that this mutation were significantly associated with better invasive disease-free survival, distant-free survival, and overall survivor in early breast cancer. That is to say, this pathway in the early setting is rather better, but in the advanced setting, in the metastatic, is much worse. And overall mutation appears to be negative prognostic, as I said, in the advanced setting, but not in the early setting. So how this activation will promote the endocrine resistant? 75% of breast cancer, as we said, express endocrine therapy, AR positive, and endocrine therapy remain the main stay of treatment, and we'll add plus minus in the if there is mutation. But despite the effectiveness of endocrine therapy, many tumors exhibit de novo or acquired resistance to therapy. So we should add something else, like alpelisib in the adjuvant second-line setting after progression on CD4/6 inhibitors. And so activation of BI3K is predictive of poor disease outcome following adjuvant endocrine therapy, as you saw the separation of the curves in this graph. And activation of this pathway is also associated with CD4/6 inhibitor resistance, which is the mainstay as the first line. So we should always think about the mutation of this pathway when we are treating ER positive, HER2 negative breast cancer. To summarize, the BIK3 gene is the code gene that encodes the alpha isoform of BI3K protein. Mutation occurring about 40%. Hyperactivation of this pathway lead to endocrine resistance in advanced setting. The presence of this mutation is negative impact and negative prognostic biomarker in AR positive, HER2 negative, and the international guidelines, as they said previously in the previous talk, recommend at the time of the diagnosis of metastatic or recurrent disease to check for this BI3K mutation. And the way how to assess is multiple. Could be first start, as Dr. Ahmed Shihri said, by simple only blood test, and then we might check it if negative in the tumor itself. And also we know that we should test this mutation in the metastatic setting, because all patients will progress at the end. And now I'll talk about the most important thing, which is the SOLAR trial, which is, phase 3 trial combining alpelisib, which is BI3K alpha isoform inhibitor, in addition to fulvestrant for ER positive, HER2 negative advanced breast cancer after failing of CD4/6 inhibitor. And this is phase 3 randomized international trial. And we know from this, they check it, of course, in early phase, which is phase 1. It was so effective. And that's why there is strong rationale for doing a phase 3 to evaluate the efficacy of alpelisib in addition to fulvestrant in BI3K mutated advanced breast cancer. So this is the SOLAR trial. There is 2 cohorts, as Dr. Shehri said. All of them ER positive, HER2 negative. Most of them receive CD4/6. There is some patient received CD4/6. I'll explain this. So they randomized in 2 cohorts, one with BI3K mutation and one without BI3K mutation. For those cohort A, they will give alpelisib in addition to fulvestrant versus fulvestrant with placebo alone. And the same thing for a patient who had non-mutant cohort. And the primary endpoint was BFS in BI3K mutated cohort. And this is the patient characteristics. It is comparable in between 2 groups. And in all things, including site of the metastasis, what they received in the first line setting. But observe here, prior CD4/6 inhibitors only 5 or to 6% alone. And this is why that's why they did another trial, which is BILIF. I'll touch it. It was phase 2. Now, this is the result, the BFS, very significant, favoring those who had received the alpelisib in addition to fulvestrant, and with significant confidence interval and significant p-value. This is the centrally assessed also BFS, very significant. And with regard to the non-mutant, almost no separation in the curves. So that is to say, you should give alpelisib only on mutant cohort to be effective. This is the subgroup analysis. Most of the patients, almost all patients, favoring addition of alpelisib to fulvestrant, regardless the site of mets, regardless the using yes or no CD4/6, and but it should be mutated BI3K. With regard to the side effects, this is very important to us as a clinician. As I said, and I'll touch it in the management of side effects of this medication, this drug. The most common is hyperglycemia, and the rash. There is others, diarrhea and pneumonitis, but you see, hyperglycemia, like 2/3 all grades, and grade 3, 1/3. And also there is grade 4. So you should make sure the patient is having controlled diabetes. And myself, and as they advise, type 1 diabetes, I don't think will give anyhow. But those who had type 2 diabetes, you might think there is guidelines. It is not the time to discuss all of it. But the most important is blood sugar and hemoglobin A1C. The same thing for the rash, especially those who had atopic or they have dermatitis. You should think about it because it will increase the incidence of rashes and toxicity. So you can conclude alpelisib is the first BI3K inhibitor which show clinically meaningful, statistically significant result in breast cancer, ER positive, HER2 negative, and significant BFS. Treatment benefit was consistent all through in the subgroups. And you should be aware about hyperglycemia and rash with manageable toxicity if you select your patient. So alpelisib and fulvestrant is potential new treatment options for patients with mutation in BI3K, ER positive, HER2 negative advanced breast who progressed on prior endocrine therapy plus minus CD4/6. What about the overall survival? In SOLAR-1, in this trial, this is the trial, and you can say probably there is some separation, but numerically also there is the median overall survival prolonged by almost 8 months, favoring the alpelisib. However, statistically was not significant. It might come with time, we don't know, but this is but in the subgroup analysis, those who had liver and lung mets actually benefited more than those who had no visceral metastasis. But this is subgroup anyhow. And this is, I'll not touch it. Those who had BI3K mutation from by DNA circulating tumor cells, also a bit benefiting actually from alpelisib. But as Dr. Ahmed, if CT DNA was negative, which occur about 40%, you need to check in the tumor itself for the mutation. There is also time to first chemotherapy was prolonged in using alpelisib in comparison with the placebo. So what we can say, overall survival is not yet statistically significant, although numerically is better, especially for those with liver and lung metastasis. Now, the difficult, you know, the more options we have, is the more difficult to answer this nowadays in all solid and non-solid. So what about progression after CD4/6 inhibitors? Is there any way to, is there any trial to help us? Actually, this is BILIF's study. It is by Rob Hojo from San Francisco, California, US. This is phase 2. She did this one. You know, as we said, almost all patients will develop resistant at the end and they will progress. So we should think about another options for those patients. And this trial, they have 3 cohorts. Of course, ER positive, HER2 negative. The first cohort is those patients who received CD4/6 with aromatase inhibitors and progressed. So they will give alpelisib with fulvestrant. On the other way, those who had previously fulvestrant with CD4/6 inhibitors, they will give him alpelisib with AIs. And the third group is those patients who progressed either after aromatase inhibitors or chemotherapy or hormonal alone. So actually they bought 3 cohorts to make it simple. Actually, it is very nice design. So anything to check. Either receive fulvestrant or AIs or even chemotherapy. And the primary endpoint is to check a proportion of patients who was alive without disease progression in 6 months' time. And I'll not go through much details. There are around 127 patients. And let us, this is the patient characteristics. And this is the efficacy, the primary endpoint, actually the BFS after 6 months. The primary endpoint, those patients who were alive without disease progression is around 50%, half of them. So it is the primary endpoint for the prior CD4/6 with AIs was met. So it is, yes, I know it is phase 2, and I think they will run phase 3 as well. So you can use in simple way, you can use the alpelisib with fulvestrant or even with AIs according to your patient. This is the response rate. It is very effective. This is the phase 2 trial BILIF, and this is the response rate in solar trial. So it is very significant, as you see from the curves. The safety profile is the same as solar. I will not go through it. However, you know now, so we have hyperglycemia and we have the rash. From this trial, it's better to give antihistamine preemptive from the beginning. So you'll decrease the rash, you know. Have a look for this curve, this diagram. Those who had grade 1 to 2, almost 1/4, and grade 3 to 4 is almost 21% for those who did not receive antihistamine. For those who had no rash from the beginning, you know, and if you give antihistamine, the grade 1, 2 will decrease to 20%, and grade 3 and 4 will decrease to 10%. So it is advised to give antihistamine from day 1 as preemptive. The side effects leading to discontinuation, basically hyperglycemia and rash. So the conclusion from this trial, this analysis BILIF demonstrates significant meaningful efficacy of alpelisib with fulvestrant in BI3K mutated, AR positive, HER2 negative, advanced breast cancer, post progression on CD4/6 and aromatase inhibitor. And this trial supports the use of alpelisib and fulvestrant for AR positive, HER2, both CD4/6 inhibitor. And this is actually as a confirmation for the solar trial. So this is phase 2 and confirming what has been, what we know before. there is one only small difference in those who received fulfosterant, then you give AIs. Surprisingly, they antihistamine or not. This might be by luck, I don't know, but this is what has been found in this one. But in general, if you are going to give alpelisib, control blood sugar and control and give antihistamine as well. What about the side effects management? Now hyperglycemia, as we said, BI3K involved in the metabolism of glucose. And if this pathway is inhibited by alpelisib, you will have problem in glucose uptake, glucose use and storage, and gluconeogenesis, glycogenolysis. So at the end, and insulin resistant, at the end, what you will have? You will have increase in blood sugar. So as we said, type 1 will not give at all. In type 2, you should check the glucose, especially the hemoglobin A1C. And this is the data of Solar regarding treatment of hyperglycemia. And this is, so you should involve, if you say you have a patient who had controlled blood sugar and during your treatment, blood sugar is increased, you will give metformin and others and consult the endocrine therapy to help you. And these are the guidelines. I will not go through all of them. If you need the slide, I will put them. These are the guidelines, what to do by hyperglycemia. And the most important, to tell your patient to check it like weekly, and then to check fasting blood sugar and to check the hemoglobin A1C. And if there is any increase in either, you should refer to endocrine therapy, to endocrinologist to help you. And there is some modification in the dose according the standard dose is 300 milligram. But anyhow, you might need to decrease it if you have uncontrolled blood sugar. And these are the grades of hyperglycemia. And this is how the guidelines for management of hyperglycemia and patient education. The last thing is the rash. The rash, which is, as said, is important, and it is common, and it's better. This is the Solar data, and how much the overall up to grade 3 and 4 up to one fifth of them, 20%. So it is also important, and this is the grades of rashes and the management of skin toxicity. You will give antihistamine as starting of the treatment, and make sure the patient is not having any dermatitis or atopy. And this is the rash management. So this is the final one. This is the conclusion from Solar again. So alpelisib is the first BI3K inhibitor to show a clinically meaningful, statistically significant result in breast cancer. BFS was significantly prolonged with the addition of alpelisib to fulfosterant in second-line setting. The treatment benefit was across all subgroups. And the two most common side effects is the hyperglycemia and the rashes, which is manageable if you choose and select your patient probably. So what we can say, alpelisib and fulfosterant is potential new treatment options for patients with BI3K mutated, AR positive, HER2 negative advanced breast cancer who progressed on prior endocrine therapy, either fulfosterant or AIs. You can use alternatively in both ways, or after the CD46 inhibitor. Thank you very much.
Thank you, Dr. Abul Khair. It was a very comprehensive talk. So I think for this talk, just in briefly, the anti-BA3K inhibitors is coming. Very effective. You can see the median progression-free survival between the standard treatment and the use of this drug is very significant. Talking about response rate, majority of the patient, they have stable disease or partial response, so it's a very effective medication. Looking to the toxicity, it looks like complex, so I think all physicians, they should be aware when they are using this medication. They should monitor and they look very carefully to the toxicity of this medication. As you said, it's not mandatory to use the antihistamine in all cases, but definitely if you think using of antihistamine for rash, and also use the protocol that you put here for control of hyperglycemia. It's very important. So this is the key messages, and it's coming. And after doing this medication and experience with it, most of the people, they will use to this toxicity and they will adjust it, and it will be very manageable toxicity. So any question from the audience? Yes, Dr. Arib.
Assalamu alaikum. Thank you for the excellent presentation. The best one was the principal investigator 3 of the kingdom. This was the best statement. But if this is non-mutant and you have CDK4/6 progression, what is your option?
This is the difficult how to sequence your treatment. But basically, what we say, hormonal treatment is the first. If the patient use CD4/6 inhibitors, you can use them because the side effects is less. In non-mutant, you have the options before shifting to chemotherapy to give mTOR inhibitors, which is everolimus, plus minus hormonal treatment, either exemestane, depend what your patient. So basically, you can say first give CD4/6 with hormonal. If non-mutant PI3K, you can use mTOR inhibitors with hormonal.
Any more question, Dr. Sharif?
Thank you, Dr. Abdallah. Just 2 quick comments, Dr. Abul Khair. First comment, I do concur with what have been said with Dr. Abdallah, that I would like to add that patient selection, especially in the first few patients you are treating with the new medication, is very essential. So we have a medication that's effective but have some toxicity. So if with the first 1 or 2 patients, please try to select the perfect patient. Patient well educated, good reporter, can follow your instruction. Better to be non-diabetic to avoid as much as we can hyperglycemia or complication related to hyperglycemia. And then after you have been well trained to how to manage the toxicity, it will be easier in the later patient. And we have the story of everolimus. Myself, after selecting my patients, nowadays I have no problem with managing the toxicity of everolimus. The second comment, the story of having alpelisib after CDK4/6 inhibitor. I will add the data coming from real-world data from US. They brought the patient who have been treated by CDK4/6 inhibitor, and then some of them have received alpelisib plus fulvestrant, and other received other medication like single hormonal therapy or chemotherapy and so. And they did matched pairwise analysis to adjust for baseline prognostic factor, and they found that the outcome with alpelisib plus hormonal therapy is much better. So we have accumulating evidence that is assuring that after CDK4/6 inhibitor, alpelisib fulvestrant is a very good option. Thank you.
Yes, I agree 100%. So by this, I think we conclude. Thank you very much, Dr. Abul Khair, and thank you for Novartis for sponsoring this activity. Thank you. I will see you in the afternoon, inshallah.
Thank you very much. We'll start, I think, at 2.
We'll start at 2 p.m. Yeah.
2. Thank you very much.
Thank you.
السلام عليكم.
وعليكم السلام. أهلا دكتور.
أهلا بحضرتك، أهلا وسهلا.
ما زلنا في البريك بس إن شاء الله هنبدأ بعد إن شاء الله 7 دقايق إن شاء الله نبدأ.
إن شاء الله إن شاء الله. تمام. دكتور أبو الخير موجود ولا في البريك؟
موجود.
موجود. أنا كنت عاوز أرتب معاه قبل البداية إن شاء الله.
السلام عليكم دكتور محمد، كيف حالك؟
عليكم السلام. أهلا أهلا دكتور أبو الخير، إزاي حضرتك؟ الحمد لله.
شرفت والله.
أنا اتشرفت والله بمشاركة حضرتك دكتور أبو الخير.
كنا نتمنى أن يكون your presence، لكن إن شاء الله coming soon.
إن شاء الله إن شاء الله إن شاء الله. أنا يمكن بعت لحضرتك رسالة لأن الصلاة طولت عندنا في مصر شوية، إحنا الصلاة عندنا لسه خلصانة حالا، بس
طيب.
الحمد لله أنا لحقت أوصل قبل ما نبدأ، كنت خايف أوصل
تمام.
أنا السيشن. تمام. حضرتك مرتب، حضرتك هتقدم مين وأنا هقدم مين وكده؟
يا سو ممكن أنا أبدأ بس طيب، وبعدين أنت تقدم الدكتور أطلال.
تمام.
هم 4 سبيكر.
الدكتور أطلال كونسلتنت، هو التايتل مكتوب كونسلتنت بس مش واضح في الاجنده. كونسلتنت اوف ميديكال اونكولوجي ولا كونسلتنت ايه؟
مين تتكلم عن مين؟
الدكتور أطلال اللي انا هقدمه
معايا الحين تسمعك ما شاء الله. يس دكتور. she is a consultant medical oncologist King Abdulaziz University and associate professor. she is with ومعك متعب الفهيدي، هو SOS سعودي اونكولوجي سوسايتي بريزيدنت، ومعك دكتور احمد سعد الدين كلينيكال اند ميديكال اونكولوجيست.
اوكي. دكتور أطلال.
ايوه انا اي كان ستارت باي دكتور اطلال، وبعدين تقدم متعب مكتوب عنده صح؟
معانا دكتور أطلال اهو. تمام.
ايوه
تمام. انا اقدم دكتور متعب الفويدي.
طيب
اوكي تمام.
خلاص خير. so when we can start. والله مفترض.
بسم الله الرحمن الرحيم والصلاة والسلام. بسم الله الرحمن الرحيم والصلاة والسلام على أشرف الأنبياء والمرسلين سيدنا محمد وعلى آله وصحبه أجمعين. Dear colleague, it's my pleasure to welcome you all in our annual conference of King Abdullah Medical City. This conference will cover several important hot topics related to the management of different cancer subtypes in our region, including recent advances in medical oncology, radiation oncology, pathology, and palliative care. We hope this meeting will bring us all up to date with the knowledge in the field of oncology, interesting scientific program that focus in debate in cancer management. We have distinguished national, regional, and international speakers who will join us on this conference and sharing their experience with us. I hope this meeting will be an excellent educational experience, and I wish you would enjoy the scientific sessions. We are sure that your active participation will add to the value of this important oncology conference. Finally, I would like to express my deepest thanks to the organizing and scientific committee. Thank you and welcome you all in our meeting.
بسم الله الرحمن الرحيم الحمد لله والصلاة والسلام على سيدنا محمد وعلى آله وصحبه أجمعين. Thank you very much for the organizing committee, and it is my pleasure to chair this session about breast cancer, triple negative and HER2 positive session. My name is Abu Khair Al-Jahmi. I'm medical oncologist in King Abdullah Medical City, Mecca. And it is my honor to chair this one with Prof. Dr. Muhammad Awad, our colleague from Egypt, Mansoura University, and he's a consultant medical oncologist and BMT transplant as well. So we have this session, and we have a group of eminent speakers. I think most of you know them, and we'll start the first speech by Dr. Atlal Abu Sanad. She is our colleague, and she's a known medical oncologist in Jeddah. She is associate professor in King Abdulaziz University Hospital, and she will give us a brief account about treatment de-escalation in early HER2 positive breast cancer. So please, the floor is yours, Dr. Atlal.
All right. Thank you, Abu Khair, for this introduction, and thank you for the organizing committee, Dr. Sharif, Prof. Hafiz. It's my pleasure to be with you as always. Actually, I think you like me very much. You're giving me challenging topics every time. I'm trying my best to squeeze everything about de-escalating anti-HER therapy in early breast cancer. So we're going to look at different strategies to do this. One strategy is through substituting toxic regimen with less toxic one, abbreviated course of anti-HER2 therapy, and omission of chemotherapy, and finally the use of other optimized anti-HER2 agents such as antibody drug conjugates and newer TKIs. So let's start with the first strategy, which is using less toxic chemotherapy backbone. Reviewing the past pivotal trial that brought the anthracycline-free chemotherapy into the clinical practice, the BCIRG-006, we noticed that it was a three-arm trial, including anthracycline with trastuzumab and Herceptin, trastuzumab and taxane, plus taxotere, carboplatin, and trastuzumab versus plain chemotherapy regimen without trastuzumab. There was no significant difference between the true trastuzumab containing arms. However, this trial was essentially comparing non-trastuzumab regimen to a trastuzumab regimen. So there was no head-to-head comparison between the AC or the anthracycline containing regimen and the carboplatin. However, in an exploratory analysis, the overall and progression-free survival of both trastuzumab-containing regimen were comparable. Also, the cardiac toxicity was much less frequent in patients who received the carboplatin base. From there, and to the present time of the contemporary trial, we have Trafenia, which was neoadjuvant, examining the pathological complete response for patients who received taxane, carboplatin, plus trastuzumab and pertuzumab in comparison to the ones treated with anthracycline-containing regimen and received trastuzumab, pertuzumab, as well as taxane. It showed a higher a complete pathological response, 64% versus 55%, among the ones who received non-anthracycline regimen. Though it was numerically higher, it did not translate into statistical significance. What about nowadays? There is a trial that is called a TRAIN study, which examined the neoadjuvant chemotherapy with or without anthracycline in the presence of dual HER2 blockade for HER2-positive breast cancer. It was multi-center, open-label, randomized, and they were able to recruit 438 patients with the stage 2 and 3 HER2-positive breast cancer. They gave one arm anthracycline-based chemotherapy, FIC, for 3 cycles, followed by 6 cycles of carboplatin and paclitaxel. And the other arm received 9 cycles of carboplatin plus paclitaxel every 3 weeks. Both arms received trastuzumab and pertuzumab. As you see here on the side, the pathologic complete response did not differ. 3-year event-free survival was almost the same, and overall survival, though it is not mature yet, was similar. This was evident through all subgroups, and it was not favoring the anthracycline in any subgroup. Interestingly, as you expect, the febrile neutropenia was less with the carboplatin-based regimen, as well as cardiac toxicity. Going into another approach or strategy, which is giving shorter duration of anti-HER2 therapy. So this has been studied in multiple trials. We have the 2 bottoms trial that examined ultra-short course of trastuzumab only for 9 weeks versus 1 year of trastuzumab. Yet none showed non-inferiority, which was the outcome. So still, 1 year of trastuzumab is better than 9 weeks of trastuzumab. How about the top 3 trials? The only one that showed result was the Persfon, which was reported at median follow-up of 5 years and included around 4,000 patients with 500 events. Disease-free survival and overall survival results showed non-inferiority between 6 months and 1 year of adjuvant trastuzumab. But there are selection for the patient who may benefit from this approach. 4-year disease-free survival was 89.8% in 1-year arm and 89.4% in the 6 arms. 4-year overall survival was more or less comparable, as you see here. But who would be a good candidate for 6 months of anti-HER therapy? So you can give it if you have a patient who has ER-positive tumor and small tumor that is not exceeding T2 and they were not treated with neoadjuvant chemotherapy. How about the ones who are not good candidate for this approach? It's going to be the ones with ER-negative HER2-positive breast cancer, the ones who received neoadjuvant, implying that they have locally advanced disease at time of diagnosis, and if patient received only taxane. In this case, 1 year of trastuzumab is better than 6 years of trastuzumab. Let's look at another strategy, which is the omission of chemotherapy. Can we do this? I tried to summarize all the trials that looked at combining trastuzumab and pertuzumab or giving the trastuzumab alone versus chemotherapy. So initially we have Neosphere, which included patient patients were treated with pertuzumab and trastuzumab for 12 weeks. So the response rate was 27 in HER2 negative breast cancer, in hormone receptor negative, and 6% in hormone receptor positive. As we expect, higher response rate with the ones who are not hormone receptor positive. Another trial, which is TBCRC006, that gave the patient trastuzumab and lapatinib in neoadjuvant setting. And then surgery was contemplated to assess the pathologic response rate after 12 weeks of the combined anti-HER therapy. They also added endocrine therapy in patients who were hormone receptor positive. So the response rate in the hormone receptor negative were 28% and 18% in the hormone receptor positive. What about Bamella? Again, same approach, utilizing trastuzumab and lapatinib, but for a longer duration, 18 weeks instead of 12 weeks. And the response rate was 43% in the hormone receptor, there is a mistake, it should be hormone receptor negative, and 18% in hormone receptor positive. Looking into a more recent trial, we have ADAPT trial, which is the adjuvant dynamic marker adjusted personalized therapy trial. It's a multi-arms trial looking at all subtypes of breast cancer, but we are interested only in HER2 positive breast cancer. And what is interesting about it is the fact that they looked into the HER2 hormone receptor positive separately than the ones who are HER2 positive, hormone receptor negative. So at first, we're gonna review the hormone receptor positive. Patients were randomized to receive one of the three treatments, TDM alone, TDM in combination with endocrine therapy, and trastuzumab with endocrine therapy for 4 cycles. And then they underwent surgery, followed by assessment of the pathological complete response. On the side, you see that the TDM response rate was 41%. TDM plus endocrine therapy was 41.5%. So basically, the addition of endocrine therapy did not much influence the PCR. However, trastuzumab with endocrine therapy was very low at 15.1%. What about the other group of HER2 positive breast cancer who are hormone receptor negative? They included 134 patients with clinically operable breast cancer, ranging from T1 to T4, as well as N0 to 3. As we mentioned earlier, it's going to be hormone receptor negative. 60% were clinically staged as T2 to 4, and 42% had node positive disease. They were given trastuzumab plus pertuzumab versus paclitaxel plus trastuzumab and pertuzumab for 12 weeks. And then surgery was scheduled after the completion within 3 weeks from the finishing of the treatment course. As you see here, the response rate, depending on the definition, if we're looking at complete, including invasive as in situ, the blue bars, you will see that with the dual blockade, it reached up to 34.4%, but with chemotherapy, which it was paclitaxel, is 90.5%. It's significantly higher. So we conclude from here that follow-up 5 years showed invasive disease-free survival was reported at 98% with the triplet and 87% with the dual HER2 blockade alone, has a ratio 0.32. However, look at the p-value, it's insignificant. Similarly, for the distant disease-free survival was more or less comparable at 98% and 92%, but again, p-value is not significant. Though this trial showed a trend towards similarity only in the patient who achieved complete pathological response from receiving dual anti-HER therapy in comparison to chemotherapy plus dual anti-HER2 therapy, we cannot draw a solid conclusion because it's still investigational and exploratory. And to conclude, ADAPT trial we look at both subsets, the ones who had hormone receptor positive and the ones who had hormone receptor negative. So initially, the ones who had HER2 positive, hormone receptor negative, we can see the showed that the ones with low HER2 expression, basal-like subtype by PAM50 assay, and lack of early response or were strongly associated with worse distant disease-free survival and invasive disease-free survival. How about the other population who were HER2 positive and hormone receptor positive as well? Remember, again, those received TDM plus endocrine therapy, TDM alone, and trastuzumab plus endocrine therapy alone. As we noticed before, adding endocrine therapy to TDM did not add to the pathological complete response. Biomarker analysis focused mainly on the drop of Ki-67, and they found that when the drop is higher or equal to 30%, then it is predictive of pathological complete response. Yet also, they faced difficulty assessing Ki-67 because 43% of the biopsies showed low cellularity because of the responses to neoadjuvant treatment. To conclude, although chemotherapy-free regimens in HER2 positive early breast cancer seems promising, they are still investigational, and patient selection with optimal biomarker testing is the key. What about the use of optimized anti-HER2 agents? Antibody drug conjugate against HER2, specifically TDM1, has been studied as single agent as well as in combination in both adjuvant and neoadjuvant setting early breast cancer. Yet we don't have long-term survival data. But if we look at summary of the trials that examine TDM1 in neoadjuvant setting, we have I-SPY 2 and compared TDM1 versus trastuzumab with taxane and pertuzumab, followed by anthracycline. The pathological complete response were higher among the patients who received TDM1. Another trial, same design, examined neoadjuvant TDM versus trastuzumab, pertuzumab with taxane, predicts HER2 trial. And again, it showed comparable result in terms of pathological complete response. Another trial titled Christine examined the TCHP, so carboplatin-based plus trastuzumab and pertuzumab versus TDM with pertuzumab. And you see here the pathological complete response was higher in the patient who received chemotherapy with carboplatin-based. Event-free survival is immature. However, the hazard ratio is 2.6, indicating worse prognosis or worse event-free survival with the ones who received TDM with pertuzumab. De-escalating treatment in HER2 positive breast cancer is ongoing. Some of the approaches or the strategies has been translated into clinical applications, such as chemotherapy regimen with less toxicity. Right now, we are favoring a carboplatin-based chemotherapy or basically anthracycline-free regimens over anthracycline-containing ones, specifically for less cardiac toxicity. Short and equivalent efficacy. Also, shorter course of anti-HER2 therapy can be utilized. However, patient selection is paramount here. We have approaches with promising results. However, it's still investigational, and basically biomarker exploration is needed and optimization, such as using dual anti-HER blockade without adding chemotherapy. It's still investigational and cannot be used in clinical practice. The use of different anti-HER2 therapy agent, specifically antibody-directed antibody drug conjugates, such as TDM in adjuvant and neoadjuvant setting. And to this, I end my presentation. Thank you very much.
Thank you very much, Dr. Atlal, for this comprehensive review, and we'll keep the question to the end. And now it is my pleasure to introduce the second speaker, well-known figure in medical oncology, Dr. Mut'ab Al-Fahidi. He is the Saudi Oncology Society president, and he is associate professor at King Saud University and consultant medical oncologist in National Guard Hospital. And it is our pleasure to introduce him for his talk today about HER2-low breast cancer, challenges and opportunities. It is yours, the floor is yours, Dr. Mut'ab, please. We cannot hear, you are mute, Dr. Mut'ab. We cannot hear you.
السلام عليكم ورحمة الله وبركاته. دكتور أبو الخير.
Yes, we are hearing you now. Yes.
Just I will put it. طيب. بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. So first of all, I would like to thank the organizing and the scientific committee for their kind invitation. Thank you, Dr. Abu Khair, for your kind introduction. So over the next 15 to 20 minutes, I will discuss with you a new breast cancer entity called the HER2-low breast cancer. I will try to discuss with you the challenges and the opportunities. So we are living now in an era of what looks to me an over simplistic view of breast cancer. We have learned how to distinguish within the breast cancer population those tumors that are estrogen receptor positive, those tumors that are triple negative, and those tumors that are HER2 positive by the classic definition. This very simplistic understanding of breast cancer, which is based only on immunohistochemistry marker, the problem actually with this approach is that whenever we see a protein expressed by a tumor, we don't know anything about the actual state of activation of that protein. So the presence of estrogen receptor in a tumor cell is not an evidence of the activity of that receptor. Another approach is to look for pathway activation is by looking at the expression of messenger of many molecules that are activated by different molecules. So actually, it's not surprising to me that we called the estrogen receptor positive, HER2 negative luminal breast cancer by immunohistochemistry may actually end up by using the molecular expression profiling in a different subclass. So there is actually discordance between the immunohistochemistry classification and a molecular classification. But for the time being, we continue to use the immunohistochemistry as a surrogate of the molecular approach. We are using the information derived from the immunohistochemistry, the ER, BR, HER2, and Ki67 to inform the choice of our systemic treatment. So the decision about the adjuvant therapy is based actually in the vast majority of the cases by looking at the immunohistochemical evaluation of this marker, and among these marker is of course the HER2-neu status. So as you know, there has been a long and widening road by the HER2 scoring to the HER2 scoring. So in the past, we had to change the way of scoring HER2 in 2007, then in 2013, and finally in 2018. And this is because of having new knowledge about the HER2 expression, new knowledge about the threshold, and new knowledge about the response to therapy, etc. So it has been imperative for us to review the HER2 scoring in the last 20 years. And in the last ASCO CAP guidelines recommendation in 2018, the HER2 equifocal status was canceled. So a simplified version of HER2 assessment, which is the dichotomous expression, meaning HER2 positive versus HER2 negative. So there is no any longer a double equifocal result, and we ended up with a simple dichotomy evaluation of HER2 status, positive versus negative. More recently, the dichotomous classification of the HER2 status is actually experiencing a paradigm shift. And this is leading to identification of what's so-called HER2 low category. So what is HER2 low breast cancer? It is a breast cancer with some immunohistochemical expression of HER2 protein in the cell membrane, which may be scored as 1+ or 2+ by the immunohistochemistry, but with negative amplification test. So there is no amplification of the gene. How many breast cancer of such type do exist? Actually, 45 to 50% of the patients with breast cancer have low expression of HER2 protein with no gene amplification. And as of today, there is actually no targeted treatment approved for those kind of patients. And usually those patients have a poor outcome. So what is the new challenge? And this is the question asked by Dr. Sharif Sammani. So this is really a new challenge. And I think it's a new challenge to our pathologists. They need now to distinguish between what is a truly negative, IHC 0, versus IHC positive 1. And as you know, the definition of IHC positive 1 is incomplete membrane staining that is faint or barely perceptible in more than 10% of the tumor cells. So this is the official ASCO CAP and FDA definition of score 1 positive. So this definition is not that easy because while this definition is inconsistent with some, is consistent with some of the immunohistochemistry assay for HER2, like for example, the DACO system, it's different in the interpretation guide of other assay, which need only one cancer cell, which is 1+, and there is no need to have more than 10%. So I think we are going to start having problem with the pure definition of 1+ by the immunohistochemistry. The second point, the membrane staining should be linear. And I think now we have to be aware of the possible artifact staining, especially with core biopsy, meaning that we might induce false positive staining. Also in regard to the IHC HER2 scoring, As you know, that the score is a difference between expression of the HER2 in the normal cells as compared to the expression of the HER2 positive in the tumor cells. And as you know, the HER2 is a normal constitute in normal cells, and it has been calculated that each individual normal breast cell may have up to 20,000 molecules of HER2 per cell. And there is also some pattern of staining of HER2 in some invasive breast cancer, especially in the low-grade carcinoma, like, for example, the tubular carcinoma and the cribriform carcinoma, where there is some staining of the tumor cells, but actually the staining is restricted to the basal membrane of the cell, and this has not to be taken into account in scoring. So actually what I think that the new challenge is to identify those tumors that have score 1 positive or 2 positive, but without gene amplification or what's so-called HER2 low expressor. The 0 means the truly negative will remain 0. The 3 positive, truly positive, remain positive. And now we have the gray area of score 1 positive, 2 positive without gene amplification. We have also to remember that there are some exceptions to the rule of the definition of 1 positive or 2 positive, because there are some unexpected pattern of expression of HER2/neu. The pathologists now, they are quite widely recognized, and they are qualifying for HER2 low expression, 1 positive or 2 positive, despite the fact that they do not currently exhibit the immunostaining, which is circumferential in this case, or in more than 10% of the tumor cell. So these exceptional and rare tumor qualify for score 2 positive by the immunohistochemistry, require FISH testing, and if negative, then these tumor will belong to the HER2 low category. So the opportunity, why we are taking care of the HER2 low breast cancer? What is the biological and clinical implication of this low expression of HER2/neu? There has been an interesting trial which was run by the NSABP, B47 trial, where patients with tumors with HER2 low invasive breast cancer were randomized to receive chemotherapy with or without trastuzumab. And as you know, there was no evidence of any benefit of trastuzumab for those patients with HER2 low breast cancer. But trastuzumab is not the only HER2 targeting agent. And actually, there are a new agent that target HER2 with a different mechanism of action. And many of these agents are the new antibody drug conjugate. And this is an example of the antibody drug conjugate, the trastuzumab deruxtecan, that actually was proven to be effective in phase 1 study in tumors with low expression of HER2 in metastatic breast cancer setting. So the HER2 low breast cancer is a new entity that may open, if this will be confirmed by subsequent trial, it may open a new opportunities for those patients. We need to remember if these tumors are estrogen receptor negative and BR negative, This HER2-low breast cancer will belong to the triple-negative breast cancer category. So we are actually extracting from the triple-negative breast cancer category a subgroup of patients with HER2-low breast cancer for whom there may be a new targeted intervention. So in summary, I think after 30 years, we now managed to optimize the HER2 testing in order to guide treatment decision for the use of trastuzumab and other anti-HER2 agents. And we now have to consider how best to improve the HER2 testing beyond the current paradigm to identify patients with HER2-low breast cancer that may benefit from the new emerging therapies like the ADCs. And I did not discuss with you the HER3 status, which I think also we have to assess, not only because the HER3 might provide information about the resistant mechanism, but also maybe a primary therapeutic target for a new intervention. And with that, I would like to thank you for your kind attention.
Thank you very much, Dr. Mutaib, for this difficult talk. And my expectation, we will have a lot of debate and controversies with the pathologist about this talk in the coming few years. We'll keep the end to the end the questions. And now it is my pleasure, Dr. Mohammed Awad from Egypt will introduce the two speakers. The third one, please.
Okay, thanks, Dr. Abul Khair. I want first to thank Dr. Mutaib, actually very elegant talk. I think in the near future, the HER2 will not be just black and white. We have shades of colors that will shape the lives of our patients. Now we move to the triple-negative breast cancer section of our session today. Topics. One in the early triple-negative breast cancer about the PARP inhibitors, and the other one in the advanced triple-negative breast cancer about the immunotherapy. It is my pleasure to introduce Dr. Ahmed Saad-Eddin, consultant adult clinical oncologist, King Abdullah Specialized Child Hospital. He is going to talk about PARP inhibitors, what is new in early breast cancer.
Dr. Mohammed, if you don't mind, it seems there is technical problem with Dr. Saad-Eddin. Can you introduce the fourth speaker for the time being?
Okay. It's my distinct honor now to introduce Dr. Adhar Sayed, a consultant oncologist, Oncology Center, King Faisal Specialized Hospital. He is going to talk about refining in advanced triple-negative breast cancer.
I would like to thank the organizing committee and Dr. Sharif and his colleague for the excellent organization and my invitation. Bismillah ar-Rahman ar-Rahim. I'm going to share with you the updated data, and at the end, maybe everyone can share with the debate about this topic. Can you see my slides?
Yes, we can see. Yes, Dr.
Okay, so triple negative currently is defined by negativity for estrogen, progesterone, and HER2 receptors with or without FISH amplification. But again, this definition may be challenged to have a subtype of HER2, as Dr. Mutaib have elegantly shown. It represents 10 to 20% of all newly diagnosed breast cancer. Early and visceral relapse is common, including CNS relapse. There's a high expression of PD-L1 in these tumors, and depending on the study and the methodology used, you can have it up to 80% of patients. And in general, if these cancer metastasize, they have a very poor prognosis with survival less than 1 year. So we have 2 agents, PD-L1 in phase 3 with completed trials. 2 trials are with pembrolizumab and 2 trials with atezolizumab, and both agents have a negative and a positive study. We have 3 trials in the first-line setting: the Impassion 130 with nab-paclitaxel and atezo, Impassion 131 with the regular paclitaxel, and the Keynote 355, and these are the updates when they were initially presented, and updates with a recent update in the virtual ESMO meeting a couple of weeks ago, and the second line with pembrolizumab with the Keynote 119. So let's look at the data with these 2 PD-L1 agents. So the Impassion 130 was a double-blind, placebo-controlled phase 3 study. They included advanced triple negative with good performance status and who had expression of PD-L1 more than 1%. And the test used for positive result was the SP142 Ventana, where anyone with stain more than 1% were considered positive. So this study included both PD-L1 positive, which represented about 41%, and PD-L1 negative, 1-to-1 randomization, atezo nab-paclitaxel versus the standard dose of nab-paclitaxel as the comparative arm. No crossover were allowed, and there were stratification depending on the PD-L1 expression and prior use of taxanes. So let's look. The initial progression-free survival was reported in ASCO 2019 meeting. And you can see for the whole population, there was a positive results with a significant p-value, 7.2 months versus 5.5 months. And the result seems to be slightly more pronounced in those who are expressing PD-L1. And this is the overall survival. For the whole group, there was no benefit in the overall survival. But if we come to the PD-L1 expressing tumors, at 2 years, the overall survival was 25 months versus 18 months in those who are not expressing PD-L1. And this study was updated in the ESMO meeting last year with the overall survival at 3 years of 36% versus 22%. And this led to the accelerated approval of FDA for atezolizumab in triple-negative breast cancer who are expressing PD-L1 more than 1% by the SP142. And this was, I will go quickly over this slide, no difference in the response rate, and median duration of response was not that different between the 2 groups. So as their accelerated approval requirement, they had to do a confirmatory study, which is the FDA regulation for the accelerated approval. And exactly they took a very similar population with triple negative who have progressed after 12 months, 1 year, as per the original study of Impassion 130, with a good performance status, and randomized them 2-to-1 to atezolizumab, regular paclitaxel versus placebo with paclitaxel. And this was the standard doses of paclitaxel, 90 milligram, day 1, 8, and 15. So this was surprisingly a negative study. There is no difference in progression-free survival in the PD-L1 positive group versus PD-L1 negative group. And this is the intent to treat population. Again, no difference. And you can see the overall survival was a negative study, which was updated in ESMO last year. So this was a negative study. As a result, about a month ago, the FDA withdrew the accelerated approval of atezolizumab with nab-paclitaxel for advanced triple-negative breast cancer. And as mentioned before, it was the accelerated approval requirements is a confirmatory study, which was not fulfilled. And that was the reason I could find in the net for withdrawing the approval. And Roche, they withdraw the medication for the use in the USA. So the second study, or the first study with pembrolizumab, which is another PD-L1 agent, was this Keynote 355. And we have the final result in ESMO 2021, presented by Dr. Hope Rugo. And this is just a slide showing that the pembro does have activity in heavily pretreated patients with a response rate between 5% to 21.4%. So the earlier you use it, the better the outcomes. And this is the measure of PD-L1 expression in the pembro trial. They used the combined positive score. So mind you, the SP142 measures the PD-L1 expression in cancer cells, but the combined positive scores measures them in the cancer cell as well as tumor infiltrating lymphocyte and macrophages. And you get a percentage of a positivity, which is again considered positive if more than 1, and is moderately positive, it's more than 10. So this was the study, and mind you, very similar population, patient with advanced triple-negative breast cancer. The difference between the Atezo study, I want to highlight that they included any disease progression after 6 months. So instead of 12 months, anyone progressing after 6 months of curative adjuvant therapy were considered eligible for this study. And it was a 2-to-1 randomization with pembro and chemotherapy versus placebo and chemotherapy. And the chemotherapy backbone was either taxane or gemcitabine carboplatin, which was about 55% were non-taxane based chemotherapy. So they initially considered CPS more than 1 as positive versus less than 1 as negative. But later on, they amended the protocol in the future to include PD-L1 CPS expressing more than 10% as a comparative arm to CPS more than 1%. So that was an amendment which was later on in the study. So the primary endpoint was progression-free survival, and then they compared the CPS more than 10 versus CPS more than 1. And the overall survival and safety secondary endpoint. And this was about more than 800 patients in the both arms. And if you can see, the majority, more than 12 months, were 46%, less than 12 months disease-free interval still were included, about 22%. And you can see 55% had the gem carbo regimen. And more than 10 were about 39% of patients. I will skip this slide. This is more details on how the patient flow was going with the study, and go directly to the result. You can see the progression-free survival was statistically significant in PD-L1 expressing more than 10. It was also significant for more than 1, but the significance was about 2 months only, and for the more than 10 was about 4 months. For the whole population, it did not make any statistical, it was also statistically significant, but less pronounced than the PD-L1 expressing tumors. And this is again, the objective response rate, again, in favor, but not statistically significant. But what was presented in ESMO was this survival. You can see at 2 years, there's a 23-month survival with PD-L1 more than 10% versus 16 months. So a 7-month difference in overall survival in those who receive pembrolizumab in addition to chemotherapy. And this was the CPS more than 1. Again, you can see a difference, which was not statistically significant, of 1.6 months. And this is the intention to treat population. Again, the confidence interval goes beyond 1, and therefore not considered statistically significant, numerically about, again, 1.8 months. And this is the subgroup. I'll skip that. Again, this is the CPS score more than 10 had a better disease control rate, but I'm not sure whether this was significant or not. And this is the duration of response, again, in favor of patients who are expressing CPS score more than 10%. You can see the red bars represent the placebo with chemotherapy, and the green bar present the pembro chemotherapy. This is for the general toxicity. You can see most of the bars are very close to each other. And there was no increase in the regular toxicity compared to chemotherapy in the immunotherapy group. But if you come to the specific immune-mediated side effects, then there is a clear difference, especially with hyperthyroidism, pneumonitis, colitis, as well as dermatitis, more common in the immunotherapy group, which is consistent with all the previous study with immunotherapy. So this study have shown that adding pembrolizumab to the chemotherapy backbone, taxane and non-taxane backbone, in patients who are triple negative with a combined positive score more than 10% results in a better progression-free survival as well as overall survival, with a safety consistent with previous studies, with no new concerns about the safety of immunotherapy. And the second study with pembrolizumab was actually in the second line. This was Keynote 119, where patients who have failed 1 or 2 regimens prior systemic therapy and had disease progression with good performance status, and they should have received anthracycline with or without taxane. So they stratified according to the taxane, were randomized between pembro, so single arm immunotherapy with a fixed dose of 200 milligram every 3 weeks, up to 35 cycles, versus investigators' choice of chemotherapy. And these are the common chemotherapy regimens: use capecitabine, eribulin, gemcitabine, and virolalbine, which is the standard therapy used in failure of breast cancer after anthracycline and taxanes. And again, the primary endpoint was overall survival with progression-free survival as secondary endpoints. And this, I'll skip this slide. There's more details on how the patient was stratified. And this is the patient characteristics. So here, just a few highlights. So 40% had received 2 lines of chemotherapy, and the majority were post-menopausal women. And this is the CPS score. Again, around 31% had CPS score more than 10, and 65. So if you take this study with combined positive score, a very high number of breast cancer will express PD-L1 based on this study. And this was, I would like you to focus in the upper 2 graphs with the intention to treat analysis and combined positive score more than 1, which was the stratification of this study, was a negative study. You can see there is no difference in overall survival in the whole population or the combined positive score more than 1. The bottom 2 graphs are exploratory analysis and were not pre-planned in the initial design of the study. And you can see that the higher the CPS expression, the more likely, and there is trending overall survival with CPS score more than 20. But again, this is an exploratory analysis and cannot be used as a positive result. And again, I will skip duration of response. Again, the higher the expression of CPS, the longer the duration of response. Again, very similarly, you can see some of these side effects are actually worse with chemotherapy, especially nausea and vomiting, alopecia, anemia, diarrhea, as well as neutropenia. But again, if you go to the immune toxicity, it's much more common with pembrolizumab and consistent with the previous results I've shown you. So just this is a final summary slide I have made. If we talk about immunotherapy in triple negative advanced breast cancer, we have 2 agents. In the first line, we had pembrolizumab with Keynote 355, which is a positive study with overall survival, and again, a positive study with atezolizumab. This is the test used in each study, combined positive score versus SP142. The second line was negative. There's no data with atezo in the second line. Progression-free survival or survival was met in both studies in the first line, and both are anti-PD-L1 antibodies. With one more additional comment, the US FDA have withdrawn its approval for atezolizumab. I haven't found the Saudi FDA stand yet in their website, but my guess will be they might consider taking the US approval into their final decision. So this is my conclusions, and I hope I'm on time. So chemoimmunotherapy improved progression-free and overall survival in the first line for advanced triple-negative breast cancer, positive for PD-L1 expression. Current data and regulatory factors favor pembrolizumab over other agents. Validation of appropriate testing and increasing costs is a major challenge for addition of immunotherapy to the management of advanced triple-negative breast cancer. Early recognition of side effects related to immunotherapy is important for optimal patient management. And the question, should chemoimmunotherapy become a new standard of care in managing advanced triple-negative breast cancer? I've shown you the positive studies, negative studies, and FDA withdrawal, but my answer will be still yes, and it's open for discussion. Thank you very much.
Thanks, Dr. Adhar. We enjoyed every slide of your very elegant presentation. Thank you. Now, was the technical issue with Dr. Ahmed resolved?
No, we are going to postpone his talk to further notice. So we are going to group discussion. If you have, please, any question, you can raise it to any of the three speakers. The floor is open for questions now. If any, just raise your hands from the attending or virtual. Yes, please. Where? I cannot read. Sharif, is there any question on the board? Yes.
Thank you very much for your talk, Dr. Atlal. As usual, very nice talk. So you gave us a talk about de-escalation therapy. So in your practice, if you find a patient with a HER2-positive breast cancer, tumor size 3 centimeters, clinically node negative, shall you proceed with full course of neoadjuvant chemo, anthracycline followed by taxane, or shall you consider only weekly paclitaxel 12 weeks plus anti-HER2 therapy, given that this is more or less a small tumor and we can achieve BCR without full course of chemotherapy, according to the data that you have just presented?
So the question is, I'm going to omit anthracycline and just go with the carboplatin-based chemotherapy, paclitaxel.
Adaptive trial and others. We have data for weekly paclitaxel plus anti-HER2 only for those patients.
I still follow the guidelines, which basically tells you to give either 4 or 6 cycle of carboplatin-based and combined with double blockade, if you said it's node negative, right? So it's going to be just Herceptin rather than pertuzumab. And I assess the response. If the tumor is larger than 2 cm, definitely I add carboplatin. I prefer carboplatin. And I try to limit it to 4 cycles rather than 6 cycles. And usually the responses are very good. Yeah. I prescribe paclitaxel or taxane as single chemotherapy in addition to anti-HER therapy if the tumor is less than 2 centimeters. All right. And node negative, of course.
Same question for you. In your practice regarding trastuzumab 6 months, nowadays, especially you have financial issues, many patients cannot offer. Again, for same, Dr. Sharif, like T2 or less, node negative. did you, in your practice, give 6 months only trust?
I haven't been brave enough to do so yet, but maybe in the coming days, if I have selected, I have to highly select the patient for this approach because unfortunately, as you know, we see locally advanced disease most of the time. We encounter few patients who has early disease, and even they are having early disease, they are very young. So you try to optimize their treatment as much as you can, but perhaps, yes, maybe.
Okay, there is one question from our colleague, Dr. Ahmed Zainuddin. He is in Egypt, and his question to Dr. Azhar Sayed, is it acceptable to start chemo and then add immuno, like pembrolizumab, when the drug became available? Yes, Dr. Azhar.
Our aim when we are managing our patient is based on the data that this addition will improve the progression-free and overall survival. So now the issue is logistic. Is the patient, if we are doing the plan based on the data that this patient will have a better overall and progression-free survival, and there are logistic issues. So I think we should, لا يكلف الله نفسا إلا وسعها. I would say in Arabic, that you are doing your best, and if the drug becomes available, I would still use it because these factors should not lead to punishment of the patient. And everywhere there is limitation where you are trying your best to get the optimal therapy. If you can, then why not to add it? If you cannot, then that's you have done your part.
Like Dr. Azhar, if you have BDL1 positive and BRCA positive, now triple negative metastatic, again, this question frequently asked, what is your practice?
Yeah,
start
again,
with what?
As you have seen, Abu Khair, the studies with BRCA or the Olympiad with olaparib have included patients who have failed at least 2 lines of therapy in the metastatic setting, and for the BRCA, or 3 lines of therapy in the metastatic setting or before they embark on olaparib. So I will, based on the availability and the evidence, I will still go for immunotherapy, which was used as the first line, provided the patient fulfill the criteria, like they have progressed more than 6 months, they are excellent performance status 0 to 1, with no immune problem like SLE or rheumatoid arthritis. My preference will be to go for the immunotherapy, chemotherapy, and use PARP inhibitor in the 2nd or 3rd line of therapy after progression.
Thank you. Now the question for Dr. Mut'ab, please. Your pathologists now start to make it low HER2 or not yet?
I think it's not yet, Dr. Abul Khair, but I think this is what's going to happen in the future. So I think the 2018 HER2 testing recommendation has to be revisited again. Now there are ongoing clinical trial to test the benefit of ADCs in breast cancer in this new entity. For example, the Destiny 04 in breast. So I think if this clinical trial is going to be positive, then I think it's going to change the way we look at the HER2 testing. As I mentioned in my talk, so it's going to change the dichotomous classification to a 3-tier system by adding the HER2 new low breast cancer. And I think, again, this is going to add to the patient who now are considered either luminal B breast cancer. So usually we have estrogen receptor positive, HER2 new negative by 0 by 1+ or 2+ with a negative fish, and also going to add to the patient with triple negative. There is ongoing now a clinical trial, the Destiny 06, which is looking at the luminal breast cancer after 2 lines of treatment in the metastatic setting, including the CDK4/6 inhibitor and endocrine treatment.
Okay, any question? Yeah, from the audience, Dr. Asia, please.
Thank you for a nice presentation. But I want to clarify what's the criteria for use trastuzumab for 6 months. There is specific criteria to explain the patient plan from the beginning. Will be 6 months. There is exact criteria, Dr. Atlal.
As I mentioned in the presentation, first of all, if you have somebody with T2, a small T2, N negative, as well as they have ER positive tumor, then you may consider abbreviating the course of Herceptin. Of course, node negative, we're talking node negative disease. So early stage, not more than, let's say 3.5 centimeter node negative and hormone receptor positive, you may consider omitting or just giving 6 months of trastuzumab rather than 1 year of trastuzumab. And by the way, there is a meta-analysis that was published recently in the JAMA, including all the trials, the negative and the positive, and because it is individual data meta-analysis. And actually it showed that 6 months in the ones we mentioned, the ones with low risk disease is not inferior to 1 year of trastuzumab. So maybe it's time to adapt this approach. Yes.
Thank you so much.
I have a question to Dr. Metaib. Regarding the trastuzumab in HER2-low, it was tested before, the monoclonal antibody, and it was not superior to chemotherapy alone. I remember the trial was Xeloda combined with trastuzumab in HER2-low, and did not show superiority. Why do we see now a potential superior effect of ADC in HER2-low disease?
Thank you, Dr. Atlal, for this question. So regarding the trastuzumab, I think the more famous clinical trial is the B47, which tested patients with HER2-low breast cancer with trastuzumab plus chemotherapy versus chemotherapy alone. And we know from this phase 3 clinical trial that there was no evidence of trastuzumab in this type of patient. But the trastuzumab is monoclonal antibody, as you are aware. And the difference between the antibody drug conjugate is trastuzumab, which is bind to the cytotoxic treatment. So the ADCs has a different mechanism of action. For example, the first ADC, which is the TDM1, actually, when you look at the Catherine study, and we test the HER2 status at the surgical resection, even the patient who has HER2 negative, but initially they were HER2 positive, benefit from the TDM1. So this is a point we have to put in our mind. The second mechanism of action, which is different between the TDM1 and the new generation of ADCs, is the bystander effect. So meaning the bystander effect, we have a heterogeneous breast cancers. So not only the HER2 positive breast cancer will be affected, but also the neighboring microenvironment will be affected. And we have different drug to antibody ratio. So if you will look, for example, the TDM1 and compare it to the trastuzumab deruxtecan, it's actually 7 molecules to 8 molecules per antibody drug. So I think we are going to have a revolution in breast cancer management in the near future with the development of this agent.
Yes, Dr. Atiyah.
My question to Dr. Adhar Sayed. What is your comment regarding the conflicting result of Ambition 130 and Ambition 131, despite almost the same inclusion criteria with backbone of atezo? Do you think it is related to nab-paclitaxel preference over conventional paclitaxel, or result of Ambition 130 was by chance from the start? What's your comment?
One of the theories is only theory, nobody exactly knows how to explain that. But with nab-paclitaxel, you don't need steroids, which is a standard pre-medication for the paclitaxel. And steroids have immunosuppressive effect. So that might explain that immunotherapy may be less effective because you're suppressing the immune system. The other comment was regarding the dosage of paclitaxel in the Impassion 131 was 90 per meter square, and the nab-paclitaxel was 90. And they say that maybe the best single agent nab-paclitaxel should be 125 rather than 90. So it's underdosing for the nab-paclitaxel in the 131 study as a single agent. So that are potential explanation, but we don't know. The results are positive. And when the Roche withdraw, they maintain that the results are robust. And it's only the US FDA that have withdrawn their approval based on their regulation, but the medication will still be used in Europe and many parts of the world because they don't apply FDA rules.
Yes. Any further questions, audience? Virtual questions? If not, Dr. Muhammad Awad, can you conclude the talk?
Okay, thank you. Actually, I want to thank Dr. Sharif and thank you all. Very, very elegant presentations, and I enjoyed this meeting very much. Yes. For today, we have enjoyed a very nice topic about the positive breast cancer de-escalation. And of course, in smaller tumors and ER positive, we have the opportunity to give only 6 months of trastuzumab instead of the long course. Also, we have a chance in the presence of dual blockade to avoid the use of anthracyclines and its very long-term toxicities. Regarding the triple-negative breast cancer subtype, we have two hot topics, one about the PARP inhibitors and also another one about the immunotherapy. We have a drug that initially approved and then the approval was withdrawn. It is the atezolizumab. We have a drug that is very promising. It is the pembrolizumab. I think the immunotherapy is working very well in the first line setting. However, in the second line setting, it seems to face difficulties. So I think positioning immunotherapy for now should be in the first line setting only. Thanks, and we end the session now.
Thank you very much. And now I think the time, thank you for all of you. And now we'll move to MSD Satellite Conference, and will be chaired by Dr. Ahmed Shehri. So please, Dr. Ahmed, thank you.
Thank you.
طيب بسم الله الرحمن الرحيم. السلام عليكم ورحمة الله وبركاته. Welcome everyone for this satellite symposium. I would like to thank the organizing committee of this conference, specifically our dear colleagues, Dr. Sharif, for the successful meeting several years in a row. And I would like to thank MSD for their kind invitation to moderate this session to talk about the systemic therapy in head and neck cancer, specifically talking about immunotherapy in advanced head and neck squamous cell carcinoma. Our speaker is Dr. Ru'a Shafi. She's a medical oncologist. Actually, she's one of the shining stars that we just got in our center almost a year ago. And she's specialized in head and neck cancer and GI cancers. And she gonna give us this elegant talk about the immunotherapy in head and neck cancer. So Dr. Ru'a, the microphone is yours.
Assalamu alaikum wa rahmatullahi wa barakatuh. I'm Ru'a Shafi, medical oncology consultant specialized in GI head and neck cancer. I work at Princess Noor Oncology Center, King Abdulaziz Medical City. So it's an honor today to be invited by MSD to talk to you about immunotherapy, focusing on the immunotherapy in the first line setting in head and neck cancer. So these are my disclosure. Thanks to MSD for sponsoring the satellite session. So to begin with, when we talk about immunotherapy in the head and neck squamous cell carcinoma, as we know, we already have nivolumab and pembrolizumab approved for a second-line systemic treatment. And we know when we talk about pembrolizumab, the higher the PD-L1 suppression, that's more predictive of response and efficacy when treating with pembrolizumab. And also we know combining these two treatments has been in other cancer, like as we hear today, has been also showing efficacy. So when we come to talk about in head and neck, this is the trial that's published in Lancet in 2019. And it really answered a lot of questions and changed the landscape a little bit for treating head and neck squamous cell carcinoma. So Keynote 048, it's a phase 3 study that looked at first-line immunotherapy in the squamous cell carcinoma. Now the study design, as we all know, so this published in Lancet 2019, we had 3 arms. So the first arm was pembrolizumab monotherapy. Okay, this is up to 35 cycles, 2 years. Then the combination, which is pembrolizumab with chemotherapy, and the chemotherapy backbone is a 5-FU platinum base. So carbocis with a 5-FU, and then you go for 6 cycles, and then you go into pembrolizumab. So the first one, the pembrolizumab monotherapy, that's the first experimental arm. Then the combination, the pembro with the chemotherapy. All of these were compared to standard of care, which is extreme. As we all know, extreme is using 5-FU platinum with cetuximab, 6 cycles, and then you continue on for cetuximab maintenance. Now they included the non-nasopharyngeal squamous cell carcinoma, so your oropharynx, hypopharynx, larynx, recurrent metastatic disease, of course, not amenable for any local therapy, performance status 0 or 1. And they did look at the PD-L1 assessment. We'll talk. They calculated the CPS and the TPS as well. And also they looked at the P16 status. Okay. And this is the initial result when they published this in, initially. So this is the baseline characteristic. So when we look at the characteristic, when we look at the PD-L1 status, and this is where we need to focus a bit on. So CPS 20 or more, almost 44% of the patient, so almost half of the patient. CPS 1 or more, so CPS positive, almost 85% of the patient, even 86 sometimes. So the majority of the population in this trial were CPS 1 or more, or positive at least. And just to remind you, combined positive score, and this has been well validated to predict response. because it's looking not only at the PD-L1 in the tumor cells, you're looking at the PD-L1 in the tumor cells, in the macrophages, and in the tumor cells, so in the microenvironment. And then you calculate the number of the PD-L1 positive cells divided on the total negative tumor cells only, and you get a number. And the maximum is 100. So this is the combined positive score, or CPS. So the initial result of this trial, we know that pembrolizumab monotherapy, comparing to the standard extreme, which is the cetuximab chemotherapy-based regimen, if you have a CPS, whether more than 1 or more than 20, there is a benefit. Now, if you are more than 1, it's non-inferior to the extreme, but definitely superior if you are more than 20. So whether CPS 1 or more or positive, at least, pembrolizumab monotherapy is the way to go for these patients. What about the combination? And when we talk about the combination, the pembro versus, plus chemo versus extreme, this was positive in all groups. So more than 1, more than 20, and the total population, meaning regardless of their CPS score. So this has showed superiority, okay? Now, when we talk about, this is the initial. Now we do have a long data, the 4 years follow-up data. So this is a long-term outcome from the Keynote-048, and that's good to see. So when we go back to the first arm, so the monotherapy, the pembrolizumab versus extreme, our standard regimen. And as you can see, CPS 20 or more and CPS more than 1. So CPS 20 or more, we still see that's benefits, around 4-month difference, significant p-value, still the same. And the same thing for 1 or more. They still benefits a bit less, but they still see a great benefit in those population too, with very significant p-value. Talking about the combination versus extreme. So this is immuno plus chemotherapy. Again, we see in the CPS 20 or more, CPS 1 or more, you see benefit. Now, if you just going back, you can see it's almost equivalent. So probably in the CPS 1 or more or 20 or more, you're good enough with with pembrolizumab monotherapy. Sorry. Yes. And then this is when we talk about duration of response, which is something we see in immunotherapy and the durable response. And this is the long-term data. So in monotherapy, pembrolizumab comparing to extreme, CPS 1 or more or CPS 20 or more, as you can see, we are seeing a median duration response of 23 months. That's almost 2 years. So that's really good. And as the same thing here, when we see also more than 1, we see that the same thing around 24 median duration of response. So that's really good in those patients. We don't see that when we look at the combination comparing to the extreme, and this in the CPS positive patients. When we talk about the safety and the side effects, so pembro monotherapy comparing to extreme, and as you can see here, the differences. Way less side effect, of course. Any grade is like 50% compared to even 96 in the extreme, and even in more importantly in the higher grade 3 to 5, way less rate of toxicity. And that's the great about this agent. But again, it's in the CPS positive patients, so going with pembro monotherapy probably it's the way to go. Very acceptable safety profile, and we see a longer good response rate and longer response duration of response. And again, always there was a question when that trial published, but what about the other subgroup, the one that less than 1 or 1 to 20? And this is the subgroup analysis for this subset. So if you can see in this graph, so start with the graph A. Again, this is looking at the combination. So chemotherapy with immunotherapy, pembrolizumab, versus extreme in the CPS less than 1. So CPS negative patient, we can say. Again, it was very small number of patients, only around 44 in the Pembro arm versus 35 in the extreme arm. So very small number of patients. So analysis was really limited. And you can see from the graph, kind of extreme is better. They did say it did meet non-inferiority, but again, it's a very small number of patients, analysis limited. You will take this with a grain of salt probably. And then going to the next graph. So graph B, the one just underneath. So if here looking at monotherapy, trembolizumab versus extreme in the CPS 1 to 19, okay? And we do see still it's almost meeting non-inferiority. So that's good. So in these patients, at least we know we can go, still if they are CPS 1 to 90, they're less than 20, but more than 1, then you can use pembrolizumab as a single agent. Looking to the graph C, so combination versus extreme in the CPS less than 1. Again, it's a very small number of patient, analysis limited, but as you can see here, it's kind of net non-inferiority. So the combination was similar to extreme, meaning non-inferior. But again, it's a very small number of patients in this data. The last one, the last graph, graph D, the combination versus extreme. In the CPS 1 to 90, we do see a benefit. Okay, and that's reasonable, given those patients, they do have CPS expression, they would benefit from the immunotherapy. This is looking at this after the first line treatment, okay? So progression after the next line of treatment. Because we always wonder if for some reason, if the patient started on combination chemotherapy plus immunotherapy, what would that add? Would that affect your next line of a treatment or the survival after that? So this is again analysis looking at in the trial, the Keynote 048, but after the progression. So they will be the initial and but after here. So when they have disease progression, and then to go into subsequent therapy, then we will look into their outcome. Now, it's good to know that they did counted these as an outcome. So patient who did not receive a second line therapy or stopped the second line therapy without disease progression for toxicity or any other reason and did not start third line, it was counted as an event. Also, patient who stopped the second line therapy with disease progression counted as an event. And the patient who stopped second line therapy without disease progression and started third line therapy, so for toxicity or anything else, also were counted as an event. So that's, we see here in, this is the Pembro monotherapy versus extreme and the CPS 1 or more. So CPS positive population, pembrolizumab monotherapy versus extreme. That we do see still, this is the second PFS2. So after they have a progression, or they might be switching treatment for another reason, if they will go on into subsequent treatment, that we still see 20% reduction in the second progression. Okay. The same thing when we talk about the more than 20, we see still reduction in the second progression. And the same thing as well, when we talk about the total population, that's everyone. Also, we see it's less, but we still see some reduction in the second progression. When we talk about combination, so immunotherapy plus chemotherapy and the CPS 1 or more, we still also see reduction in the second progression. Now, again, as I told you initially, they did include, it wasn't only disease progression. It might be people who stopped treatment for toxicity or people who switched line therapy, or didn't go on into second line treatment. So, but we do see reduction in the second PFS for those group. The same thing here, and this is for the more than 20, we do see 37% risk reduction in the second PFS. And this is, this was not, I think, significant. So this is what just the most second line treatment each group had. So obviously, if you started with Pembro monotherapy, then your most second common agent, most of the people had chemotherapy or EGFR inhibitor. The other will be way less. And the opposite for the Pembro combination. If you had chemotherapy and immunotherapy up front, then the majority went on other treatment or chemotherapy still, or even anti-EGFR. And if you started off with the extreme, the 50% of you can go into immunotherapy next or so. Just looking what each group had after they progress on the first line treatment. So summary, we know that pembro monotherapy versus extreme or standard. That's for the PFS2, the patient who are CPS positive. We do see even benefit whether you're talking on the in the first line or even after that, it did not affect after that. So basically you start off with immunotherapy if they are CPS positive, then if the progression, you go on into the next line and you will go back into chemotherapy. And the same thing apply whether you start even with a combined chemotherapy and immunotherapy. Now again, there is other reason for stopping treatment, right? That was counted in, whether it's stopping treatment for toxicity or just go without disease progression. This is summary of the keynote 4.8 update, a bit crowded. I think we'll go to this much to simplify things. So treatment algorithm. So this is first line. When we talk about first line for head and neck squamous cell carcinoma, non-amiable for any local disease. Ideally, if you have a patient, you want to send for CPS. And if your CPS came more than 1, whether 1 to 19 or more than 20, we know pembro as a monotherapy will be the way to go. As in 1 and 19, it was non-inferior to extreme, and more than 20 was superior to extreme. And of course, better safety profile and quality of life. And even the PFS2 was better in those population. If you have patient with a CPS negative or less than 1, and also patients, you probably want a rapid response is needed, like when they're symptomatic, and that's the case in most, I would say, quite majority or half of the patient and the head and neck patient, then you have 2 options, whether you go with your standard chemotherapy or you can go with combination. You can go with pembro plus chemotherapy. Just to tell you that in the NCC guideline, they did add, so in the first line, in the unresectable metastatic squamous cell carcinoma, you can use pembro monotherapy for the CPS more than 1 or more than 20, or combination if you don't know the CPS status. And then the second line, we all know we can go nivolumab and pembrolizumab. And even in the ESMO guideline, they did add, so this is non-platinum, in the first 6 month PD-L1 positive tumor, then you go for pembrolizumab. And if you don't know, or if you can also, you have the option of the combination. This is in the ESMO guideline. The last thing I want to talk about is, and this is from melanoma. So this is looking at the pembrolizumab 400, the Q6 week dosing. This is from melanoma, which is a phase 2 keynote 555 in melanoma. And they basically had melanoma patient where they had 2 arm, the single arm, every Q6 week for up to 2 weeks. So this is different than our usual, which is we give 200 milligram every 3 weeks. This is double the dosing and more frequency. So 400 every Q6 week up to 2 years. And looking at the objective response rate was almost very similar to all other previous trial, that there were no any toxicity signals in this dosing or efficacy difference. So that has been approved for melanoma, and we can probably in any other pembrolizumab to try to use that. For my practice, I would not at the beginning, because you want to probably follow up your patient closely to assess response and to assess toxicity. As we all know, in the adverse effect of the immunotherapy, the key is early detection and treatment. So you probably want to start off slowly first and see how they're doing, and then switch them if they're more stable to Q6 dosing. There's just a case I had, I wanted to share with you. I had this elderly gentleman, ischemic heart disease, heart failure, ejection fraction is 45%, hypertension, diabetes, COPD, ex-smoker, had hypopharyngeal cancer treated with radiation back in 2018. He had a CT scan, this was last year, almost at the time when I arrived to started my career in the National Guard Hospital. He had CT scan that showed multiple lung nodules, cervical lymph node consistent with metastases. At the time he was referred to my clinic, he came with his daughter on a wheelchair, but is still independent for his ADL adult daily activity. He was asymptomatic at the time. PS was 2. Of course, he wasn't a candidate for chemotherapy. And we had at the time MSD support, so we sent for his CPS, came back at 75. So started pembrolizumab monotherapy in November 2020, that was last year. Initially started, of course, the usual dose, the 200 every Q3 week. After the first 4 months, repeated scan, showed response, and he had no any adverse effect. So switch it to Q6 week dosing. And he's still on treatment for now, up to a year. Hope he will continue even more. And that's it. Thank you.
Excellent talk, Ru'a, as always.
Thank you.
Very thorough review of the first line treatment, specifically about the role of immunotherapy in head and neck cancer. Probably we might have maybe around 5 minutes of discussion or even more. So if we have any question at the Q&A box, or we can receive some questions from the audience. Meanwhile, I can start with one question to you. Ru'a, so you presented these data very interestingly about the combination of chemo plus pembro. And even in CPS negative population, it was not inferior to extreme. So my question to you, why do we bother to do BDL1? If you decide upfront this patient need a chemotherapy to induce a response, should we do BDL1 or should we just jump to start the combination? What do you think about that?
Well, again, as I mentioned, in the trial, this trial, the Keynote 048, most of the patients were at least CPS 1 or more, so 88%. So when we say total population, they did meet the non-inferiority, you wonder whether it was driven by mainly the CPS positive patient. Because if you see in the subgroup analysis that I presented, when they looked at the CPS less than 1, extreme was actually almost a the CPS or you want a rapid response, you can start the combination. But we know, of course, the chemotherapy, also the backbone they used with the combination. It's an older regimen that the 5FU with the platinum base, which is very tough, and to combine that with immunotherapy. And our head and neck patients, most of the time, they're not the robust patient as you know. So if I can save the patient that toxicity, I would send for CPS because they're positive, then I can just get that the same benefit with just monotherapy, immunotherapy, pembrolizumab monotherapy. But if they are negative, then you can still use the combination. We know that can be beneficial. If that's the case. So I think I would save it to the people who are negative or I'm looking for rapid response to use the combination.
Okay, fair enough. So do we have any question in the Q&A? Any question from the audience? Yes, please. Can we have a microphone over there? I mean, for the people virtual, just to hear your question. Yeah, it's working now. Can you raise your voice?
I can.
Your voice. Can you raise your voice, please? Okay, just leave the microphone. You can ask without the microphone.
Yeah, it was non-inferior to the extreme. So you can, okay. So the question was in the patient who's CPS 1 or more, at using pembrolizumab as a single agent. And we know that that specific group was non-inferior to extreme. It's opposite when we talk about, because they still benefit, but the benefit is not like in the people who had CPS 20 or more. But it was non-inferior to chemotherapy, the extreme regimen, which is a chemo cetuximab-based regimen. So if that's case, if you have those patients, and we know when looking at the safety profile, the side effect profile, of course, using immunotherapy is way better. So then if that's the case, you can still use it because it did meet non-inferiority comparing to extreme. Well, the higher, of course, it was superior even, like if you're talking about CPS 20 or more.
Okay. I think, Muhammad, we have a question at the Q&A. Can we see if we have a question to address? Meanwhile, until we see that, another question to you, Ruha. You talked about the chemotherapy companion with the Pempro, which is the old standard, 5-FU, platinum. It's not an easy chemotherapy. It needs admission in most of the cancer centers. Would you consider, if you have a patient who needs chemotherapy and he's PD-L1 positive, okay, would you consider a different kind of chemotherapy like the one have been used in the TPX plus the Pempro?
I mean, the NCC guideline, they do mention you can pair Pembro with like docetaxel or paclitaxel carbo regimen. Now, again, we don't have any evidence supporting that, so I'll be a bit hesitant to do that. But it is in the NCC guideline that you can pair, I mean, Pembro with Pacli or Dosi, like the TPX regimen, for example, but without, of course, the cetuximab, just the taxane, I mean. Yeah.
Okay. Fair enough. Do we have any other question from the audience? I think we have a question at the Q&A box, but it seems to be a breast question. Are you interested to take this question?
No.
Okay. I think with that, we finish all of the questions that we have. Thank you, Dr. Arwa, for this nice presentation about the immunotherapy in head and neck cancer. Thank you, MSD, for sponsoring this satellite symposium.
You're welcome.
As per the chairman of the meeting, 15 minutes break for Asr prayer, then we'll be back, inshallah, at around what time? 4 p.m., inshallah.
check. بسم الله الرحمن الرحيم. Hello, say check. Hello. Hello.
السلام عليكم. السلام عليكم.
بسم الله الرحمن الرحيم. السلام عليكم جميعا. We'll present now the lung cancer session. It's my pleasure to present Dr. Turki Al-Faya. Dr. Turki, he's a consultant medical oncologist, Prince Noura Oncology Center, King Abdulaziz Medical City, Jeddah. He will present the recent advances in management of early and locally advanced non-small cell lung cancer. Dr. Turki.
Thank you, Mr. Chairman. Assalamu alaikum wa rahmatullah. I would like to thank all of you for being with us today, and a special thanks to AstraZeneca for allowing me to present in this pharmaceutical lecture. So my topic will be about the recent advances in the management of early and locally advanced non-small cell lung cancer. These are my disclosures. So we all know that lung cancer is a very aggressive type of cancer. It is actually the number 2 with regard to the mortality and with regard to also the incidence. If you look at the estimated number of cases in 2020, the lung cancer is located just below the breast and above the colorectal cancer, and this is worldwide. And there was about 2.2 million cases that has been reported in 2020 with diagnosis of lung cancer. And in Saudi Arabia, we are not that different too much. The only difference is the incidence of lung cancer is the 5th after colorectal, leukemia, lymphoma, and thyroid cancer. The median age for diagnosis is 64 in male and 63.5 in female, and there was about 1,000 new cases diagnosed in 2020 in Saudi Arabia. And again, we are not different than the other part of the world. So the majority of the cases presented with advanced condition, about 75%, with only 10 to 15% localized disease and up to 18% with locally advanced disease. And this is actually a challenging issue, because when you have a disease that present majority of the cases present with advanced condition, then the options of therapy and the outcome as well as the survival is going to be challenging. And that is why, if you look at this graph, you will notice that the stage 2 and 3, they did not do well with lung cancer. For example, if you look at stage 3, it's a 36% overall survival at 5 years. And when you compare it with colon cancer or with the breast cancer, these numbers are very low in comparison. And that is why we need to have more options of therapy in these stages to try to improve the overall survival. Lung cancer is very important to be diagnosed and treated through multidisciplinary care, because It is not a unique or a one disease. It is a it is a heterogeneous disease. So you need medical oncologist, radiation oncologist, surgeon, pathologist, respirologist, palliative care. All of them need to be on board upon diagnosis of lung cancer. And this is the importance of discussing cases in tumor board. Always patients who have been discussed in tumor board and managed per recommendations, they always do better. This is an example of a single institution data where patients who have been treated based on a multidisciplinary plan or approach, they did a very good with regard to overall survival compared to those who have been treated without multidisciplinary input. So always we try our best to discuss every case, new case of lung cancer in our meetings to try to achieve better outcome. So in earlier stages, the question comes whether this patient has a resectable disease or unresectable disease. And after discussion in tumor board, if the patient has a resectable disease, then patient should go for some form of adjuvant therapy. If you look at the 8th TNM staging system, you will notice, at least, for example, the stage 3 disease, you will notice a very heterogeneous disease. It is not one disease. It is varied between a large tumor size with 0 lymph node up to a tumors that are small tumors, but very large number or extensive lymph node metastases. That is why the approach of therapy is different. For example, here you can offer chemo, you can offer surgery. In these stages, you can offer chemoradiation, but in still locally advanced disease, for example, stage 3C, the only option is palliative therapy. So it is indeed very heterogeneous type of tumor. So after resection, adjuvant chemotherapy is the standard of care. It should be platinum-based chemotherapy. These are clinical trials that evaluated the adjuvant chemotherapy after resection. And you can see here that the overall survival benefit at 5 years is ranging between 5 to 15% benefit. But the latest meta-analysis showed that the 5-year survival is only 5% with chemotherapy. So outcome is really very poor. The best people who benefited are those with stage 2 and stage 3 disease. And unfortunately, after chemotherapy, many patients will have a recurrence. And when the stage gets bigger, the rate of recurrence is getting bigger. And the most important place for recurrence is the brain, because 40% of patients will have a recurrence in the brain. And it is actually associated with a lower survival and faster deterioration in quality of life compared to those who have a recurrence in the lung or in the bone or in the lymph node. So recurrence is a significant issue with such cases. If I take you to stage 4 disease, if you remember, with chemotherapy in stage 4, the median survival was the best we achieved is 8 months. And in some 1 or 2 clinical trials, they passed 12 months median survival. But there was significant improvement in the outcome when targeted therapy introduced and also immunotherapy introduced. For example, if you look at the targeted therapy, we are now talking about 50 and 60% 5-year overall survival. For example, alectinib, 5-year survival is 60%. For immunotherapy single agent, in patient more than 50% PD-L1, we are talking about 30% survival. So these are very important achievements in stage 4. And that is why, because of these achievements in stage 4, all of these options have been moved to be used in the adjuvant setting and in the locally advanced setting. So that is why there have been many efforts of EGFR therapy in adjuvant setting. This graph is telling us that the incidence of EGFR mutation does not matter between the stages. What really matters here is the geographical distribution. So you will see here that in the Asia, it is the highest prevalence of EGFR mutation compared to the Europe. And we are here in this graph between 25 to 30% incidence of EGFR mutation. So there have been many trials to evaluate EGFR TKIs in the adjuvant setting all of these trials were positive for disease-free survival, but they were negative for overall survival. And the most important trial, I think it is actually a landmark trial in this field, is the ADORA trial that have been published in the New England Journal of Medicine on two occasions or two issues. And in this study, patients with early stage lung cancer, stage 1B, stage 2, or stage 3A, who have been resected, they were tested for EGFR mutation, and if they are exon 19 deletion or exon 21 mutation, they were randomized to osimertinib for 3 years or for placebo. And the primary endpoint was the disease-free survival in stage 2 and stage 3A. And the secondary endpoint was disease-free survival in the whole population, as well as the overall survival. So baseline characteristics, they were very well balanced. I need to draw your attention that the adjuvant chemotherapy here, 60% in each arm received adjuvant chemotherapy, which is lower than what's expected to be done in such cases. So this is the primary endpoint in stage 2 and stage 3A. You can see here that after a follow-up of 20 months, there have been significant improvement in DFS in favor of osimertinib compared to the placebo, and the hazard ratio is 0.17. And I have to tell you the truth that we never see a graph like this in lung cancer where the separation is a very, very significant. When included stage 1B, still the benefit is a significant with hazard ratio of 0.20. And this is the DFS based on the stages. So there is no doubt that the bigger stages, stage 2 and stage 3, they will benefit better from the systemic therapy in general, including the EGFR TKIs, but also for stage 1B, the hazard ratio is 0.39. And usually with the stage 1B, we always have a discussion with patients regarding chemo, whether we give chemo or not, but definitely for EGFR TKIs, we really recommend it because there is a benefit in stage 1B as well as the other stages. This is a slide from the WCLC last year, where a patient who received adjuvant chemotherapy then had osimertinib, they benefited. And also those who did not have adjuvant chemotherapy for any reason, their benefit was also significant. And we always focus more on stage 3A because this is a high-risk group where chemotherapy should be given to those patients. Difference in the two curves. Now, the type of disease recurrence is very important because if you look at the osimertinib, those who treated with osimertinib, there have been 2%, two-thirds of the cases have been had a recurrence locally. Only 38% had a distant recurrence. For the placebo, it is the opposite. 2/3 had a distant metastasis and 1/3 had only local recurrence. And we know definitely if you have a patient with a recurrence in the lymph node or in the lung or in the bone, they do much better than those who have a recurrence in the liver or in the brain. So the pattern of recurrence is also important in such cases. This, because with osimertinib crossed the blood-brain barrier, that is why the DFS in the brain was also significant in favor of the osimertinib. For example, at 3 years, there is only 2% had a recurrence in the brain compared to 18% in the placebo arm. And osimertinib is a generally safe drug with a grade 3 toxicity, 10%, compared to 9% to 3% in the placebo arm. So if the patient is unable to be resected because of a extent of disease or because of the operable causes, then we have to take this patient as unresectable locally advanced with option of concurrent chemoradiation therapy. Then we have to offer some form of immunotherapy as a consolidation to try to improve the overall survival. And this has been evident in the Pacific trial. Now, combining immunotherapy plus radiation is important, and it has actually evidence in the preclinical model. If you look at the murine model here, the cells that had a radiation, they have a better PD-L1 expression compared to those with no PD-L1 expression. And the difference is really significant. And those cells treated with radiation plus monoclonal antibody against PD-L1, their survival was very, very significant compared to those who had no treatment or cells that has only immunotherapy. So immuno plus radiation is always seems to be better option in these cases. That is why Pacific trial has been designed to address this issue. So this study including unresectable stage 3 disease after chemoradiation, who had a disease, who had no progressive disease. And all comers have been involved irrespective of PD-L1. And they were all randomized to durvalumab for 1 year or placebo. The randomization happened within 1 to 42 days post chemoradiation. Remember here, it is always in real life difficult to put patients as soon as finishing chemoradiation on immunotherapy. They always get tired, fatigue. They cannot go for systemic therapy. So they always get a little bit delay. So this is the progression-free survival, and this is the updated curve at 5 years. You will see here that there is a PFS benefit across all the data cutoff dates, and the median PFS was 16.9 months compared to 5.6 months with placebo. This is the overall survival. You see, this is the end of the treatment. So at the end of treatment, there is a significant benefit. And the benefit of the durvalumab in terms of survival was continuing over the years, and there was no overlap of the curves. And what is really striking here is that the median survival at 5 years was 47 point, well, at 4 years, this is at 4 years, was 47.5 months. Now, if you put the Pacific in conjunction with the other clinical trials that used concurrent chemoradiation therapy, you will notice in this table that the median survival from a different meta-analysis is ranging between 12 months and 25 months. However, with the Pacific, the median survival was 47.5 months, so almost doubled the median survival. And the 5-year overall survival was ranging between 6 and 31%, but with the Pacific, it was actually the 5-year survival was 43%. So there's no doubt that this is a practice-changing approach in such cases. So if you look at this graph, you notice that the survival of stage 1 and stage 2 and stage 3 is going down as the tumor gets bigger and as the stage gets bigger. But interestingly, in stage 4, if you have a patient with, for example, EGFR mutation or ALK or BRAF, or patient with PD-L1 expression of 50% or more, they seems to have a better overall survival with stage 4 compared to stage 3 and stage 2, which is some really paradoxical phenomena here. To have a stage 4 disease, they live longer than stage 1, stage 3, and stage 2 and stage 3. The only thing really changing this observation is the Pacific. So Pacific seems to improve the stage 3 overall survival, trying to match the stage 4 patients. we have some questions about the Pacific. Number one, is Pacific representing the whole population or the general population that we treat in our clinics? I think the answer simply is no, because with clinical trials, always the patient characteristics are a little bit better than what we see in the clinic, which is expected. For example, if you look at the stage 3 here, stage 3A, they are actually 52%, and majority of the cases here are actually ECOG 0, which is not usually seen after chemoradiation. If you look at the other clinical trials of the locally advanced cancer, the stage 3A is less, performance status of 0 is less. This is a data from China, including 61 patients treated with durvalumab after chemoradiation. There were only 53% of them, 55% of them were matching the criteria for the Pacific. But majority are still in stage 3B and stage 3C with performance status of 1. This is very important study, the Pacific R, because it really mirror the data from the real life, and it has been reported and presented in the ESMO a few weeks ago. And it is actually presenting the PFS of the durvalumab after concurrent chemoradiation in real world fashion. And they included in this study about 1,400 patients. Majority of them are actually from Europe. And they actually presented their data as part of a retrospective analysis. So all of them had a durvalumab after concurrent chemoradiation. So these are the baseline characteristics for those patients. What is important here is that they were 14% given durvalumab after sequential chemoradiation, and the rest are given after concurrent. And we always know people who treat lung cancer, sometimes we treat with sequential rather than concurrent chemoradiation. And this is usually because of older age or because the tumor is big. And that is why you cannot give chemoradiation. So we give sequential approach. Then durvalumab was given in this study. One of the other observation in this real life data is that the start of durvalumab was low, between 1 and 42 days. So only 35% were able to receive durvalumab in this time. The median time to start durvalumab was 52 days, which is expected, and which is also, we see it in real life. Those patients need some time to recover from chemoradiation. But this is the striking thing here, is that the PFS was 21 months, 0.7 months, compared to 16.9 months from the Pacific trial. There are explanations why in real life PFS is better. Probably this is because of the heterogeneity in assessing the PFS among different centers. Also, we know that when you assess for progression, there is always a difference between the real life and the clinical trials. Also, this has been conducted through the pandemic of the COVID, and that is why probably one of the reasons is that there are fewer visits to the hospital to assess for disease progression. But what is important from this study is that and patient who had a sequential treatment followed by durvalumab did as good as those who had a concurrent chemoradiation followed by durvalumab. This curve is very important. It is actually not a recommendation, but it is actually a hypothesis generating a curve to tell that durvalumab is working after sequential chemoradiation. We need to have a better data or bigger data to be sure that durvalumab is a good option in this condition. The other question, do we have any predictive biomarkers? The answer is no. Durvalumab works well for every level of PD-L1 expression. And remember, in this study, there was about 40% of patients had unknown PD-L1 expression. And the PD-L1 expression cutoff of 1% was actually part of the unplanned post hoc analysis by EMA. But if you look at all the guidelines, NCCN guidelines, FDA approval was all approved, independent and irrespective of the PD-L1 expression. Moving forward, I think the timing is important for immunotherapy plus radiation. Because if you look at the Pacific, one of the subgroups is that the timing of start of immuno, does it really matter? I think yes, because the patient who received durvalumab within 14 days did much better than those who received durvalumab after 14 days. So as much as you can, try to put your patient on the medication. And this may answer the question more clear. This is the Pacific 6 study, which is a phase 2 study evaluating durvalumab after sequential chemoradiation. There is no result from it yet, but what is really important here is that if you look at the time to radiation, time from radiation to durvalumab, less than 14 days is 100%. Means that almost all of your patients were able to start durvalumab after sequential chemoradiation. And we know sequential chemoradiation is an easier option on patients compared to concurrent chemoradiation. There is this effort to try to put durvalumab with concurrent chemoradiation. This is ongoing phase 3 trial of a chemoradiation plus durvalumab or chemoradiation alone, followed by durvalumab. And we don't have answer yet, but probably soon we will know whether durvalumab plus chemoradiation will change the practice. So the message here is that the upfront resectable non-small cell lung cancer, mainly adenocarcinoma, should undergo the EGFR mutation testing. And if it is positive, should go under EGFR TKIs, namely osimertinib. For stage 3 disease, we know that it is a very heterogeneous group of disease. That is why multidisciplinary team approach is very important in the management of stage 3 disease. For the unresectable stage 3 disease, after concurrent chemoradiation, it should be a standard of care to have a durvalumab because it has impressive outcome with regard to PFS and overall survival. And there are many ongoing trials to evaluate the strategy, like the timing, regimens, and the duration of immunotherapy. And these may change the practice in the near future. Thank you.
Thank you, Dr. Turki, for the excellent presentation. And we have 5 minutes for question.
Assalamu alaikum. Thank you, Dr. Turki, for the excellent presentation, as like always. I have 2 questions, but they are interrelated to each other. If I have, the first question is the squamous cell, non-small cell, with EGFR positive. What approach shall we go for it? Squamous cell, non-small cell with EGFR mutation. It's a rare case, but what approach shall we go? It's the same question for PD-L1 with squamous cell. Shall we give durva for that also? Only 2 different questions.
Yeah. So for the squamous histology, the EGFR mutation, as you mentioned, it is a rare entity. It is accounting for only 2%, 2.6% in literature. Majority of the time, we don't test for mutation in resected squam unless patient is having a very low history of smoking, or there is what seems to be a mixture of pathology with some glandular differentiations. So we will ask for EGFR mutation, but if it is positive, then yes, patient should go for EGFR TKIs. For immunotherapy, the squamous histology tend to have more PD-L1 expression actually. And that is why immunotherapy work well for such cases. So yes, IO should be an option for squam in advanced condition. And also in locally advanced, for example, in the Pacific, they included all comers, locally advanced all comers, squam, non-sequem, and they were given durvalumab. And the histology did not really matter, did not really affect the outcome. So the outcome was there across all the subgroups.
Okay, I have one more question, Dr. Turki. What's your approach about the N2 stage 3 disease in general? And the other question, do we have to test for the PDL for locally advanced before starting, like concurrent chemoradiation and durvalumab as consolidation?
So for stage 2 disease, we are now talking about the stage 3A and probably stage 3B if the tumor is big. Patients should go again through the multidisciplinary approach. We should do full investigations, including PET scan, and also confirmation of these into disease pathologically. And if it is positive and there is no option of surgery, which is the usual case for into disease, then the best is concurrent chemoradiation therapy followed by immunotherapy durvalumab.
And the test for PDL?
If you look at the data from the Pacific and also data from pembrolizumab, there is also data, I cannot talk about it because it's not really released yet. The benefit was irrespective of PD-L1 expression. So whether you test or not, it does not really matter. But if you are in a place where where the facilities are there, then it's better to have the full picture of your patients, NGS plus PD-L1 expression, because sometimes in such cases, for any reason, patient declined maintenance immunotherapy. When they have a progression later on, then you will know which treatment you will choose based on the PD-L1 expression.
Thank you. There is a question about adenocarcinoma stage 1B, 3B, PDL negative and EGFR positive. What should be the treatment? This question from Abdurrahman Khamis.
Sure. So for stage 3B disease, still, such cases, you have to push as much as you can for curative approach. So if there is a way to give radiation, concurrent chemoradiation, then I will go for chemoradiation followed by maintenance durvalumab, and watch this patient. When they progress, I will put them on osimertinib. If they are definitely not case for concurrent chemoradiation, then they will be treated as a maintenance, as a stage 4.
But as you present the outcome for advanced stages with mutations, it's better.
Seems to be better, yeah. But there is, remember, when you give chemoradiation here, there is a still chance for cure. That is why we would really like to take this chance.
Okay. Thank you, Dr. Turki. By this, we'll complete this session and we'll move for the second session. Also, it's still in the lung cancer, and it's my pleasure to present Dr. Samir Yasser. Dr. Samir, he's a consultant medical oncology in King Hussein Medical City, Jordan. He will present the second session.
Thank you very much, Dr. Walid. I would like to thank really everyone and everybody for hanging at this time of the weekend. Thank you for the invitation. As you know, the next speak is really very interesting. The molecular testing has become an inevitable standard in thoracic oncology, and medical oncologists are now confronting another challenge, which is a liquid biopsy. Our guest speaker is Dr. Abdullah Tuwaijri. He's a consultant medical oncologist and the chairman of medical oncology department at Comprehensive Cancer Center, King Fahd Medical City in Riyadh. We're waiting to hear from you, Dr. Abdullah, this very interesting topic. The floor is yours, and we're waiting to hear.
Assalamu alaikum wa rahmatullahi wa barakatuh. Thank you so much for the introduction. Just a quick disclaimer, I'm not a pathologist, I'm not a molecular pathologist. In fact, I'm an oncologist. I will try to speak about liquid biopsy from a clinical standpoint of view. Next. slide. Yeah, so why we need liquid biopsy?
We really need liquid biopsy to test for biomarkers. We needed to test also or monitor for the tumor and predict their outcome. We also need to liquid biopsy to track for drug resistance. And probably in the near future, we might be looking for even more than that. We are looking to look for example, minimal residual disease in order to define those patients who might be, or at least it will guide us for those who might need adjuvant therapy, for example. And hopefully we might use it also for a screening and early detection of cancer as well. So here at the liquid biopsy, we can look at many things. In fact, we can look at the proteins, we can look at RNAs, we can look also at also the circulating tumor cells. But our focus, in fact, is right now, it's mostly on the utility of the liquid biopsy, or the utility of liquid biopsy, in fact, in lung cancer is mostly on the circulating tumor DNA. Just put the pointer. Okay. So when we talk about liquid biopsy, we are focusing mostly almost on the blood, which is the most source of, or the most common source that that was fully addressed in most of the clinical trials. But we also can test other fluid such as CSF, for example, pleural effusion, ascites, probably urine even, or others to track also for other circulating DNA. But in the lung cancer, in fact, the blood is the main source for such testing. There are a number of clinical factors that, in fact, can affect the detection of the circulating tumor DNA. The most important is, in fact, is the stage, and especially if we have extrathoracic metastasis. And the more site we have, the more chance that we can pick up more circulating tumor DNA. So, for example, for a smaller tumor, early stage, less metastatic site, it's probably we might face what we call it the false negative result because of the few circulating tumor cells that might be around. Also, from a technical standpoint of view, there are a number of steps in order to quantify those circulating tumor cells that starting from a pre-analytic phase, then analytic phase, then gene panel of interest. And there's a number of factors that can affect this process at any time, such as handling, delays, and so on. So we need you need to have a very sensitive, in fact, technique in order to be able to detect those kind of circulating tumor cells, and any things impacting those phases really can give you also a false negative result. Those are the different techniques that currently being used nowadays. We do have a PCR, which is probably a quicker one, but it's give you a very limited mutations, while the NGS can be more sensitive and also can provide you with a larger set of genomic alterations that even can be seen at earlier stage disease. And even if you have also smaller tumors with a few circulating tumor DNA that are around. So first, we do need liquid biopsy, definitely to find for more biomarkers that are druggable, especially in the situation where we do have a very limited tissue or might be no enough tissue to run such kind of analysis. As you know, nowadays we have many drugs that currently approved, especially with advanced non-small cell lung cancer. It's not just an EGFR or ALK, but we also have many others. ROS1, BRAF, NTRK, RET, MET, and there are many others that coming in the futures. So to keep looking for more, especially if we have an issue with limited tissue, liquid biopsy definitely will be the future. So by doing liquid biopsy, we can pick up to more than 15% or 17% with the driver mutations. Not only those with a difficult tissue or not enough tissue, but also you can find additional 15% of the driver when you just add liquid biopsy to tissue in the sum of the retrospective data that are outlined here in this slide. The other important fact about liquid biopsy is if we have a positive liquid biopsy, for example, I think there is very quite discordance between the tissue and the liquid biopsy, which is an average from probably 80 to 90% in some of those reports. Plus the fact of the turnaround time when you speak about liquid biopsy, it's just 10 days. Of course, definitely when you do it in the same center, not just kind of send out test. And from a clinical perspective, you can trust also positive liquid biopsy. And this was seen across different clinical trials, including the FLORA trials of osimertinib in a first-line setting for EGFR mutant lung cancer. On the left side, you can see the PFS based on the tissue, and on the right side, you can see the PFS based on the liquid biopsy. And what we can see here is quite, you can see that the benefit is quite similar between both, whether the EGFR is found on the tissue or the EGFR found on the plasma. Doesn't matter, all of them, they do benefit the same way. The same story also we have it with an ALK positive in a BEAST trial with alectinib in patient with a positive plasma. Here you can see a similar number of response rate, PFS in the ALEX trial. So the bottom line, in fact, if you have a positive result, I think we can believe that the result, and those patients, you don't have to confirm those with a tissue. But it's not the vice versa when you talk about that, and I will speak about that probably in the next coming slide. So the second important fact about liquid biopsy is we track for resistance, and that's really one of the important fact that we have. Those patients with the driver mutations, when you start them on a targeted therapy, definitely at some point they will progress at some point. And so we need to know what's the type of resistance the tumor they have, and in order to, for example, select the best option that can be considered in the subsequent therapy. And such field is in fact expanded, especially in the EGFR and ALK lung cancer situation. The story, in fact, was started initially in the EGFR mutant tumor and the presence of the T790 mutations, both first generation or second generation EGFR TKI. We do see the frequency of these mutations in about 50% of patients, and such mutations is quite sensitive to osimertinib. And the fact also is not always easy or feasible to repeat the tissue in all patients on a second-line setting. Therefore, probably liquid biopsy concept were so exciting for such frequent mutations. So the AURA trial, which is the trial that have looked at the osimertinib in a second-line setting post first generation TKI. Here, when they looked at the sensitivity of the liquid biopsy to find this mutation, it's not that high. It is in a range of 50 to 66 or 65% when you use an NGS. Still, that we have what we call it the false negative And those situations, what we call them is probably we are dealing with what we call the non-Schedder tumors or the low tumor burden tumors. So if we have a larger tumor, more metastatic disease site, then the sensitivity of the liquid biopsy would be much higher, as we can see here in those in this slide. But given the concern of the low sensitivity of this test, if you come across a negative liquid biopsy, then you might have to confirm that with a tissue, not to miss such frequent mutation. Same story also we have with an ALK. The sensitivity of finding different acquired mutations is probably in the range of 60%, and that was seen in some of the reported data listed here. But if we have a positive one, I think the specificity is much higher. So if we got a positive result, for example, then I think you can trust the result and you can also act accordingly. Here we have data for EGFR, and we have data also for ALK. When you look at the clinical benefit of both tissue and plasma, you can see that, in fact, we have seen the same benefit, whether with osimertinib in EGFR mutant or with lorlatinib in an ALK positive cancer. Both agents have similar clinical benefit, whether the test was positive from the tissue or from the plasma itself. So liquid biopsy is not just important for EGFR or ALK, but also it's quite useful to look for other acquired mutations, and for example, ROS1, BRAF, RET, and mutations where you do have also other options right now proven, either they are proven or probably in a clinical trials. Liquid biopsy also might be useful to monitor for the tumor evolution, or it can predict also for future outcome. Here you can see those patients with positive circulating tumor DNA. They do have a poor outcome, and this was seen across different clinical trials for an EGFR mutations, including the FLORA trial, where those patients with a negative circulating DNA, their disease was controlled for much longer than those with circulating DNA positive tumors. And we can see here at the FLORA trial, for example, the BFS is at 23 for the negative one, while it's only 15 months for the positive liquid biopsy. The same trend we have seen it across different clinical trials, either for the BFS or for the overall survival. Not only the negative one have a better outcome, but also the fast you clear those positive circulating DNA with the treatment, you might also achieve the best outcome for such patient. Here we do see different clinical trials, including, for example, the AURA trial of osimertinib in a second-line setting, which showed patient with a clearance of their circulating DNA at 6 weeks have a better outcome compared to those with no clearance. The same trend was seen across different clinical trials with EGFR also positive lung cancer. The story also shared with other tumors, such as an ALK in ALEX trials with alectinib, also the trials of lorlatinib in the subsequent therapy, as well as the BRAF and the RET and so on. All these trials really prove the concept is of the more circulating tumor DNA cleared from the circulation, probably they will have the best outcome. such kind of observation, it also might help to direct future therapy for such a disease. For example, those with a positive circulating DNA, if they don't really have clearance, you might have to change or probably adjust the treatment to different therapy for such, or adding, for example, chemotherapy for resistance clone and or anything else, just help to clear more of those and probably you can achieve also the best outcome possible. There are also some more future applications for liquid biopsy. Such strategy might also be used for measuring minimal residual disease or probably early detection or screening approach as well. You know that we are exposing our patient for adjuvant chemotherapy, though we know that the benefit is quite small, and the question is, does the circulating DNA, for example, could help with that? We do have a number of data for a curative disease situations showed that those patients who were treated with the radical intent therapy, they could this could be a surgery, for example, for a stage 2 or 3, or even concurrent chemo rad for the inoperable stage 3. So the circulating DNA is quite prognostic, as you know, and also it could also predict for the benefit of further adjuvant therapy. So another way, the presence or absence of circulating DNA might help to, or might be used to select patient for further adjuvant therapy, rather than we just use those decisions based on the stage as we do right now. What about screening? We do know that low-dose CT is it's been used for screening for high-risk patient, and but could this be replaced by just a blood test with a circulating DNA? This could be, but the only issue we have, especially with the current technique, is very smaller tumor. This test might not be so sensitive, and probably we need more kind of sensitive technique to pick up such low circulating tumor DNA, and that's probably one of the future directions. So finally, I believe the liquid biopsy is quite useful in non-small cell lung cancer, and that it's really have a proven clinical application to find more druggable target, as well as tracking for resistance. There are many other applications that coming in the future, and probably one of the issue is the sensitivity of those tests, and it might be one of the ongoing issues that might also influenced by a number of clinical, technical factors. And there are a number of future research working on just to improve that issues, and especially with the technical factors. With this, I think I have reached to my last slide, and thank you so much for listening.
Thank you very much.
Thank you very much.
Interesting presentation, and we'll keep the question till the end. Next presentation will be with Dr. Rabab Jafar. Dr. Rabab, she's a professor, medical oncologist in National Cancer Institute, Cairo, Egypt. She will talk about multidisciplinary management of patients with stage 3 non-small cell lung cancer. Dr. Rabab, microphone is yours.
Thank you very much. I'm very happy to be with you today, and thank you for the organizing committee. And I think I have a video with my presentation, and I am online with you. Professors and colleagues, I would like first to thank Professor Hafiz Ghanem, Dr. Sharif Al-Sammani, and Dr. Mervat Mahrous, and all the organizing committee for giving me the opportunity to speak in this prestigious meeting. And my talk will be on multidisciplinary treatment of stage 3 non-small cell lung cancer. With this stage 3 is a very challenging stage in non-small cell lung cancer up till now. Overview of my talk will be introduction, resectable stage 3 non-small cell lung cancer, neoadjuvant and adjuvant immunotherapy. Professors and colleagues, I would like first to thank Professor Hafiz Ghanem, Dr. Sharif Al-Sammani, and Dr. Mirvat Mahrous, and all the organizing committee for giving me the opportunity to speak in this prestigious meeting. And my talk will be on multidisciplinary treatment of stage 3 non-small cell lung cancer. This stage 3 is a very challenging stage in non-small cell lung cancer up till now. Overview of my talk will be introduction, resectable stage 3 non-small cell lung cancer, neoadjuvant and adjuvant immunotherapy, phase 3 adjuvant chemotherapy followed by immunotherapy, positive adjuvant EGFR pulsar TKI, and the conclusion for the resectable stage 3A or stage 3 resectable. Unresectable stage 3 non-small cell lung cancer, concurrent chemoradiotherapy followed by immunotherapy, and the conclusion for the unresectable stage 3 with the NCCN guidelines for unresectable stage 3. This is the revised AJCC 8th edition of lung cancer staging guideline, and you see the differences between the 7th edition and the 8th edition, like T2B would be reclassified as T3, and T3 is reclassified as T4, while T3 and 2 will upstage from 3A to 3B, and there is a new stage 3C for the T3-4 together with the N3, upstage from 3B to 3C. And 1 in 3 patients with non-small cell lung cancer usually presents with a resectable disease, as you see in the form of stage 1B, stage 2, or stage 3A. But look, or stage 3 in general, but look to the this prognosis of this stage 3, and you find that 76% will be recurrent cases or failure cases to therapy. And the background for stage 3 non-small cell lung cancer is the real unmet need. Why? It approximately 22% of the patients with lung cancer diagnosed as stage 3 disease. And stage 3 non-small cell lung cancer is a very heterogeneous disease, and majority of patients are unresectable. And the goal of therapy is curative, but actually there is no long-term survival. The clinical practice of guidelines comes from the ESMO, as you see, you have to do generally examination, medical history, and assessing the comorbidities of the patient performance status. Imaging, like the most important will be the PET-CT to assess resectability and operability, laboratory, cardiopulmonary function, and tissue repair. Considerations when determining resectability in stage 3 non-small cell lung cancer, you look to the patient characteristics like performance status, comorbidities, as we said, COPD, CVD, cerebrovascular disease, lung functions, and age, and nodal involvement. How bulky is the nodal involvement? Have tumors spread beyond the nodal capsule, and is there any multistation of nodal involvement? Clinical picture guidelines will tell you after PET-CT or CT and PET, you have to do a mediastinal lymph node biopsy. So if it proves to be negative, you go for surgery. If it proves to be positive, then you have to do anyway to see this mediastinum like EUS or EBUS or so on to get a proper biopsy and to diagnose if the case is resectable or not. So resectable stage 3A non-small cell lung cancer, there was a plethora of literature about the neoadjuvant and the adjuvant chemotherapy. As you see, many trials have been done as neoadjuvant and adjuvant chemotherapy. And the fact is that it prolongs survival in resectable stage 3, but this difference, even for stage 1 and stage 2 and stage 3, all the resectable cases, the adjuvant chemotherapy will not give you more than 5 per neoadjuvant 2. So how do we optimize the adjuvant therapy to increase the cure rate for the patients? We look for efficacious systemic therapy like immunotherapy, molecularly targeted therapy, new chemotherapeutic drugs, 1 or 2 or 3 or more, the drug sequence, the concurrent versus sequential, all these are questions to be solved. And for the patient selection, many patients can be cured just with surgery. And chemotherapy has side effects that we all know. So we have to identify some biomarkers and like tumor gene signature or molecular residual disease, etc., to know who is going to benefit from this treatment. Neoadjuvant and adjuvant immunotherapy, the rationale to use immunotherapy for neoadjuvant or adjuvant therapy is that immune-tolerant tumor microenvironment is present in the early stage. And the treatment with immunotherapy is synergistic, associated with increased efficacy when you use the chemotherapy and radiotherapy or both. So the possibility of maximal tumor response prior to surgery is there. And the pathological response in phase 2 neoadjuvant immunotherapy alone trial, as you see, most of the trials will give you a residual disease, major pathological response ranging from 9% to 45% and PCR 0 to 29%. Phase 2 adjuvant chemo followed by immunotherapy trials. As you see, we have the Empower 10, we have the B31, BR31, AMBEL trial, and the PEARLS trial. What is the difference? The difference is the type of immunotherapy used. So in Empower 10, it's atezolizumab. For BR31, we use durvalumab. For the AMBEL, we use nivolumab, and for the PEARLS, we use pembrolizumab. Important study is the Empower 10 update because this is approved regimen now. Adjuvant atezolizumab extend disease-free survival in non-small cell lung cancer. So you see here in Empower 010 was a study design that we completely dissected stage 1B up to stage 3C non-small cell lung cancer, and they have to receive first cisplatin with cisplatin-based chemotherapy that we give in adjuvant therapy, and then to randomize the patients between having atezolizumab or placebo. PD-L1 was found to be a predictive biomarker for this trial. As you see, the disease-free survival at 36 months was 60% versus only 48% for the cases that had received placebo. For the cases having PD-L1 TC more than 1% and stage 2 to 3A population. And we have the ongoing adjuvant chemo IO trials other than Empower 10. We have the Alchemist chemotherapy trial, and we have the BTCRC trial using, again, chemotherapy by immunotherapy, which is pembrolizumab in the first one, and atezolizumab in the second. Ongoing phase 3 Mermaid 1 trial using here also personalizing approach to adjuvant immunotherapy. And you see the study design and using the ctDNA to identify the patients with high risk of post-operative cancer. We have no data on the results of this study. Positive adjuvant EGFR TKI trials are very important in early disease. So we have adjuvant Sitong trial. It's a Chinese trial using gefitinib or vinorelbine platinum, randomized cases with the primary endpoint, disease-free survival, and secondary endpoints as usual, overall survival, 5-year overall survival, etc. And positive adjuvant EGFR TKI trial in the Sitong is found in this slide. You see here that for the disease-free survival, phase 3 and the hazard ratio was 0.6, so the p-value very high for the gefitinib. And when the erlotinib was used, again, the hazard ratio was high and the p-value was very significant. When you come to the updated 3 years and 5 year disease-free survival, it is still significant, but definitely it's much, much less than before. And for overall survival of ITT population, unfortunately, the hazard ratio became 0.92 and the p-value was no more significant, it's 0.674. The second study, important study, is the ADORA study. And ADORA is a phase 3 double-blind study. And this is the design of the study proving that the patient have to be completely resected from stage 1B, 2, or 3A with or without adjuvant chemotherapy. And of course, having mutation EGFR. And this will receive either osimertinib or placebo, and then to be followed up. So the primary endpoint is disease-free survival in patients with stage 2, 3 disease. As you see in the slide, osimertinib, the hazard ratio 0.17, 0.17 with a p-value 0.0001. We have never seen this degree of differences between the targeted therapy and other. So disease-free survival, again, by stage, meaning that in 3A was a very important one that benefited from the trial, with a hazard ratio of 0.12. And a 2-year disease-free survival, 88 versus only 32 for the cases receiving placebo. So this is a very, very important study and published. But we have unanswered questions. Which patients need adjuvant targeted therapy? Which generation of EGFR TKI is the best? What is the optimal treatment duration of adjuvant EGFR TKI? And which adjuvant regimen is the best for EGFR mutation patients? So we have what to say is select phase 3 adjuvant trials with PD-1, PDL1, and other immune-targeted therapy in non-small cell lung cancer, constituting of using nivolumab in the Alchemist study, atezolizumab, as you showed before, in the IMpower 010, durvalumab in BR31, pembrolizumab in Keynote 09, etc. And these, most of these studies are still under evaluation and did not come to approval. So the conclusion of the resectable stage 3 non-small cell lung cancer, resectable stage 3 non-small cell lung cancer is treated with curative intent, but is associated with high risk post-surgical tumor relapse. Multiple trials are currently underway to evaluate the incorporation of targeted therapy and immunotherapy in the perioperative treatment of stage 3 non-small cell cancer. So adjuvant osimertinib is the first targeted therapy with regulatory approval in resected non-small cell lung cancer based on superior survival benefit in resected EGFR mutant lung cancer. And recent data from the neoadjuvant checkmate 816. And adjuvant IMpower 10 trials are practice changing, and data shows a substantial benefit of incorporating immunotherapy in perioperative therapy of resected non-small cell lung cancer, with particularly impressive results in patients with stage 3A disease, as we showed. And the development and the standardization of biomarkers for risk stratification and predicting the response to novel agents is needed to optimize the therapy and to achieve the goal of precision medicine in lung cancer. Now coming to the unresectable stage 3 non-small cell lung cancer, unresectable stage 3, as you see here, meta-analysis of concurrent versus sequential trials using chemotherapy and radiotherapy for this stage, unresectable stage 3 disease, proves that for the sequential chemoradiotherapy, the median survival was 13 months and the 5-year survival was only 10%. While concurrent chemoradiotherapy, the median survival was 25 months and the overall survival was 15%. So what is now usual or standard to be used in stage 3 unresectable is the concurrent chemoradiotherapy. So what is new after this? These are the studies of 10 years that failed to modify or improve our standard of care of chemoradiotherapy in patients with unresectable stage 3 non-small cell lung cancer. They used the docetaxel after chemoradiotherapy and it failed, docetaxel and platinum and it failed, gefitinib and also it failed, consolidation with cetuximab and it was not of value, even erlotinib was not effective. So all these trials were negative and did not improve the outcome after concurrent chemotherapy, chemoradiotherapy for the patients with unresectable stage 3 non-small cell lung cancer until we have our Pacific study. And what is the rationale for this Pacific study? Radiation upregulates tumor cell PGL1 expression in preclinical models, and increased PGL1 expression is found after radiotherapy in marine models, and there is definitely a synergy between radiotherapy and immunotherapy. So the Pacific regimen here is the mechanism of action. After chemoradiotherapy, you give durvalumab. And here, durvalumab will reverse the immune suppressor and leads to a systemic anti-tumor response. This is the study design of the Pacific trial using unresectable stage 3 non-small cell lung cancer without progression after definitive platinum-based chemoradiotherapy, at least 2 cycles. And this was followed by either durvalumab or placebo. And durvalumab was given between 1 and 42 days with the primary endpoint, progression-free survival, and then overall survival. A Pacific baseline characteristics will show that all the differences between the group of durvalumab and placebo is very, very well balanced between the 2 groups for randomization. And here also, baseline characteristics prove that even if the patient did not receive chemotherapy or received chemotherapy, both of them will benefit from the Pacific trial. And 3-year overall survival follow-up outcomes consistent with overall survival primary analysis. And here you see the data cut off of the patients with the hazard ratio 0.69 and the data cut off 2 with a hazard ratio 0.68, very similar for disease-free survival. There is definitely more than 30% reduction in the risk of death. Median overall survival is not reached in the Primary endpoints, as we said, is progression-free survival. And progression-free survival, as you see from this slide, at 18 months, progression-free survival is 49.5% versus only 26.7% for the placebo group. And for exploratory endpoint, as the data cut of the patient, the overall survival at 48 months was 49.6% versus only 36% for the placebo group. Again, you see here the PFS at 48 months, PFS 35.3 versus only 19.5%. Again, for the ASCO 2021, updated 5 years overall survival for the study, and you see clearly that the difference is evident, and the durvalumab will give you 42.9% probability of overall survival versus only 33.4% for the other group of placebo. And again, from the ASCO, looking at the progression-free survival, we have at 5 years, 33.1% versus only 19% patients living in this group. Updated overall survival in the subgroups of the patients, as you see, it's very, very well seen the difference between the durvalumab versus the placebo, and definitely durvalumab was better than the other group in all subgroups for the patients. Important to know that even PGL1 testing was not done in the initial study, and also this was for the EGFR and now, although randomization occurs from 1 to 42 days, it was found that the patient had received the chemotherapy and followed to durvalumab within 15 days were the best. And the anti-tumor activity of Pacific trial shows that you have the durvalumab 28.4 responders versus only 16% responders for the other group. And looking for the safety, as we are using immunotherapy after chemo radiation, and we are very skeptic about hearing that maybe pneumonitis will increase or so on, you'll find that the leading for discontinuation was okay, 15.4 versus 9.8 for the placebo group, and the grade 3 to 4 toxicity was 3.6% versus only 3 in the placebo, so very similar to each other. And the very important question was about pneumonitis, because we can have radiation pneumonitis and we can have pneumonitis of immunotherapy. So the difference was like 34% versus 25% for placebo. And this is the price of what we do and what we care for. Not only that, but the most frequent adverse events is seen in this table. We have the cough, we have the pneumonitis and radiation pneumonitis, and we have the fatigue. So we take care while giving this durvalumab. Conclusion of the Pacific study is durvalumab demonstrated statistically significant and clinically meaningful improvement in overall survival versus placebo in the ITT population at the hazard ratio 0.68. An improvement in PFS and the time to distant metastasis and incidence of new lesions is definitely not similar at all between durvalumab and placebo in favor of durvalumab. And durvalumab was well tolerated with no newly safety signals for immunotherapy. So Pacific is the first study to demonstrate a survival advantage for unresectable stage Non-small cell lung cancer, supporting the Pacific regimen with chemoradiotherapy followed by durvalumab as standard of care. And now you see again from the NCCN guideline proving that if you are this unresectable stage 3 group, you have to give definitive concurrent chemoradiotherapy, and this is category 1 level of evidence, followed by durvalumab, and this is also category 1 level of evidence. And I thank you very much for your attention. Thank you.
Thank you very much, Dr. Rabab, for this comprehensive talk. The next, we're short of the time, and the next talk will be an update in the management of extensive stage small cell lung cancer. Our guest speaker is Dr. Mirvat Mahrous. She's an associate professor of oncology and oncology consultant at Prince Sultan Military Medical City in Riyadh. Dr. Mirvat, welcome, and the floor is yours.
Thank you very much, Dr. Yasser, for introducing me, and it's always my pleasure to be with the faculty in King Fahd, King Abdullah Medical City meeting. Congratulations for the eminent faculty and the excellent talks. And my talk, I would like to extend my thanks first to Dr. Walid Baja and also Dr. Sharif and Dr. Abdullah Zahrani and Dr. Ahmed Tashqand, all the team in King Abdullah Medical City. Thank you very much. My talk will be updating the management of extensive stage small cell lung cancer. And we know that small cell lung cancer, it's one of the worst and still unmet need, specifically that we do, even it's a small percentage, it's uncommon disease, 15% only of lung cancer patients, and the majority is non-small cell. However, the small cell, we are stratifying this type of the disease to limited and extensive stage. And the small cell, even with all the advances and all the medication, is still totally unmet need. So this is the outline of my talk, treatment and advance in small cell lung cancer. Two landmark studies, which is the IMpower 133 and CASPIAN study, and we do have the update for both studies. And do we have any recent approval? Do we have any future going regarding this disease? We'll give, we'll come to this in a second. So why is small cell, it's unfavorable disease? And most of the time we have, once we have a patient, you know that those patients, they were coming and they may respond. And then you will find that those patients, they are not, they will relapse or progress. And most of the patients, they presented with extensive manifestations or extensive stage. So small cell lung cancer, what is the challenges? It's a poor cousin for lung cancer, multiple failed studies, no improvement in overall survival since 1990s, good upfront overall response, as once you give the patient chemotherapy, they are responding. So in a few months, you can find that this patient, that they relapse or having brain mets or distant metastasis. And this is the scenario for most of the cases. So the overall survival of 10 months. When you look at this, you will find that the small cell lung cancer patients, as we are pointed out, most of the patient extensive stage, you can see that this category is stage 4 disease, and this is about 70% of the small cell. And this is a reality actually. And the limited stage for stage 1, it's only 4%, and stage 1, it's 1%. The majority of limited stage is 25, and this ranking on the possibility that this patient can go for surgery or concomitant chemoradiotherapy, and this is beyond the talk of today. So the characteristic of a small cell, why it's considered aggressive. Usually the neuroendocrine tumor undifferentiated type, those patients have aggressive behavior, and this specified for the small cell patients, and even neuroendocrine in prostate patients, in the GI and in the lung as well. But still, we don't know exactly how to treat this patient as a driver mutation, because we consider lung cancer is the best example of how to treat patients on a precision medicine. But still, for the small cell and the neuroendocrine tumor undifferentiated type, we are treating them with chemotherapy as a backbone, with some improvement regarding the IO therapy. So how about this patient? Most of these patients, they are heavy smoker. They are highly responsive to the treatment, but most responses are transient. So when we look here, we found that since 1985, we started with the cisplatin etoposide. Looking at down the road, you will find that the cisplatin etoposide is still the backbone since 1985. And between that, almost 10 years, you will have the topotecan with very dismal response rate for relapsed patient, and the possibility of putting the PCI for the limited stage or giving radiotherapy for this patient as a hyperfractionation. And you can see that this is very comparable with other diseases. This is very a small amount of medications in this part. The immune therapy, since the introduction of the IM Power 133 in 2018, it was a breakthrough at that time regarding immune therapy. But however, we know that it wasn't much, but it was breaking the ceiling of the and breaking the frozen part regarding small cell. You can see that in a year, it's almost 12% difference. And when we look at the 24 months, you can see that almost double. It's a 14 versus 22. So why this patient they are not responding to? Actually, unfortunately, small cell even non-expressive for the PD-L1, and they try to check about 94 patients of a small cell. They found that a majority of this patient they are non-expressive, and you can see here in this slide that the majority, the expression, it was only 18.5% of this patient, almost less than a quarter of the patient they can be expressive. And this may be as an answer why this patient they didn't have a durable response like a lung cancer for IO therapy. And even in the other part, when I look at this graph here, which is very familiar, in this one, you can see that it's one of the immunogenic diseases. However, it's non-responsive as well, with high tumor mutation burden. The point that it was presented last year regarding small cell, that small cell lung cancer is not one disease, it's a multiple, and there is subcategories. And some of the small cell actually, which is called the inflammatory type, they categorize a small cell to 4 subtypes, and the most one, which can be responsive to the immune therapy, which is the inflamed one, and this is category only 17%. And we have to know that this is not validated. We don't know exactly who is the patient can be responding, but this is a step that we are categorizing the small cell, and sometime at some point we make recognize the patient who will respond to the IO therapy or different treatment as well. And just give you a signal that they did the multivariate analysis, and for the patient who expressive to PD-L1, this is it can be for this one of the main factors for the patient as a prognostic and predictive factor as well. So we can see that the predictive factor for the response and the overall survival, the performance status and stage, and the third one down the road, it was the PD-L1. So this is considered a good signal that those patients, they may responding. However, it's not a clue, because some patients, they can respond, they can have expression to PD-L1, and the entity of the disease itself as an aggressive disease, those patients can relapse in between. The first study, which incorporate the IO therapy to the chemotherapy, it was presented by Lee Horn from Memorial, And the first presented at the WCLC in 2018 with a median follow-up almost a year, and updated in in ESMO 2019 and with follow-up almost 2 years regarding the IMpower 133. So the IMpower 133, it's a landmark study. It's a phase 3 double-blind randomized placebo-controlled, and it included about 400 patients. The patient randomized to 1:1, and they included patients no prior systemic therapy, and CNS patient asymptomatic were included as well. The stratification factor, it was the 6 echo performance status 0 to 1 and brain tests. The patient randomized 1:1 with induction therapy, 4 cycles of chemotherapy plus atezo, and then maintenance atezo as experimental arm. And the standard arm, it was chemotherapy backbone, which is the cisplatin etoposide, and PCI was per standard of care of our physician discussion. It was not mandated, which is some of the element which is a little bit different than the Caspian study. The maintenance was for atezo until disease progression or loss of the clinical benefit. The primary endpoint, it was overall survival, and the secondary endpoint, it was objective response and duration of response. The study met the primary endpoint, and we can see that the study included mainly white patients, and most of the patients were performance 1, and most of the patients were former smoker as well. One of the elements was included in this study. It was analyzed, which is the tumor mutation burden. We know that the small cell is high mutation burden. And here we can see that more than 10 mutation megabase, about 60% of the population, and a quarter of them more than 16 mutation base. However, we didn't see that has an impact on the patient, and we'll come to this in the subgroup analysis. So the study met the primary endpoint, and you can see that the first year, which is 12 months, it was 39 versus 51, and 18 months, it was 21 versus 34, and the median overall survival, it was 12.3 versus 10, which is almost 2 months, and the hazard ratio 0.76. Again, it was only that those patients, we don't have much for them. And when we look at this graph, we found that the benefit started after 6 months and then separation of the curve. And once a patient, they have a response, and even at the end of the curve, you can see that it's a little bit coming down together. When we look at the PFS, you can see that the overall survival was better than the PFS as numbers. You can see that it was 30.9 versus 22 after 6 months, and in a year it was 12.6 versus 54, 5.4, and the hazard ratio 0.77, and you can see that the p-value, it's 0.2. Yes, it is significant, but again, you can estimate from the picture of the curve that there is some patients, they are not benefit from the treatment. In the subgroup analysis, you can see that all the patients, they are benefit from the treatment, and however, we can see that the patient with brain mets, they are not still on the side of the atezo. However, we can see that the patient without brain mets, they can have a better outcome from the combination. We know that the IO doesn't cross the blood-brain barrier, and this considered a signal that for the patient who did not, who have brain mets as well. There was updated analysis by Stephen Liu from Comprehensive Cancer Center in Georgetown University, and you can see that for the LDH and the metastatic side and the echo performance status, and this is all has an impact on the patient and the duration of response and overall survival. And what was a conclusion that adding the atezo to the chemotherapy, improving the outcome of the patient regarding the response rate, PFS, and the overall survival as well. Another study which came 1 year later after the IMpower 133, which is the Caspian study. It was presented by Bazeras from Spain. And the study was done the same fashion as inclusion criteria for the patient with extensive stage. And you can see that they included a third arm, which is the dura plus tremi plus the chemotherapy. And in the meantime, they have 6 cycles for the standard of care versus 4 cycles for the treatment, and the PCI was not allowed for the patient under IO therapy. The primary endpoint, it was overall survival, and PFS response rate, it was the secondary endpoint. The overall survival, it looks like the same, however, with some difference, small differences, specifically that for the 24, we can see that's 14 point, it's almost 15 versus 22. And those patients, again, start to respond or give the difference started after 6 months. And for adding the tremi plus the dura, we can not see any benefit, and it's coming together. And in the meantime, there was updated data as well in ESMO last week. And we can see that those patients with the durvalumab plus EP here for the 24 months, it's 2.9 versus 11 for the PFS. 3 years overall survival update was the dura plus chemotherapy. And you can see this was presented again last week. And you can see that for the 3 years, it's 5.8 versus 17.6. And the p-value is striking 0.003. And you can see that those patients who are responding initially, they continue the response, and you can look at the tail of the curve, and you can see the separation between the chemotherapy and the chemo plus IO. In the subgroup analysis, we can see all the patients, they benefit from the treatment, and even for the patient with CNS metastasis, we can see that they have a benefit comparable to with patient without. However, it was only 55 patients, and we cannot draw any conclusion, but it gives a signal. And in the meantime, I just wanted to remind you the study was not included PCI for the patient with the IO therapy. And this means that those patients, they may have a benefit regarding the systemic control, and maybe there have some benefit as well for patients with brain metastasis. Regarding the dura plus tremi, you can see that it's a 5.8 versus 15.3, and this was compared with the chemotherapy as well. I couldn't see that there is a much difference between if you are using the quadritherapy versus the single agent of the dura. I think we need to consider just only the dura other than using another CTLA-4, we cannot see there is much benefit. However, in the subgroup analysis, we can see that those patients, they are benefit all from the treatment. Definitely the NCA guidelines and the ESMO endorsed the IO therapy as a first line, and now it is the standard of care for all the patients with a small cell extensive stage to receive IO plus the chemotherapy, either atezo or dura. Both mirror image studies. However, the durvalumab study have update regarding the 3 years with some benefit as well. Other checkpoints as well, I will not spend so much time regarding this. This was negative study regarding Nivo plus IPI or Nivo plus chemotherapy as a first line. And in the keynote, in the phase 2, it was positive regarding the PFS. However, in the ERTC study, which is presented again last year, we can see that it's a negative study. And I think Nivo and the Pembro has no role now in a small cell patient. And here another study for the Nivo, and this is phase 2 study. I think we need just only to rely on a phase 3 study, and we do have 2 agents at the time and consider it. So like a summary for first line extensive stage, we have some future regarding the anti-TIGIT plus atezo and Ventaclox plus atezo as well. For the relapsed small cell lorlatinib is it's another agent, and of course we do have the liposomal irinotecan. I think lorlatinib has FDA approval last year, and this was a study was presented by Eloy Pazeras again from Spain, and the study it was for lorabectin for the patient with relapsed small cell lung cancer patient, and they enroll about 100 patients. And you can see that those patient was heavily pretreated with CNS involvement as well. And you can see the duration of response, it was 5.3. And we do have stable disease, about 33% of the population, and partial response. And this is the first time for a relapsed patient. You can see that we do have such thing. And in the meantime, in the study, they stratified the patient to sensitive and resistant. And as you are expecting, the sensitive patient 6.2 versus 4.7. And this patient, they have a good outcome comparable with the patient who did not. Tumor size, one of the elements as well, we can use it as an estimate for the patient and the assessment. And most of the patients, 65% of the patients, they have a decrease in the tumor size. But we cannot rely on this because we have to have overall survival and PFS as a main element. And when we look at the overall survival sensitive versus the resistant patient, you can see that the sensitive patients have a significant comparable, and it's from the start, you can see that those patients have a good response comparable to the patient who did not. So lorabectin showed an encouraging efficacy as a second line, and now we do have as a second line in small cell lung cancer with a response rate 35% and anti-tumor activity response rate about 45, comparable with topotecan and what we have. However, the most common side effects is the nausea and neutropenia, and it's a FDA approval last year, and can be considered for the patient with a small cell with a dose of 3.2 milligram. And I think we don't have much options regarding small cells, so it's also endorsed in the NC guidelines. And as the summary, first line for small cell lung cancer, the atezo or durvalumab based on the iron power 133. We know that the small cell patients, they are responding initially and they relapsed shortly after. And I think we still consider unmet need in this area, the subcategory of the small cell and the subclassification. It can be a lot of future involvement as well. Thank you very much for your attention.
Thank you very much. Marvelous talk, Dr. Mervat. We're running a short of time for the next session, but probably, Dr. Walid, we can accommodate a couple of questions. We have a question from the audience for Dr. Abdullah. Is the liquid biopsy suitable for accurate diagnosis of adenocarcinoma?
Thank you so much. When we speak about liquid biopsy, the role of liquid biopsy is the current practice is mostly, I would say, at initial diagnosis, and this is not for everyone, and especially for those what we call them the patient where they have insufficient tissue, and this is not really quite. This is something common. I would say it's probably 15 to 20%, even in larger institutions. So definitely, the tissue is a must when it comes to initial diagnosis to know whether it's small versus non-small, squamous versus adenocarcinoma. But sometimes we run into an issue of the tissue, and that's something we do see it in our real practice. And when you do liquid biopsy, it's just to have or to avoid repeat biopsy in a situation like that. It's not quite sensitive, and that's why if you have negative liquid biopsy, I would say probably you need to do probably one more or probably repeat a tissue. That's something we need to consider. That's probably the first indication. The second indications, and that's probably I highlighted in the talk, is tracking for the resistance. It's something we do see it in a situation where we have approved agent in the second line, EGFR and ALK and so on. So definitely is not replacing the tissue. It's probably addition to the tissue, especially in the for the insufficient or avoiding repeat biopsy in a situation where it might be difficult.
Yeah, great. Thank you very much. Dr. Walid, do you have anything to add?
I have a question for Dr. Mervat. What about the consolidation radiation, thoracic radiation post chemo and immunotherapy for small cell lung cancer. Before we are giving like BCI and plus minus thoracic radiation for those patients treated with chemotherapy. Still, we are going with the same?
Thank you very much, Dr. Walid. This is a very important question. Regarding the consolidation, we have to stratify the issue first. For the limited stage disease is different than the extensive stage. So the extensive stage, this patient, they came with metastatic disease. So if you are giving them the treatment, so the point of the consolidation radiotherapy for a patient responding to the treatment can be an option as a tumor control. However, this is not standard of care because you are treating the patient on systemic base. So you are giving them the 4 cycles of treatment plus IO, and then you maintain. In responding and sensitive patient, you can go for consolidation as well. And this was documented, by the way, in the 2 studies. There is about 10% of the population in the IMpower and about 15% in the Caspian study. They had local control regarding the radiotherapy for the tumor itself. And again, this is part of the sequence and physician discussion, but this is not, it was in the study or it was not included because for the extensive stage, usually we are not giving consolidation.
Dr. Mervat, let me ask another complementary question. سؤال دكتور وليد. From the subgroup analysis of IMpower 133 and the keynote 604, patients with brain metastasis, they did not deliver that significant benefit from the immunotherapy.
Yes.
On the other hand, from the checkmate 331, patients with liver metastasis or low LDH, those patients who benefited more from immunotherapy. Now, can we put all these subgroups into one group just to categorize patients a priori, those who might benefit from immunotherapy and those who might not benefit?
Yes.
Would you take that into clinical practice?
Well, I cannot take this in the clinical practice because first of all, you were talking about first the brain metastasis, and we do have in the IMpower 133, those patients, they were not benefit from the, or have less benefit for regarding the brain mets. And we know that from the start that the IO doesn't cross the blood-brain barrier. And the brain mets in a small cell patient, we know there is a difficult disease. And brain mets overall in all disease sites, except for the driver mutation patient, they have a dismal outcome comparable with the other. So back to your point. We do have the IMpower, there was those patients, they were not benefit from the IO therapy. However, in the Caspian study, when we look at the subgroup analysis for the patient with brain mets, we found that they were responding, they were benefit from the treatment. And it was a question even that why those patients with the atezo, didn't have benefit from the treatment and they have a benefit from the dura. We don't have a clue regarding this, and even the investigator was elucidating the idea that it may be tumor control, it's a systemic control for the disease, and the second element, they may be that the patient with a brain mets, they have disturbed blood-brain barrier, and so they have some penetration. They didn't give us a conclusion this because it's only 55 patients regarding the dura, and you don't have even the concentration regarding the CSF for this patient, so you can say that the dura have a higher concentration comparable with the other. Back to your other point regarding the liver mets, yes, the liver mets and the patient with LDH, low LDH, it's one of the predictive factors. So the patient with brain mets, they are the worst outcome, and the liver mets followed by the adrenal and bone. Those patients, they can responding well to the treatment comparable. And even not all the patients with liver mets, I mean, they are pointing out that they have a tumor comparable to the rest of the liver as well, so not heavily affected patients.
Thank you very much. Thank you.
Thank you.
I wonder if there's any other question.
I can't see the window of the question. There is like 2 questions remaining. But I would like to ask Dr. Abab if she's with us. Is it the time to start the adjuvant immunotherapy, and how to select the patient would be benefit from this approach?
Yes, it is time to start to treat with osimertinib for the ADAURA trial in the early cases of non-small cell lung cancer having mutation in EGFR, and this is evident from the study. You will see that the difference is very well taken between the cases that had received the osimertinib versus those that did receive only placebo after chemotherapy or without even chemotherapy. So I know there is no such overall survival up till now, but it is taken and very well taken even in the NCCN guidelines and everywhere, that this is very, very promising, and we have to start treatment our patients so long that we are having this mutation of EGFR, and that we can give osimertinib for 3 years after chemotherapy or without chemotherapy. Yeah.
Thank you, Dr. Abab. The last question for Dr. Merfat. Is there any future role for PARP inhibitors in small cell lung cancer?
Well,
this question from Anas Al-Ghazi.
Okay, it's a very good question. There is one of the clinical trials so far for the PARP inhibitor. It was included as well, but again, there is about more than 250 clinical trials for different ages, and we don't know that this patient can be BRCA positive or not. But it's just only one of the trials, but we don't have a clue regarding any results or any data.
Thank you, Dr. Merfat. Dr. Samir.
You are muted, Dr. Samir.
You are mute.
I'm saying, Dr. Walid, are you ready for your satellite talk? Or we can adopt another question, Dr. Rabab.
It's okay, proceed.
But Dr. Rabab, a very interesting question. Now, we know patients with metastatic lung cancer and have those who have a PD-L1 positive plus EGFR positive, they do not benefit much from the immunotherapy. And actually, it's not reimbursed. Can we take this principle? Can we take this principle into stage 3? Do you test patients for EGFR before durvalumab?
Actually, for the metastatic cases, whenever we have a target like EGFR or alcohol, so on, it's not wise at all to start immunotherapy. We start with the targeted therapy. And when there is resistance, we do another tissue biopsy and see what is happening. But it's very wrong to give any immunotherapy, even if the immunotherapy PGL1 is 90% or so. But for stage 3, the situation is different because we are depending on the Pacific trial. And in the Pacific trial, they did not think about PGL1, and they did not put any they didn't care about the EGFR or ALK or any target marker. So we took it as it is, Pacific study, and the response is very well. The PFS is very good. Overall survival for 5 years is even good. And we have the everything subgroups of patients, and everyone is responding or everyone is beneficial from the study. So this is the situation up till now. Of course, we can do the EGFR and we can do the PGL1 and start to separate the patients and see what we can do, but this needs other studies.
Thank you. Thank you very much.
Thank you. I would like by the end of the session to thank Dr. Abdullah Twergi, Dr. Abab Jafar, and Dr. Narfat Mahrous, and also my colleague, the co-chair, Dr. Samir, for the interesting session. And thank you all.
Thank you very much. Let's see.
Assalamu alaikum wa rahmatullah. Back to back. The next session will be Symposium BMS. The first, I would like to thank organizing committee and BMS for inviting me for this presentation and the lecture about the innovative approach in treatment of first-line metastatic non-small cell lung cancer, update about Checkmate 9LA. As we know, the lung cancer is a leading cause of cancer-related mortality worldwide, and more than 80% of lung cancer are classified as non-small cell lung cancer. Although targeted therapy have redefined treatment option for patients with positive molecular alteration like EGFR, ALK, ROS1, BRAF, and others, these therapies are ineffective in those whose tumor lacks such genetic alteration and who compromise the majority of non-small cell lung cancer. However, immunotherapy has become integrated into the treatment of such patients, which has led to improving survival and quality of life. The incidence, mortality, and prevalence of lung cancer in Saudi Arabia in 2018, we have like 923 new cases annually, and it accounts for 4% of all cases of lung cancer. And the mortality, it's like 779 deaths annually. It's quite high. It's account also for 8% of all cancer deaths. And the prevalence, the 5 years prevalence for all ages around 3%. And it's based on the stage, but if in the early stage of non-small cell lung cancer, as we can see here, the localized disease, the 5-year survival only 55%, which is poor. And this getting worse with the distance mets, the 5-year survival 4.5. And this data from the earlier before the immunotherapy and targeted therapy based on the platinum-based chemotherapy. And it's one of the leading cause of death, and the death annually account for like 1.5 million cases per year. It's equal to colorectal, breast, and prostate combined mortality per year. And it's a different heterogeneous diseases. The lung cancer, it's not only one disease, and it's classified to non-squamous and squamous histology. both 60% of adenocarcinoma and 80% of squamous cell carcinoma are associated with known mutation. Not all those mutations is targetable, but there is considerable number of those mutations targetable. As we can see here, the squamous, there's EGFR, ALK, and MET mutation account only for less than 5%. But in the adenocarcinoma, it's different. The EGFR account for 15 to 20%, ALK 3 to 7%, ROS1, and HER2, BRAF, it's all like 1 to 3%. MET and RET, it's around 1%. And all those mutation with targetable drug. There is an ongoing need for new treatment and therapeutic modality for patients with advanced non-small cell lung cancer, because the 5-year survival is poor, as we mentioned, it's around 4%, and worldwide is estimated 8.2 million deaths due to cancer occurred in 2012. Immunotherapy has established, and there is multiple action for the T-cell checkpoint and co-stimulator pathway. It's divided to activation and inhibitors pathway, and most of the available immunotherapy like CTLA-4 and PD-1 are acting on inhibitory pathway. This is the mechanism of action of the nivolumab. It's like on the PD receptor, and it's well known how to act, and also the ipilimumab as acting on the CTLA-4 receptors, and it has complementary and synergistic effect for both nivolumab and ipilimumab. Ipilimumab shown an overall survival plateau at 3 years analysis by phase 2 and phase 3 trial, with median overall survival, it's around 11.4 months, and 3-year overall survival, it's 22%. And this potentially synergistic immunotherapy that together help drive enhanced anti-tumor response greater than with either antibody alone. NIFO and EB offer dual immunotherapy durability and deliver a chance for long-term survival in multiple tumor sites, as defined by in melanoma and renal cell carcinoma, and recently in the metastatic non-small cell lung cancer. And the protocol of nivolumab plus ipilimumab plus 2 cycles of chemotherapy now approved in the first-line metastatic non-small cell lung cancer lacking targetable mutation. And the presentation today about the update of and 2-year update from the Checkmate 9LA. As we know, there is multiple option for the first-line metastatic non-small cell lung cancer for those patients lacking targetable mutation. And this not based on the histology and the PDL expression. And we can divide them according to the PDL expression. For the high PDL expression, 50% or above, we have the option of monotherapy with immunotherapy alone, either pembrolizumab or atezolizumab. And for those patients with less expressor, less than 50% of the PDL, combined modality chemotherapy and immunotherapy is a standard of care. And also, this approach can be given for selected patients with high expressor, and also for negative PDL expression, the immunotherapy and chemotherapy is the standard of care now. For the Checkmate 9LA, the combination of the nivolumab and ipilimumab, which have distinct but complementary mechanism of action, has shown improved long-term overall survival benefit and in advanced metastatic non-small cell lung cancer, melanoma, as well in the renal cell carcinoma. In the randomized trial of Checkmate 9LA, first-line nivo plus EB and limited cycle of chemotherapy, only 2 cycles, significantly improve OS, BFS, and overall response rate versus standard chemotherapy for cycle based on the histology of the disease. And no safety signal was observed. This regimen is now approved in the US, Europe, and several other countries as first-line treatment for adult patients with metastatic non-small cell lung cancer and no EGFR or ALK genomic tumor abbreviation. In this presentation, we are updating the efficacy and safety result from Checkmate 9LA with minimum follow-up of 2 years and post-hoc efficacy analysis in patients who discontinue nivo and EB and chemo due to treatment-related adverse effect. This is the design of the Checkmate 9LA. The inclusion criteria, as we mentioned, it's like stage 4 or recurrent non-small cell lung cancer, both histologic type, squamous cell carcinoma and non-squamous, and no sensitizing EGFR or ALK alteration, with good performance status and stratified according to the PDL negative or positive, 6 histology squamous versus non-squamous, and randomized to the nivo 360 milligram Q3 weeks with a small dose of ipilimumab 1 milligram per kg Q6 weeks plus 2 cycles of chemotherapy histologically based on the histologically of the disease. The control arm chemotherapy, the standard 4 cycle Q3 weeks, optional of pemetrexed maintenance for non-squamous non-small cell lung cancer was allowed, and the treatment continued till disease progression and acceptable toxicity or 2 years for the immunotherapy. The primary endpoint is overall survival and secondary BFS, overall response rate and efficacy by tumor PDL expression, and the safety. 2-year update treatment deposition and subsequent therapy. 719 patient randomized, 361 located in the nivo plus EB and chemo, and of them 358 patients received the treatment. And in the chemo group, 358 located and 349 received the treatment. 0% still receiving study by the end of the 2 years. 13% completed maximum 2 years of the treatment in the nivo plus EB and chemotherapy. Most of the cases, around 52%, they discontinue the treatment due to the disease progression, and 20% due to the drug toxicity. In the chemo arm, still 3% receiving pemetrexed as maintenance, and 29% completed 4 cycles of the chemotherapy. Here we can see the overall survival in all randomized patients. At the end of 24 months, there is a 38% versus 26%. 38% in the chemo and immunotherapy group still alive, comparing to 26% in the chemo alone, with median overall survival 15.8 months in the nivo, EB, and chemo, versus 11 months in the chemo alone, with hazard ratio 0.72. All the subgroup, it's benefiting from nivo, EB, and chemotherapy comparing to the chemo, including the liver metastasis, the bone metastasis, and the CNS metastasis. Here, the 2 years of progression-free survival and overall response and duration of the response. The progression-free survival was significantly improved in the NIFU, EB, and chemo group comparing to the chemo alone. It's 20% by 24 months, comparing to 8% only in the chemo group. And the median progression-free survival by month was 6.7 months, comparing to the 5.3 months in the chemo group, and the hazard ratio 0.67. As well, the duration of response, it was better in the NIFU, EB, and chemo group comparing to the chemo alone. And the response rate was 130. The median duration of response was 13 months, comparing to 5.6 months in the chemo group alone. And this based on the BDL expression, all the group, they are benefiting regarding overall survival, progression-free survival, and duration of response. Either the negative BDL expression, or they benefit from the NIFU and EB plus 2 cycle of the chemotherapy comparing to the chemo. Also, those patients with 1% and above BDL expression, they has the same benefit of NIFU, EB, and chemo comparing to the chemo. And the benefit goes, it's better, but much better with the high expressor group. For the safety and exposure, at the end of 2 years, the protocol NIFU and EB plus chemo, it's well tolerable and manageable side effect. Despite the long term of the immunotherapy for 2 years, the serious adverse event, it's for the any grade is 30 comparing to 18 in the chemo arm, and the grade 3 to 4, 26 comparing to 15 in the chemo arm. The median duration of therapy 6.1 months with the NIFU, EB, and chemo, and 2.5 months in the chemo group. In the NIFU, EB, and chemo arm, patients receive a median of 9 doses of NIFU and 4 doses of EB. And 93% of patients received 2 cycles of chemotherapy. Here, the most of the adverse event, it's in the first and second cycle of the chemotherapy, but the subsequent cycle from cycle 5 and 6, it's the side effect, it's less significantly. And here the efficacy in patients who discontinue NIFI and EB plus chemo due to treatment-related adverse event. Despite of considerable number of patients who discontinue the treatment, the response contain to I mean, there is good response instead of stopping the NIFU, EB, and chemo. By the end of 2 years, there is 54% of those patients who discontinue the treatment due to treatment-related effect still alive, comparing to 38% for those for the all randomized group. And the median overall survival by month for those patients discontinue the treatment due to the adverse event is 27.5, and 2-year overall survival 54%, and the response rate was 31%. Median duration of response after discontinuation is 14.5. And there is ongoing response for more than 1 year after discontinuation of the treatment. The summary, the 2-year overall survival in the first line nivolumab and ipilimumab plus 2 cycle of chemo was durable versus chemo 38 versus 26% in patients with advanced non-small cell lung cancer. BFS and duration of response benefit were also maintained with longer follow-up. Benefit with first-line NIVO and EB and 2 cycle of chemo versus chemo was observed across key subgroup, including by the BDL expression level, histology, and patient with CNS metastasis. No new safety signal were observed with longer follow-up, onset of most grade 3-4 adverse event in the NIFU plus EB and chemo arm was during the first 2 cycles of the chemo treatment. In post-hoc analysis, discontinuation of the NIFU and EB and chemo due to adverse event did not have negative impact on the long-term benefit seen in the all randomized patient. 56% of the responder who had adverse event leading to discontinuation maintained their response more than 1 year after discontinuation. This update result continue to support NIFI plus EB and 2 cycles of chemo and an efficacy of first-line treatment option for patients with advanced non-small cell lung cancer. This pre-specified pro-exploratory endpoint and measurement for the lung cancer symptom scales. The anorexia, fatigue, cough, dyspnea, hemoptysis, pain, all improved with the NIFU plus EB and chemo comparing with the chemo alone. And this is the protocol of the Checkmate 9LA. It's nivolumab 360 milligram plus ipilimumab 1 milligram per kg and 2 cycles of chemotherapy. The nivolumab given Q3 weeks and EB Q6 weeks and chemo Q3 weeks for 2 cycles and maintenance NIFU and EB for 2 years. And it's approved and FDA approved and in the NCCN guideline, the NIFU and EB plus 2 cycle of ipilimumab, it's a category 1 for advanced metastatic non-small cell lung cancer without actionable mutation and for all BDL expression, is it, I mean, either negative or positive or high. And this is the summary of the first line non-small cell lung cancer approved landscape. It's for all patients with metastatic non-small cell lung cancer. We have different options. We have the chemo plus immunotherapy. It's the standard of care, either pembrolizumab or atezo or NIFU plus EB and chemotherapy. For those patients with the BDL expression 1 to 49%, the pembrolizumab 50% or more, pembrolizumab or atezo monotherapy is the standard of care, and also the combined modality immunochemo still we can start it for those group of patients, and also NIFU plus EB and 2 cycle of the chemo. And for the high expressor only, we have the option of immunotherapy alone and immuno plus chemo. The squamous and non-squamous is different for the histology, chemotherapy based only. By this, I would like to thank you all. Any question?
Thank you very much, Dr. Walid. Very nicely presenting the update on this very important trial. I may start with a question, Walid. How do you make between these choices? I mean, in the first line setting, how do you make between chemoimmunotherapy or chemotherapy plus dual immunotherapy? You as a medical oncologist, how you choose between these options?
Thank you, Dr. Samir. It's a challenging question. Actually, it's for we can take the opportunity to see the BDL expression. For those patients with high BDL, 50% or above, we can save them from the chemotherapy and start them only on the immunotherapy, either pembrolizumab or atezo as approved medication. Although the chemo and immunotherapy, it's still a valid option. And but we can select the patient. There is no comparison for immunotherapy and chemo and immunotherapy in the first line setting in those patients with high expressor. There is a study, but it's not released yet. After the release of the result of this study, maybe we'll have answer. But till that time, I think for the high expressor, the immunotherapy alone for 50% or above PDL expression is the reasonable option. For those with the less expressor, less than 50%, immuno and chemo is the standard of care. And it's presented in the last ASCO. There's like presentation, they collect the 9 randomized trial, all the randomized trial taking the combo chemo and immuno for the less expressor patient. The benefit from chemo and immunotherapy, it's better than immuno alone. Also, there is there is the keynote 042 showed approved the pembrolizumab for those patients with positive PDL expression. But as we know, the benefit goes mainly for those patients with high expressor. And when they did subgroup analysis for those patients with 1 to 49% of the PDL expression, the magnitude of the benefits was not great. For the negative PDL expression, still we are going with the immunotherapy, with the chemotherapy, or immunotherapy as in Checkmate 227. This is what I have, if I answer your question, Dr. Samir. Dr. Samir, we can't.
I think it belongs to the previous session. Well, Walid, if official questions, and I can ask another question. Have you tried this combination? I mean, Nivo-Ipi and chemotherapy?
Actually, we have some like difficulty in the approval all this medication. In our institute, we approved only pembrolizumab in the first line setting, either monotherapy or combined with the chemo. Still EB, it's not formulary in our hospital, and we have to order it as non-formulary medication. And yet I didn't start this protocol, hoping we can solve this problem and start it.
My question كان حقيقة إنه if you have this protocol adopted in your institution, will you stop doing PD-L1 and you just smash all patients with Nivo-Ipi and chemo?
PDL, we are testing now all the patient.
No, but I mean, if you have this protocol, you don't need PD-L1.
Yeah, but also we don't have PD-L1 in the pembro plus chemo group. I mean, if I will start the combo protocol, I don't need the PD-L1. I can start.
You don't need it.
Negative, either positive. But still, we are selecting patients to save them from the chemotherapy, and we are doing the PDL for those high expressor. We are saving them from the chemotherapy and keep it for subsequent treatment option.
Yeah. Great. I don't know if we have any question from the audience.
I think we can conclude.
We can conclude, I think, yeah.
Okay. Thank you.
Thank you. Thank you very much. Thank you.
Thank you, Dr. Samir, and thank you for the all audience. Thank you very much.
Okay. Test.
Assalamu alaikum wa rahmatullah. Shall we start our last session for today, inshallah? We'll start the session by sentinel lymph node biopsy post-neoadjuvant chemotherapy, going to be presented by Dr. Roa Atiya. She is consultant breast endocrine surgery, King Abdullah Medical City. Mic is yours, Dr. Roa.
Assalamu alaikum wa rahmatullahi wa barakatuh. Bismillah ar-Rahman ar-Rahim. Thank you very much for the privilege of the podium, and thank you very much for invitation for such an eminent presentations. Without any further delay, I will go straight into the topic that it's been of a controversy throughout the last 2-3 centuries. We're here about the axillary surgery of neoadjuvant chemotherapy, post-neoadjuvant chemotherapy. Do we know it all? That was always the debate. My name is Roa, and thank you very much, the chair lady and the co-chair lady, for the nice presentation. Okay, so initially I would like to declare that I have no conflict of interest. I have no financial support or sponsorship, and if any materials being presented into this topic is our genuine original material, and the paper consenting were taken from the patients. These are the following outlines that I would like, hopefully, be able to cover over the coming few minutes. There was always and ever, and I think it's going to continue for another couple of decades, concerns regarding the feasibility of sentinel lymph node biopsy. The cohort of patients that will be addressed with such biopsies, the clinically node negative, clinically node positive patients. How can we enhance the sensitivity and specificity of these techniques? And finally, the timing for the sentinel lymph node, namely preoperative or post-chemotherapy or pre-chemotherapy. Always there was concerns regarding the feasibility of sentinel lymph node biopsy. Theoretically, and it carries some sort of a treatment, that there was concerns regarding the initial treatment of the chemotherapy of the patients. By all means, chemotherapy is crucial. You can't live without it, and it's the main player of the game. if we're going to give the patient neoadjuvant chemotherapy, it's going to create a status of inflammation that will end up eventually by fibrosis, as most of the histopathological changes that we have. Subsequently, that will lead, again, theoretically and emphasizing on this point, a non-uniform response to the treatment in the axillary node, causing an unacceptably high false negative rate for a sentinel lymph node biopsy post-NAC. This theoretically stands still. Now, am I mapping the proper sentinel lymph node? Whatever result I'm harvesting out is true. Let me convert this theory into a schematic representation that will make the things maybe quite easier. Let's consider this is a lymphatic channel loaded with a lot of cancer cells. And our colleague in the medical oncology will hammer it with a good, effective chemotherapy. What will happen afterward? This chemotherapy effect will initiate a media of immediate inflammatory and immune responses that ends up with a dysfunctional valve of the affected lymph nodes and lymphatic channels. What is the consequence of that? The consequence of that, if I'm going to map this lymph node, it will carry no ground. It will not reflect the original status of the disease. What unfortunately solidified this problem, the earlier results of the proposed sentinel lymph node biopsy after neoadjuvant chemotherapy came all over the place. If I could use this quotation. All the studies for this showed that identification rate with a very wide range of identification between 63 to 100 and false negative rate between 0 to 33. The only explanation of that this is an all over the place studies. This can't be true. So what happened? When we re-reviewed what happened in the 90s and early 20s about the proposed sentinel post-NAC, we found that there was no proper standardization of the patients who were involved. We were extrapolating results from a non-uniform cohort of patients. There was very wide variation of the patients who were included. There was sometimes bulky disease at presentation, and even more, there was persistent lymphadenopathy after NAC, which by all means should not include these patients. So, as a subsequent studies examined more well-defined patients, sustained established feasibility of the sentinel lymph node biopsy post-NAC. So, that was a concern and sustained is still correct until we verified more. What are the other concerns? There is a genuine concern, and it's still going active. How about if I started with a loco-regional disease, a disease that's bulky enough to give a clinical and radiological lymph node, and I decided this disease will not be cured by surgery alone? Go ahead and give a chemotherapy. You give a chemotherapy, it's absolutely pristine, and you come jumping up and down saying that it's the day. We converted these patients from clinically positive lymph node to clinically negative. I need to quote here, clinical positive, clinical negative is augmented by a radiological confirmation. So it's not only about the clinical presentation. How about the local recurrence? If I said that, okay, that's happy day, we call it ELFAT here, do a sentinel, it's negative, send the patient away. Will her local recurrence rate will be higher than those who were treated with a complete axillary dissection? How about if I leave behind a residual disease? And this is really annoying. You know what? If you leave a residual disease after neoadjuvant chemotherapy, that means you are leaving a nidus that's been hammered with an extensive amount of neoadjuvant chemotherapy for 6 or 8 cycles, yet it did not touch it. That means potentially we are talking about very aggressive nidus that's left behind, and it was not touched, and it gave us a false impression that we are happy day. So they were trying to quote back the data of the false negativity that we're taking from an upfront surgery. The acceptable data for false negativity is about 5 to 10% in an upfront surgery. And if you have such a data, that means your rate of axillary failure, or what we call it loco-regional recurrence in a follow-up of about 44 months is just about less than 1%. But this, we cannot sustain it through post a NAC. So what shall we do? There's a lot of concerns about this. I think the way to tackle this problem and study it stepwise is to have the fine balance. And you have to subset the things in a proper way so you can understand what are you providing to your patient. It's about providing a safe practice. Don't allow the patients to break down into profound metastasis because you left a very resistant disease behind, and find balance with reducing the morbidity and mortality related to unnecessary axillary dissection that has been seen once after the other. But what can we do? This is simply what we all have to do. It's about stratification of the eligibility cohort and stratification of the technique. This technique is doable, curable, helpful, working for you, but it's your call to stratify the cohort of the patients that you will offer them such a technique, and you use a very well-established technique for those patients. This is the way. Otherwise, you will slip into the false negativity and you will slip to the bad selection. It's always the case. I know statistics is very dry. Statistics is boring, and that's why we hate to go around it. But we have to tackle it in a more appealing way. If you're talking about a technique, this technique, and in order to reduce the negativity of it, when I stand confidently saying that I harvested the sentinel lymph node and this sentinel lymph node is negative, that means it's appropriately negative. I increase the specificity of this study. If I stand still and I said that I recognized the sentinel lymph node, I harvested it, I sent it to my colleague histopathologist, I increase the sensitivity of this. What can I do? It's always about the false negative. You leave something bad behind. How can you address it? The way to address this is a proper selection. Please don't offer a sentinel lymph node biopsy to somebody who has a bulky disease. Don't offer it to somebody there is inconcordance between whatever imaging modalities has been used or a clinical examination. Firstly, the clinically negative patients, the easy game part. Those patients from the beginning, they have, by definition, early disease, early breast cancer. The node were not involved. Clinically and radiologically, there is concordance that the disease is not touching the axilla. Why am I always referring to GENERA? GENERA is a very well-designed study. Among all the studies that have been conducted for the study of the sentinel lymph node biopsy post a neoadjuvant chemotherapy, GENERA was one of the best. It's very recent data, and the design of the study was very good. Basically, what did they say? They said, okay, I have a cohort of the patient. This cohort will be classified into clinically nodal negative, which means clinical and radiological, and pathological in one disease. The disease has been confirmed by ultrasound-guided FNA, and there is no mistake about cytology-proven involvement. What should we do about this? This group of patients underwent sentinel lymph node and axillary dissection, and that was the nice thing about them. Those people, they did only sentinel. They did not go with a concomitant axillary dissection, which lost the benefit. If I do a concomitant axillary dissection, how may I hold into the truth about the sentinel lymph node effectiveness? So only in case of mapping failure, or the sentinel positively come back as positive. So you embark on dissection. The end point, always and ever, the false negativity. And the secondary was very nice about a predictor. I need a predictor to tell me this person most probably will fail. Why he will fail or she will fail? Because of these points. Let's take it from there. This is their design. I will not take you through the little details about that. There was about 606 patients who were eligible to be clinically radiologically negative. However, there was some dropovers, not very significant, 17 patients initially and then another 14. The whole business in the bottom of the 419 patients. 400 received the neoadjuvant chemotherapy, went to their surgery, whatever it is, mastectomy versus wide local excision, breast conserving surgery. Afterward, they have had their sentinel lymph node without any further management. What happened? Among those patients, the sentinel lymph node biopsy was done and one axillary relapse has happened to those patients. Mind you, the follow-up time was more than 5 years. So I can stand confidently and say this approach is comparable to axillary dissection. صح؟ لأنه there is no local regional recontrol in a quite long time of follow-up. The identification rate and the false negative rate were not significantly different in comparison to those who had a concomitant axillary dissection. Okay? And these are the studies. I just kind of pack it all together to confirm and solidify the idea. The difference between GENEA and those all studies back from the NSABP 27 down to the MD Anderson Cancer Center, all of these studies were shared in one point. I will do a sentinel, and then I will do a concomitant axillary dissection to verify and validate the negativity. The GENEA said, no, we're not doing that. We've done it enough. And all the studies come back with a positive impact on these things. The meta-analysis was done twice, once in 2011, where 24 published studies, including 1,799 patients, underwent the sentinel followed by axillary dissection, and the harvesting rate was nearly 90% and the negative rate was 8.4. The same as again in 2015, where 1,500 patients across 16 studies were established again and gave close information. So finally, if you care, compare. This is the way. Don't come and tell me that your approach with a sentinel lymph node in a properly selected patient is not as safe as doing axillary dissection, because I am withdrawing your own data. The National Project of Breast and Bowel Cancer was the massive project that conducted in the United States. Very clear, no mistake. In the SAPPB 32, they were going upfront for surgery with axillary dissection with a sentinel lymph node biopsy. In the NSAPP 27, the same cohort of patients who received a sentinel lymph node biopsy after a neoadjuvant chemotherapy. Both ends, they were early breast cancer. Both ends were good to be established as sentinel lymph node biopsy. What are the results? Let's take it in here. Sentinel lymph was identified in 97% of the patients. False negative is 9.8. Upfront surgery, no alteration in the presentation with the neoadjuvant chemotherapy. While if I'm going to give a neoadjuvant chemotherapy and I want to address all the concerns that I mentioned 10 minutes ago, it will drop the sensitivity to 85% and the false negativity rise up to about 11%. Not bad, but confirming. So how can I give you a summary of recommendation at this point? The long-term follow-up of sentinel after systemic therapy does not lead to a higher local regional rate, confirmed by a lot of meta-analysis. For patients with clinically negative axilla prior to adjuvant chemo and neoadjuvant chemotherapy, accuracy rate are acceptable. Among the clinically negative patients undergoing breast-conserving surgery, the local regional recurrence is less than 2%, which is comparable to those who received axillary dissection. So there is further enlight in here saying that in aggregation, the neoadjuvant chemotherapy will allow us to kill out the micrometastases that might upgrade the patients if we go into upfront surgeries for those patients. Okay, so that was the main cohort. The nodal negative. Let's push the bar farther. Let's stretch our indication. Let's go and tackle the hive of B, the nodal positive patients. This was for 20 years, the no-no zone. Don't touch a patient and do a sentinel lymph node who has a nodal positive disease. What do you want? She has to have an axillary dissection. No, she doesn't need to have the axillary dissection if she was properly selected. Let's see that. Again, my love, GENEA. In GENEA, when they had the second cohort of the patient, they did something very nice. It's all about the prediction. Why make those people are more likely to fail their axilla while those they are not? She's locally advanced by definition, and this locally advanced. Because they did something brilliant. They did a multivariant analysis showing that the residual index tumor more than 5 millimeters is an independent risk factor of failure of the axilla. So before you embark on doing this, check the response of the index tumor. all the patients that they studied, they found that those who had a bad index tumor tend to have bad axilla. So for the patients with initial involved node with the negative sentinel after NAC, that means the patient showed a pathological response, relatively good pathological response. There was no lymphovascular invasion on them, and the residual disease was less than 5 millimeter. So absolutely, that's fine. And I can use this tool if I selected my patients properly. That was the second cohort of the patients. Again, 350 patients. There was the drops out, and the final was 103 patients where we have in here. Now we're coming to the Centina. Everybody knows Centina. Everybody's talking about Centina. It's very well designed, but there was a lot of drawbacks around Centina. Centina study is a formed studies about 103 centers across Germany and Austria between 2009 to 12. It ticks all the boxes. It has a strong power. It has a good selection, and many centers, eminent centers, were involved in there. As we mentioned earlier, clinical node status was assessed with the concomitance and concordance between the clinical picture and the ultrasound. The thing about Centina, they did not need to confirm it by an FNA, ultrasound guided FNA, which is quite different between them and the Genia trial. What happened? Okay. Eventually, the patient converted from clinically positive to clinically negative, and they were a good cohort, about 500, nearly 600 patients. But the detection rate was only 80. Shame. So what can we do? They improved the detection rate using a dual radiocolloid and blue dye compared with the radiocolloid again. And they raised the detection from 80 to 88% when we use a dual tracer. Okay, hold on. There's something good coming the way. The overall false negative rate was 14. Again, that's unacceptable. I want something goes straight to compare with the upfront surgery. The dual tracer has dropped the false negativity to 9% versus radiocolloid alone, which was 16%. More than that, the false negativity when we removed more than 2 and more 3 lymph nodes of the sentinel lymph node was 7% or less compared to the 19% of 2 nodes removed. And that's how the Centina looked like. I'm just kind of highlighting the part that we are looking at. All this cohort had the new adjuvant chemotherapy. They converted to a clinically negative lymph node, so the sentinel lymph node biopsy and axillary dissection, which is the bad downside of it in comparison to Genia. While those who did not respond or partially responded, they went upfront to axillary lymph node dissection. But one more to go. Now, the American College of Surgeon Oncology Group, they come with a strongly designed study, the Z10, pretty much similar to the design of the Centina, but here all the patients received NAC, all the patients received sentinel followed by concomitant axillary dissection. The primary endpoint always and ever presetted for a false negative rate of 10 or less. Unlike Centina, the conversion was not a must, because if we can get into, and I don't want to get into the side channels of that, they were doing this in concomitance with Amorous trial. So, okay, you don't need to convert completely from C positive to C negative, not mandatory, but was completed for those patients for the disease. What happened? What happened is quite pessimistic. With all these settling of the events, we find that the harvesting of 2 or more was no more than 7% of the cohort that been studied. And unfortunately, they were able to harvest only 1 sentinel lymph node from a 639%, representing 93% of the patient. And they failed to meet the predefined area of 10%. Okay, so we are back to square number 0. This thing is not feasible. Don't give it and don't offer it to the patients who are clinically positive pre-new adjuvant chemotherapy. And guess what? It was labeled as negative study. Centina and the American College of Surgeon Oncology Group Z10 was labeled as negative impact study and should not be replicated. Furthermore, parallel to it, the sentinel node biopsy following new adjuvant chemotherapy study Enrollment was pretty much similar, pre-definition for harvesting of more than 90% and false negative less than 10%. Pathological evaluation was a must. I should wrap up in less than 5 minutes. So what happened? I'll go quickly through that. The same things. They failed to meet the pre-setted criteria. It's negative study. What should we do? We should call it off? It's very pessimistic. Don't do sentinel lymph node on a patient who received new adjuvant. Hold on a second. Just hold on a second. Not always it's pessimistic. There's shade at the end of the tunnel. If we managed to get back into the first slide, stratification of the technique, then we will be able, I should not take more than 2 minutes, guys. Okay? Sensitivity and specificity. What should we do? Stratify your patient. Offer them a sentinel lymph node biopsy in a locally advanced breast cancer after new adjuvant chemotherapy if and only if you used a dual radiocolloid and blue dye tracer. Remove 3 or more sentinel lymph nodes. Immunohistochemistry has to be on board. Don't accept something less. Ask the histopathologist to do IHC on the patients plus the routine station. Consider isolated tumor cells as a part of metastasis. This disease has been hammered with 8 cycles of chemotherapy. You left something behind, and this something behind is sinister. Okay? Get use of the techniques for your beloved radiologists. They have the seeds, they have the wire localization, and that would be of a good benefit to you. Quickly through that. So, what can we recommend in here? It's reasonable to consider sentinel lymph node biopsy in patient clinically positive after a good clinical response to a new adjuvant chemotherapy. Dual tracer is a must. Effort should be made to relocalize your lymph node if you can. If you're not, then you have to harvest at least 2 to 3 lymph nodes. Exhaust your histopathologist in examining this lymph node. Okay, so if you've done that and you tick the boxes, then your local regional recurrence will not be as bad as worse than that with an upfront surgery. Okay, just a glimpse. This has been exhaustively treated with a new adjuvant chemotherapy. For those who've been treated with a new adjuvant hormonal, we don't yet have a consensus about that. Okay, now just a quick glimpse about the timing of the sentinel. Sentinel is good. Do the sentinel correctly, choose your patient, correctly choose your technique. When shall we do it? An upfront or no? The answer is no. Do it after the new adjuvant chemotherapy for zillions of causes. Number 1. If you want to do it pre-treatment, then it provides an accurate axillary staging because you did not manipulate the axilla. That makes sense. And okay, it identified the nodal negative patient who avoid axillary dissection from the get-go. It identified nodal positive patient who will need by default a radiotherapy afterward. But hold on, the major drawback of this thing is the following. It delays the initiation of NAC, God forbidden there's a wound healing. Most importantly, if you stage the patient as axillary positive and you give him the chemotherapy, then game over. You will not be able to restage this patient afterward, and it's a must to embark on axillary dissection. So don't do it. It looks nice, it looks doable. It's lovely to harvest a lymph node before NAC. But if you've done it, the patient missed the boat. Okay, so what I wanted into here, because we're already late, those who harvested this lymph node up front and then they went for a sentinel lymph node biopsy as per Sentina, what happened? The way to identify the lymph node was dropped down to unacceptable level, 61%, and the false negative rate was 52%. No way to accept such thing. It's not a viable strategy. Don't do it. Okay, so again, the early argument about using it to identify the cohort that need radiation. In fact, I will be more confident to call for radiation if there is a residual disease after NAC. Okay, so it's better to do the sentinel lymph node biopsy after NAC. And I'm sorry for going behind time. Thank you very much.
Thank you, Dr. Doa, for this very nice and informative presentation. We will keep the question at the end of the session, please, for the sake of time. We'll move to the second presentation, going to be presented by Dr. Tani Ghamdi. She is a woman imaging in King Abdullah Medical City. She is going to present about breast cancer screening in Saudi Arabia.
it's working now. Yeah. Thank you for the invitation. Thank you, Dr. For the comprehensive approach for the sentinel lymph node post-neoadjuvant chemotherapy. Basically, let's come to a very simplified language from radiology point of view. It's not going to be like heavy as usual. This is for general view with oncology basis. Our main objective is to get familiarized with the latest recommendations for breast screening. Basically, breast cancer is not only a significant problem in Saudi Arabia, we consider it one of the most common causes of cancer-related mortality worldwide. It's estimated that more than 1 million new cases of breast cancer diagnosed annually. This is according to the ACS. Basically, a total of 6,922 female with breast cancer cases recorded in the Saudi Cancer Registry from 2001 to 8. Highest overall percentage of female breast cancers, 38 and 31 respectively, aged between 30 and 44, 45 to 59. So this is the highest, and the peak of newly diagnosed cases is 30. This is scary. The eastern region of Saudi Arabia has the highest overall. Anyhow, just like a quick review, and though I really hate these paragraphs, but it's so scary when we know that the breast cancer has the highest incidence rate and mortality rate. Then comes to the mortality rate where the liver and lung almost equally comes. Here again, this is per Saudi Arabia estimated age standardization rate for breast cancer. Basically, this is the highest number is come to the breast compared to what comes to male. It's kind of like sporadically distributed, but breast is like really, really high. So this is the leading cause of mortality rate in Saudi Arabia, up to 14.8%. And the percentage of 29.7, it's almost 30 of mortality cases related to breast cancer. Anyhow, if we come to the risk factors that we know, everybody knows about it, contribute to incidence of having invasive cancer. It's about age related. Lifetime risk is 12.8% as the lady getting advanced in age. Now we talk just like briefly about these things that actually everybody, I believe, familiarized with, from fourth-year medical students to primary healthcare practitioners, that these factors should be like highlighted. And when it comes to oncology basis, oncology centers, I believe they have a nice pool of cases of PRCA positive patients, of those who has a mantle radiation earlier age. So I believe those people can be recruited, can be investigated in a very systemic way, rather than leave them in the society and give them the full right of being screened or not. This is, I believe, it's not. But genetics people can be helpful. The genetics doctors can help in these. So one of the important things that had been discussed in the last 20 minutes, those people who has night shift works, doctors, medical personnel, nurses, flight attendants, those with different circadian rhythm disruptions, those are come with high risk of getting breast cancer in their age. And this is not listed here. So scary. Again, mammographically dense breast, this is one of, it stands as high risk percent. Anyhow, we just talk just like briefly about the 5-year survival of the patients with newly diagnosed breast cancer, the localized cancer, meaning the early detected cases are more of 99% of having free survival in 5 years' time. Yes. if we talk about what does screening, so why we make a big fuss about the screening, mammography, blah, blah, blah. Basically, screening meaning it's doing imaging before the patients come to with a clinically evident abnormality, palpable lump, or anything. So, for example, basically we are doing it as mammography based. Mammography, it's a low cost, accessible, readily used. A lot of debates and controversies took place over the 40 back years, though this is, we talk about 1930, it's like 13, something very remotely. Dr. Albert Solomon, who x-rayed 3,000 breast specimens with pathologically positive findings on x-ray. So it's very, very remotely the breast cancer detection took place. So one of the controversies that it can be overdiagnosed, resulting in a lot of positive, where's that? Overdiagnosis, harm of the patients from radiation, results in unnecessary biopsies and everything. But the lost lives from breast cancer is it's so high if we compare it to the unnecessary things and the harm and overdiagnosis. And they say that most of the patients who diagnosed over screening base are DCIS pathology. This, having said this, correct, it has no association with high mortality, though it's a pathological thing that should be treated on and should be acted on. Anyway, one of the things that the screening mammography can detect is the slow-growing cancer, and the against debate about it's like the highly aggressive cancer can be missed. So we talk about the sojourn time, which is like 1.7 or 18 months. So that's why U.S. Preventive Services Task Force, they were against that the lady starting her screening mammography by age of 40. They said she can do it by her own self, should not be covered by the health insurance companies. Though in our country now, we are pushing the ladies to start their screening from age 35. The lady should not have any, in nice way, she's not like can optionally choose at 40. She can optionally choose to screen at 35, but 40 to 49 is not time that can be missed. It's preferable to start it earlier, because of, as we said, the sugar and time or the interval cancers can develop in 18 months. So annual is much better than biennial follow-up. Anyway, we say this annual staging from 40 to 45, these guidelines from the American Cancer Society. And one thing just to highlight it, in our most of the patients who came to ours, like she's 82 or something, and she wants to be screened in a wheelchair. So we have to make a very being fair with those patients and check their life expectancy through the calculator, whether they are able to come for screening, what the comorbidities they do have. If we talk about 75 and they can go like 13.5 more years, that's quite gracefully to be lived in a healthy way. Anyway, just one of the things that we always say in mammogram, that the ladies should, there's a campaign, big campaign, whether are you dense or not. This is an independent risk factor of having breast cancer. So density is equivalent with it's with higher breast cancer, not because of being dense itself, it's being hidden, of the hidden cancers that can be seen. That's why we do not depend exclusively on mammography. We always combine it with tomosynthesis, for example, up to 1 to 2 cases additional, mammogram and ultrasound, 4 cases, plus mammo and MR is like 7 cases detected with additional 40 biopsies. These things actually, it's kind of come with free in our screening programs, though European countries and US, they still fighting to do more of large randomized clinical trials to prove the efficacy of these additional modalities. Anyhow, again, to the diagrams, a simple diagram, important diagram about the life loss due to breast cancer. We say it's starting from 40, 45 is the highest, 50 to 40 to 54. So from 40 to 59 is kind of really high percentage of chance of losing life because of breast cancer. So the mortality is scary at this time. Anyway, these risk assessment tools, it can be run through the primary health care practitioners. It can be run in genetics clinics, oncologists, surgeons, radiologists. They can just suggest to others to do it because these are very lengthy questionnaires. Ladies can optionally go through these calculators to assess their lifetime risk. Lifetime risk more than 20%, meaning the lady is eligible to have free MRI annually. Just a quick preview about it. Breast Cancer Surveillance Consortium Risk Calculator. It predicts the PRCA carrier plus the invasive. Tyrer-Cuzick Risk Calculator is kind of more of logic assessment for invasive family breast cancer, age, HRCT use. And one of the recommendations for MRI screening based evidence, the PRCA patients, those we have a very nice pool for PRCA patients in any oncology center, those who got radiation and first degree relative with PRCA. Anyway, we're not gonna go through it because it's not mine. CDC screening guidelines have a lot of comprehensive schedules and they have different recommendations. It can be seen through the American College of Radiology, Society of Breast Imaging. They favoring that tomosynthesis and MRI started from 40, especially those with PRCA patients, 25 to 30. Actually, this is a new, it's not new to 2010, but meaning it's quite early to start from 25 to 30. Those patients who have got prior chest wall radiation, they start the screening 8 years after receiving the radiation. I remember I witnessed a 24-year-old lady who completed her radiation age at 11, and she diagnosed with invasive cancer, 4 centimeter at age of 24. It's kind of really scary. Anyway, this is one of the cases that ladies who got radiation therapy, 13 years old, like her mid-30s, she was 43. That was in 2017, the subtracted images, nothing is there. Then in 2018, a very small invasive cancer had been detected. Anyway, because we are radiologists, so I have just like to bring some mammograms to, it's kind of nice to enrich our eyes. Anyway, this is a 40-year-old lady presented to our screening in our hospital. Basically, as we said, mammogram, dense breast, meaning more recall rate, meaning it can obscure some lesions. So this lady, very dense breast, she had this abnormality here. We're not really like quite sure how does it look on sonogram. Once she did the sonogram, it's very invasive, very infiltrative, large area from 4 to 6 o'clock with positive axilla. Unfortunately, this is the screening kind of cases that we face, not the very small and neat ones where we talk about stage 1 or 2. This is very ugly. Anyhow, it was invasive cancer. She received her treatment, and it was lengthy time for treatment instead of having an early breast cancer. This is a very neat case. 40-year-old lady presented to screening just for her age. She was on vacation, came to do the mammogram. Nice small asymmetry, right upper outer quadrant, posterior depth. Then we biopsy, sample her breast, put a clip, and 1 month later, she got this nice specimen with very nice compliance with her treatment regimen. Finally, this is another case, asymptomatic, small lesion, upper outer quadrant, 1.5 centimeters. So this lady is eligible for having just lumpectomy with no consequences, ugly kind of treatment like chemotherapy and everything. So thank you, and that's it.
Thank you very much for sticking into time. And now, with no further delay, I'm very delighted to represent Dr. Mariam Salami. She's our colleague in King Abdullah Medical City, consultant breast and endocrine surgeon. And she will be talking to us about the new updates in the oncoplastic surgeries. The podium is yours, Mariam. Thank you very much.
Thank you very much. I would like to thank the organizing committee for this, for invitation and for this organized meeting. Oncoplastic breast surgery, what news? The new things is called extreme oncoplastic surgery. As you know, with the recent data that we have, which showed ladies with who's treated with breast conservation surgery, they had a better 10-year survival over compared to the mastectomy group. Since then, all the recommendation goes toward a preservation of a breast and patient treating with breast cancer. So the goals of breast conservation surgery is to achieve a tumor-free resection margins, prevention of local recurrence, optimizing cosmetic outcome by maintaining breast shape and appearance, operating on time to perform the definitive procedure. As everyone knows, the sequences behind the standard lumpectomy and the deformity can be happen even on the very skilled surgical hands. For that reason, during the last 10 to 15 years, there was a lot of data and publication in the literature supporting oncoplastic techniques in treating breast cancer with good long-term outcome and good survival and quality of life compared to the standard breast lumpectomy. So oncoplastic breast surgery, it allows removal of large portion of the breast in order to achieve free margin without compromising or even improving the natural shape of the breast. It becomes the standard of care in the management of breast cancer and should be considered in all patients who required surgery when technically feasible and oncologically safe. Oncoplastic conserving breast surgery represents a better option than the combination of mastectomy with reconstruction and radiation therapy due to the morbidities can be happened for such patients. As I mentioned, there was a lot of data was reported. Krishna, he reported his experience with 10 years follow-up for a patient who underwent oncoplastic breast surgery with acceptable local recurrence. He had 2.2% of local failure. Italian group, they reported their oncoplastic breast conserving surgery when they compare it to the standard lumpectomy. And again, they had similar overall survival between both groups, and disease-free survival. There was no statistically significant difference between both groups. So they suggest that oncoplastic surgery is a safe and reliable treatment option for managing invasive breast cancer. Since then, there was a lot of techniques was reported in the literature. Oncoplastic techniques can be used in treating breast cancer patients. What about if we have locally advanced with large tumor size? In these cases, usually we require the excision of large amount of breast tissue or partial mastectomy. So then extreme oncoplastic techniques came up in the last 5-7 years with some reported data. This was written by Melvin, who's the most interesting in preserving breast tissue in patient treating with breast cancer. So extreme oncoplastic surgery is emerging as a new promising concept of a breast conserving operation using advanced oncoplastic technique in a patient who usually required and recommended to do mastectomy when we treat them with breast cancer. Usually those patients, they have T3, tumor larger than 5 centimeters, multifocal or multicentric, which is most of our patients. There is many cases reported and the literature was published with good long-term outcome. And this data actually, they included 60 patients with stage 3 breast cancer. 70% of them, they received neoadjuvant chemotherapy, and they found that the local failure and local recurrence in 6 patients, 3 of them, they had distal metastasis out of total of 23 who's having distal metastasis in the whole group. Again, 42 patients was included in this data. Most of them, they have 90% of them, they have large tumor size T3 and T4. All of them, they have nodal positive disease, and they reported 14% of local failure and overall survival 86%. Another reported data showed there was no significant differences between extreme oncoplastic versus non-extreme oncoplastic in treating breast cancer with similar 10 years recurrence rate. Melvin earlier, he reported his experience with extreme oncoplastic. He included 66 patients with a large tumor size more than 5 centimeters who underwent extreme oncoplastic, and he compared them to the standard oncoplastic for a patient who's having smaller tumor size, less than 5%. And he showed that there was no statistically significance in terms of local recurrence between both groups. Then he included more number of patients, 200 in extreme oncoplastic for a patient who's having locally advanced tumor, more than 5 centimeters. He compared it to the standard oncoplastic technique for a patient who having smaller size tumor. And he found again, local recurrence is similar between both groups, but median follow-up was only 2 years. One more study from UK, they reviewed the therapeutic mammoplasty in treating locally advanced breast cancer. They included 28 patients, and again, they found predicted 5 and 10 years the local recurrence rate of 1.1 and 16%. Another study, they included 111 patients who underwent extreme oncoplastic between 2011 and 2017. 82 patients out of 111 patients, they had multifocal multicentric disease. And again, they have a recurrence rate of 1.1%. So usually for extreme oncoplastic, we need to excise large amount of breast tissue, and usually it can be done by any other technique other than standard wise pattern breast reduction mammoplasty or split reduction mammoplasty. And this is usually the marking. We are seeing that T4 patient having a tumor in upper central, and the tumor is extended to the nipple with nipple involvement. So the best option for them to be treated by what's called Grisotti flap. We are excising the tumor, including nipple areola complex, and we reconstruct the nipple with skin island. And this was done 2017, and her follow-up in 2021 with no local relapse. This is a lady, she is 45 years old with triple negative breast cancer, presented 2017. She received neoadjuvant chemotherapy for 5 centimeter tumor, but unfortunately after 4 cycle chemotherapy, she did not respond to chemotherapy and her tumor is progressed. It's become 7 centimeters. Patient was completely refusing mastectomy, so we had to reduce her breast with excising the tumor with a large margin. And this is her follow-up in 2021, no local relapse and no distal metastasis. Another lady, she presented with multicentric tumor, and the lower part of the breast. Triple negative again, she has large size breast, so we excise the both lesions by after localizing by 2 wires, and we reduce her breast, and this is her mammogram 2021, showed no local recurrence. Another lady, 35 years old, multicentric breast cancer, she is triple negative. Again, we excise her, we did for her 2 lumpectomy and reshaping her breast. Again, recent follow-up mammogram showed no local relapse. This is fat necrosis as a part of this such procedure. One more case, she is 45 years old. She has metaplastic triple negative cancer, presented 2016. Patient was refusing chemotherapy and refusing mastectomy, so we just excise her tumor and reshaping her breast. Unfortunately, patient she refused radiation, chemotherapy, and she died of her disease 3 years later due to systemic failure. One more lady, she's 70 years old, again, presented with nipple areola complex involvement. So we did for her central lumpectomy with reconstruction, her nipple areola. Again, one more, usually patient who's really candidate, good candidate for such technique, wise button reduction mammoplasty, who's having tumor in the lower breast. We can excise the skin and the tumor and up to the fascia with good peripheral radial margins and reshaping the breast. Again, this is done 2018, 3 years later to 2021, she had no local recurrence. Multifocal disease presented to 2018, and 2021, she has a mammogram with no local relapse. This is recent case done 2021. She has multifocal disease. Actually, the whole lower outer quadrant of her breast get involved with a disease, and she has a huge mega breast. So we decided to do for her reducing, removing the whole lower part and outer part of her breast with reshaping her breast. This technique can be used not only for cancer, can be used for other fibroepithelial tumor. This lady, she presents with more than 15 centimeter lesion. So we did this approach and we reshape her breast. If we don't have enough breast tissue, so we can choose another technique of oncoplastic. And this lady, she has juvenile fibroadenoma. Again, difficult for 14 years old to decide about major reconstructive for the breast after removing such huge mass. So a great surgical hand in extreme oncoplastic surgery is not enough to optimize the oncological and aesthetic results. Good oncoplastic surgery requires both individual ability and technical skills and decision-making skills. Not all patient candidate for such technique. The use of oncoplastic technique on selected patient with locally advanced breast cancer looks suitable and safe and didn't threaten oncological local control. And it must be individualized for each particular patient. A large number of women may spare mastectomy by using the carefully selected technique. And extreme oncoplastic allows successful breast conservation in selected 5 centimeter multifocal multicentric tumor, who's usually candidate for, going for mastectomy, but long-term data on recurrence and survival are not available yet. This is a new technique, and prospective randomized and multi-centered study applying oncoplastic technique on such group of patients with locally advanced breast cancer is required. I know it is a debatable topic, but it works. Thank you very much.
Thank you very much, Dr. Selami. Threaded into what you mentioned about oncoplastic surgery, it's a great pleasure to introduce our next speaker, Dr. Muhammad Al-Harbi. Muhammad Al-Harbi is a consultant plastic and reconstructive surgery. He's the head of the plastic surgery department. It would be an asset to have him on board today, but unfortunately he will be presenting through Zoom link. He will be talking to us today about breast reconstruction and the best modalities and sequence with the radiotherapy. Thank you very much, and the podium is yours, Dr. Harbi.
يلا شكرا تقرا. السلام عليكم ورحمة الله وبركاته. ما أدري إذا كان بسمع الصوت ولا لا.
أيوة سامعين حضرتك.
السلام عليكم ورحمة الله وبركاته. I would like first to thank all the organizer and the committee for this great giving the chance to participate in this great conference among great colleagues and speakers. Our topics is a huge topics. I think I have 20 minutes. I'll try my best to summarize it and to go step by step in a short concept for each procedure that we'll go through. Just having difficulty moving the slides. Our outlines will be about the patient assessment, and after that, the options, timing, and the contralateral. Always we have to think about the contralateral breast. And the last is the nebular complex reconstruction, which I'll not go through it as a consider as aesthetic. The diagnosis, once the patient gets diagnosed, we know it's straightforward, it's a negative impact on the patient's psychological well-being. And the reason that we just go for reconstruction to improve the self-esteem, the self-image, and the confidence for the patient. Once we go through the assessment, the history, the tumor details, the genetic family history, where the patient go for radiation, this is one of the most points, and the general condition of the patient, the BMI, and the expectations. And this is a big point that we have to make sure what's the expectation of the patient and if she really understood everything that you delivered to her. So when you come to the physical examination, we have the disease part, the ipsilateral breast, and we have the general condition and the contralateral. And if you go into the free flap, we always have to think of donor side. Simply, we have immediate versus delayed. So for the reconstructive options, surgical, the most of the non-surgical for these patients want to delay or refuse any surgery, they go with the prosthesis. Or we start by our option for surgical, whether it's autologous or alloplastic with the ADM as a biological materials which can support the implants. So once we go for the autologous, simple diagram here show the pedicle flap, so simple, and free flap. Pedicle, everybody know about the most common use, tram flap, latissimus dorsi flap, and free flap. You can use both of these flap as a free flap, and then from the gluteal region, thigh flap, perforators with DIB flap, the most common perforator flap being used, and the S-gap and I-gap, which taken from the gluteal area. And the alloplastic, whether we go for saline or silicone, if we go for immediate permanent, or tissue expander starting by temporary, and then end up with the permanent implant. This is just, since the ADM, this is from Salzburg, a very nice classification. Usually this considered for the patient, you go for immediate breast implants supported by the ADM artificial dermis. He made a classification very simple. It's not applicable for all patients, for our surgeon. Still, we do understand that every surgeon has his own experience, even the oncologist. But he considered, just to summarize it, what he wants to deliver about the ptosis regarding the contralateral side by using the ADM. If it's small to medium, you go down by inframammary fold. So by this way, you can fold the implant with the ADM. In a way, you just suture it behind the implant, you create a ptosis compared to other side. But if you have a huge breast, then you go for other wise pattern, any other techniques for reshaping. Now we go for the tissue expander. Everybody know about the tissue expander, the custom reconstructive expander, wide range of size and shape. promote mild tissue ingrowth, inhibit migration of the expander from periostatic. When it's structure, we have the integrated port and we have external port. Both of them can be used, and it depends about the what is available. Mostly are temporary. Nowadays, nobody uses as a permanent. And this is the way where we do apply it and make it under the muscle. But usually nowadays, we are using it with ADM. And here we are showing how we can usually, once we want to go to the subpectoral, we have the deficiency in the inferior lateral part where we put the support of ADM and we fix it so we can cover the muscle up and the lower inferior part by the ADM. The complication, cytoma, everybody knows this, the infection, the wound dehiscence, and all these complications especially become worse if the patient immediately go for radiotherapy. And also, remember this, the migration of the expander, the portable necessity is one of the sometimes an issue for the surgeon for the expander. Very rare pneumothorax, misport, as I said, during inflation. Implants, whether the saline implants or the silicone implants, now because of the anaplastic large cell lymphoma, mostly the only implants we use is the smooth part or microtexture part. The complications, same as some of the expander, hematoma, seroma, infection, rupture, asymmetry, sometimes ripping, especially the subcutaneous, and capsular contraction. The most problem issue if you face is not in a measure, but this is the most common complication related to the implants. Now I will start with the autogenous reconstruction, starting by the most common flap that we are seeing. Usually the indication, if the patient has a preference radiotherapy, although it's not necessary, we can go from the immediate reconstruction, patient preference, or if the patient refuses any alloplastic material. The contraindication, if the poor health preclude lengthy surgical procedure and refusal of any donor side morbidity or scar. The advantage, the most common, more natural skin texture, it's a permanent and have less complication if it's go for radiation and durable, versatile. We have different way to do the reconstruction with the pre or pedicle. The only disadvantage, it's a long procedure, technically more demanding, need more skills, longer OR, or recovery of donor side morbidity. The most common, the flap that we use as a pedicle or free is a tram flap. The diagram on the right side where we can use it as a pedicle or free to make it simple. We use it as single or pedicle. And the advantage, simultaneous abdominoplasty, same for the free flap as a deep flap, which will come later for it, except the donor side as is hidden. Generous amount of tissue that we can have for moderate or large breast, good color and texture, versatile. The only disadvantage, like any other flap donor side mobility, is considered major operation and need more recovery. The indication for the tight, thin chest wall, fade preface reconstruction, preface radiotherapy, or patient preference or refusal alloplastic material. The contraindication, very obese patients, usually for pedicle trauma, we don't recommend for partial flap necrosis and COPD and patient unwilling or unfavorable scar. The complication, it's like any other flap. We have partial or complete total flap loss, necrosis, hematoma, seroma, all other complication, and DVT, pulmonary embolism as it's a longer procedure, fat necrosis, and asymmetry. And if you use it as a pedicle, we have the risk of hernia as well as a deviation of the umbilicus. But to a certain house, some patients, they do accept if they have this complication as long as they are agree about their options. Let's medullary side flap is the most common. Also, it's used in combination, can be used with implant or without implant. And now for the trends, they use it with the fat injection, need multiple surgery, is a constant anatomy. Sometimes when the patient has any failed procedure, whether tissue expander, implants, or any other flap, is still considered as a lifeboat for all the surgeons. We can use it for a small, moderate size. But the only issue of this flap is does not give any projection. It's very moderate or low projection. That's why we use implant with it or multiple sessions of fat injection. As the recovery is faster, the only disadvantage is the position in OR. We cannot do it. We can do it bilateral, but in longer procedure. That's why once we want to do it bilateral, we consider a separate procedure. We'll go now to the free flaps. The tram flap, when you take the muscle, we call it tram, but we don't take the muscle base and the small perforators, we call it deep inferior epigastric artery. Both the same indication for all of it, the same. We include a procedure that divides the superior epigastric. When the patient have past history, any injury to the superior epigastric, it's a good advantage. We go for free flap. Smoker can use it for the obese or smoker relatively. It depends on more details. The blood supply and the risk of the partial flap loss is less in the free flap, especially for the smoker. And the disadvantage only it's less as for all general flap. We can have complete flap loss if we have any thrombus can obstruct the anastomosis. This is so simple. We have seen the hidden scar of the abdominoplasty, and we can see the muscle that we keep the muscle, and we just take based on the small perforator, we are just taking the skin and subcutaneous tissue. The gluteal free flap, not every surgeon like to do it. It still is not the first choice, neither the second choice. It's based on the superior gluteal. If it's superior part or inferior gluteal, end up with the hidden scar and the infragluteal. It's considered for the small to moderate, need 2 positions. It's a longer procedure. It's still considered as an option. Other option, deep circumflex iliac free flap, we call it Rubin's flap. It depends on the deep circumflex iliac vessels. The only issue, it takes cuff of muscle and sometimes it's painful for the patient. Rarely get also the bulging hernia. Some surgeons, they take it as a deep flap when they need a large breast extended to this artery. The last one, the tube flap transfer upper gracilis flap. This is very nice flap. We use it for the very small breast. When the patient, very thin athletes, does not have the option to go for tram or free flaps, some surgeon, because of the discoloration of the skin of this area, we can do a nipple areolar reconstruction at the same time. Now, once we decide to go for surgery, we do have a high-risk patient, and we have to put it in our mind to be aware for our colleagues and for the patient. When the patient is 60 years old, the body mass index more than 30, especially when you go for free flaps or pedicle flap, the risk of fat necrosis is high. Comorbidity based on the Charlson score, if it's more than 5, smoking stage 3 or 4 disease of mastectomy or prior post radiation. This is the Charlson score. It depends mostly on the medical old disease. It just is not applied for all patients, but just once we reach to the 5, it's considered high risk. Now I try to go through the literature and all the studies about each part. I try to summarize it as much as you can. It's all debates. It's all debates about which one's the best, whether you go for an immediate, whether you go for the implant, or tissue expander or free flap. Here, this it was done recently in 2001. He compared, and the patient had bilateral breast autologous reconstruction. Mostly it was a DIB flap and the tram. When they found no statistic different in the long term as a complication, the only was mild fibrosis, which was acceptable by the patient. They just targeted the patient who will have radiation on one side. And that's why very nice as a comparison. Just they notice if the patient will go irradiated mammary lymph node radiation, internal mammary lymph node radiation, it's likely will have more complication. Other studies was generally about all the types of reconstruction, implant, expander, or autologous. They found out in simply that the delayed autologous, or generally the autologous breast reconstruction, have less complication, which is logic compared to the implant or expander. This is other studies. Here was just literature review. Whereas surprisingly, beside that, the complication is more to the implant-based reconstruction. And the patient they found is getting raised. Most of the surgeon now increasing by doing implant, even if they know the patient that they will go for radiation. Although we know the complication is still high for these just patient, but in the long term, they find the satisfaction and the complicated is acceptable, which is not stop them from doing it. So when we say the immediate autologous reconstruction for post-mastectomy, tissue fat necrosis is less and the skin integrity and wound. Another, when we go for the delayed, here another study, he found when we do it after 1 year as a delayed, it still give better result and less complication for the autologous, especially for the wound contraction, was considered the fibrosis. Now, the last two topics about the immediate plant-based reconstruction. Same studies they done on the implant itself or the implant expander followed by the implant. The advantage of the implant, it's 1-day surgery. It's preserve the breast landmark anatomy, and the patient psychologically from the next day, she can feel that she has breast. And this is the only advantage. But we come to the point, comparing with the second 2-stage procedure, still we found that 2-stage procedure less complication. The delayed expander implant reconstruction, 2 procedure, we started by the expander. Then if the patient will go for radiation, either we go immediately after the radiation, we just start to inflate it if there is no much complication, or we wait a couple of months once she finished the radiation and up with the implant or any autologous reconstruction. The same studies here, they noticed as long as the patient going for primary implant and expander, and if you go for radiation, it's better that either you finish it 4 months before or you wait till 1 year, as after 1 year is less complication. This is very nice simple diagram done MD Anderson, where I think most of the surgeons, they go for it, which is a logic that when you start just to try to protect the skin envelope post-mastectomy, we just, rather than delay the operation, even if the patient, we don't know that if going for radiation or not, just we put the expander, we inflate it, not too much, just we make the skin relax, and then we wait a couple of weeks after the result. If our colleague and the radiologist decide the interventionist for radiation, then we start either we deflate it, we go for radiation, or we start the radiation. And if the patient start to have pain, we can deflate it. And we just wait a couple of months until the finish. And then we just follow the skin. If everything is fine, no more exclusion, need an urgent emergency to remove it, just wait and up to 1 year, and then we choose our. This is the last, it's very simple. If the patient going for skin sparing mastectomy, we go for subpectoral, although remember, some doctors and some surgeons, they go subfacial. They just use the ADM as an envelope for the implant and they put it, they fix it, which is a very nice result. It all depends on the patient. Once you wait for result, if we see on the left side, the patient will go for MRI, then we deflate, we wait, and after radiation, re-evaluate, and we start to re-inflate the expander. If it's in a good position and no more major complication need us to remove it. And then once we decide whether we go again for the implant or LD or with free or medical flap. But if there is no radiation, in 2 weeks, we can decide the final reconstruction with a permanent implant or trunk. I just want to know, let you know, at the end, it all depends on 3 things, and the patient itself, the expectation, the surgeon skills, and all material that we have in our centers, and the teamwork from our side, the oncological team and the breast surgeon. At the end, the risks and benefit of the immediate versus delayed autologous reconstruction, it depends on all different for each individual patient. And the most challenging is how to achieve a good result without compromising the adjuvant therapy when mastectomy radiation is required. No level 1 evidence indicating the optimal strategy, and this complex decision involve and should consider the quality of life for the patient, surgical outcome, the history of radiation, and the cosmetic result aesthetic that could be the best for the patient and the life expectancy. So I think we are lucky in our center that we have our colleagues from the oncology team, Dr. Miriam, Dr. Ihab, Dr. Taimur, everybody. I'm from radiation, Dr. Tahani. Really the teamwork that we have and the discussion that to end up with the best result, this is the make us in a progress a nice way. And I should advise all my colleagues in every center, always the discussion and the healthy discussion and what is the best for the patient and the expectation, the main issue for the patient psychologically is the most important. Thank you so much for your time and for your kind listening for this.
Thank you, Dr. Muhammad. Welcoming now Dr. Fahad, consultant, Fahad Al-Jandan, consultant, plastic and reconstructive surgery.
السلام عليكم. واضح الصوت مسموع؟
واضح دكتور.
طيب. First of all, I would like to thank the organizing committee for organizing such a wonderful event. Today we'll talk about a unique topic, which not a lot of us are, believe in it. I used to be one of those who were skeptical about it and took it with a grain of salt. However, after doing my fellowship in Taiwan and having the honor of working with such pioneers in lymphedema surgery, I was convinced about the result in selected patients. So today we'll talk about lymphedema surgery, including patient selection and an overview of surgical techniques. So we know that the lymphatic system plays an important role of regulation of the interstitial fluids. There are about 600 to 700 lymph nodes distributed all over the body. These have connections, efferent and afferent lymphatic channels that serve to transport this lymph. We also have lymphaticovenous connections that drain this lymphatic fluid into the venous system. Therefore, disruption of this system results in what we call a lymphedema. There are about 250 million people worldwide suffering from this lymphedema condition. We have two types. We have the primary, which is genetic or developmental lymphedema, and we have the well-known secondary lymphedema, which is usually due to postnatal causes. Worldwide, it was found that the leading cause of lymphedema is filariasis. However, this figure is different in developed countries where the leading cause is oncologic therapies. It was estimated in some publications that 29 to 49% of patients with axillary lymph node dissection will develop lymphedema, comparing to only 5 to 7% of those with sentinel lymph node dissection. How does lymphedema progress? So once there's a disruption of this system, we start to have lymphedema, which is a buildup of protein-rich fluid. This will eventually lead to formation of fibrous tissue and also adipose tissue deposition. So the patient will come with swelling, with occasional pain, heaviness, and in advanced cases, they will start to complain of thickening and firmness of the skin. And a lot of times we see recurrent infections in form of cellulitis, ascending cholangitis. But you have to keep in mind that there are a number of conditions that can mimic lymphedema. These include cardiac causes, renal, liver, protein deficiencies, electrolyte disturbances, DVT, infection, and malignancies. So you have to go and take a thorough history, do a comprehensive physical examination. But you have to keep in mind that volumetric measurements are very important and essential. Always compare the limbs. We have different modalities for comparing or doing our measurements. We have the water displacement test, circumference measurements. This is my preferable method. And also there's bioimpedance spectroscopy, which is not done that frequently. And we have also lab tests to rule out other causes. So as we can see that the diagnosis is usually done clinically, and you don't need to do an investigation unless you're planning to take the patient for surgery, or you are suspecting other diagnoses. So once you want to take your patient to surgery, lymph scintigraphy is the gold standard, where a tracer is attached to a technetium-99, and this is injected into the dermis. Other tests that can also be done, but they are less commonly done. This is we have the CT scan, MRI, infrared, and ICG, which is very useful and gives us a real-time imaging of the lymphatic drainage. And this is usually done in the OR when doing, especially when doing lymphovenous anastomosis. So this is just to show you how the lymph scintigraphy can be very useful. As you can see here on the left lower limb of this patient, we can see that there is a dermal backflow here, and there is absence of the lymphatic drainage in the affected limb when you compare it to the contralateral side. So this can give us a clue or a hint that the patient is having a problem on that side. There are different systems for staging lymphedema. The most commonly accepted one is the International Society of Lymphology, which stages patient from 0 when we have a subclinical stage, and then 1 when it's reversible and it disappears with simple elevation, then 2 when the swelling is constant and does not resolve regardless of elevation. Then we have 3 in which the skin becomes hard, fibrotic, with associated changes. Professor Cheng from Chang'an Memorial Hospital also made this very useful classification. I was lucky to work with him during my fellowship. He classified the patient from 0 to 4 according to the symptoms, circumference differentiation, and lymphoscintigraphy finding. And based on these findings, he assigns the patient or allocate the patient to the management plan. So we have from 0, which is reversible with less than 9 circumference differentiation. This means that there is a partial occlusion, and the patient will only go for conservative therapy like complex decongestive therapy. And then as the patient progresses, we can see that they will start to have a total occlusion, in which it might be useless to do a lymphovenous anastomosis since we don't have any patent channels. And in this case, the patient will most likely need what we call a vascularized lymph node transfer. And then we can see that in very severe cases where there is a total occlusion and more than 40% difference between the limbs in terms of circumference measurement, the patient will need the vascularized lymph node transfer in addition to some form of a debulking procedure, such as the Charles procedure. We'll talk about these procedures shortly. So what are the treatment options? We have to remember our primary goals. Our goal is to limit the morbidity, improve the function and quality of life. And therefore, we are left with 2 options. We have non-surgical, which is the first modality of treatment, and then we have the surgical treatment. The non-surgical treatment, which is the complex decongestive therapy, which is the hallmark of conservative therapy, includes compression garments, exercises, massage. This is widely variable. And however, the only disadvantage of this modality that it can have an economic and personal burden in the patient, which can result in non-compliance. We're lucky to have Maria with us she's an expert in this form of modality at King Abdullah Medical City. And I refer to her a lot of patients, and she helps a lot with them. She's very very good and efficient. Regarding the debulking procedure, which is usually reserved only for advanced cases, we have what's called a Charles procedure, which is the best known form of debulking procedure. It involves resecting the skin and soft tissue to the deep fascia, and then the skin can be used as a skin graft. However, this procedure tends to be disfiguring, and it's only reserved for most severe cases. We have also other forms of debulking procedures, which include the wedge excision, which is less aggressive or less invasive than the Charles procedure. And we have the liposuction. This liposuction can be done either alone or combined with other procedures. The idea is to remove the buildup of fatty tissue, which is resistant to the complex decongestive therapy. However, it has risk of hematoma, seroma, and can also cause a further lymphatic damage. And the patient will also need continuous compressive therapy post-op. However, studies have shown that this modality, which is liposuction, can decrease edema formation and infection rates with good long-term follow-up. Now, let's talk about the most recent modalities for lymphedema management. We have what's called a lymphovenous anastomosis. This is a physiological procedure. The idea behind this modality is to bypass the damaged lymphatics by diverting them into the venous system. This modality was first described in 1969. It's only effective if performed early, as I showed you earlier in the lymphology and also in Dr. Chang classification system. There's a big controversy whether to do a multiple anastomoses or just one, and also whether to do it, the configuration, whether it should be end-to-end versus end-to-side or side-to-end. So there's a lot of debate. I was lucky to be involved in this paper during my fellowship. We did a comparison we did a comparison between the end-to-end lymphovenous anastomosis and the side-to-end for early grade extremity lymphedema. And the results showed that both side-to-end and end-to-end lymphovenous anastomosis configurations were effective surgical approaches for improving early grade extremity lymphedema. However, the side-to-end anastomosis has the advantages of having greater efficacy for lymphatic drainage, and it requires only one anastomosis, and also it will eliminate the need for use of compression garments. So as you can see here in these figures or illustrations here, this is the side-to-end, this is the lymphatic. The yellow vessel is the lymphatic vessel, and the blue is the venous. You can see that here how there is a bidirectional flow in the side-to-end of the lymphatic drainage. So it will drain from up and down to the venous system, whereas in the end-to-end, you will have only a unidirectional flow. In addition, that you will disturb or disrupt the existing lymphatic system. That's why, in theory, you can conclude that the side-to-end is logically more efficient than the end-to-end, and we were able to prove this clinically. So what are the factors influencing the success of the lymphatic-venous anastomosis? First, we have to choose a suitable lymphatic channel, and this can be identified by the ICG lymphography. The suitable vein, so must be identified as well after choosing a suitable lymphatic channel. What do you mean by a suitable vein? I'm sure that a lot of you are wondering. A suitable vein means that the vein should be compatible, of a compatible size, is in a proper location with minimal backflow, because we don't want the blood to have to flow backwards from the venous system into the lymphatic system. And then after doing the anastomosis, we can test it or by doing the immediate patency test, also by ICG lymphography. This is a study published in the Plastic and Reconstructive Surgery Journal, which aimed to study the long-term results of microlymphatic venous anastomosis in obstructive lymphedema. And it included 52 patients. Subjective improvement occurred in 38 patients, which is about 73%. And also objectively, volume changes were significant, showed some significant improvement in 22 patients, which is 42%, with an average reduction of 44% of excess volume. This is another study, which was a prospective study. It included 100 consecutive lymphovenous bypass cases for treatment of extremity lymphedema. The mean volume of differential reduction at 3 and 6 and 12 months were studied in those patients who had either stage 1 or stage 2. It showed 58 and 52 and 61% improvement respectively at 3 and 6 and 12 months, which was significantly larger than those patients with stage 3 and 4. However, this procedure can also have some complications, but they're minimal, thank God. These can include infection sometimes, lymphatic fistulas, and wound healing problems, but these are very rare complications and minor ones. This is just to show you the steps. This is the vein here. We are choosing the suitable vein, and this is the lymphatic vessel. You can see here we did a side to end because the side of the lymphatic vessel was anastomosed to the end of a suitable nearby vein with minimal backflow. And then you can see here the immediate patency test. You can see the dye flowing smoothly from the lymphatic vessel into the venous system, and also here by also the gamma fluorescent imaging. I'll show you a brief video just to show you, to go through the steps quickly. So here we are dissecting the venous system. We want to choose an appropriate size veins, a suitable vein. Okay. This is the vein now ready for the anastomosis. Side branches were ligated. And then we're here opening the lymphatic channel, a patent one. Just making a small opening, and we'll do a side to end anastomosis with this vein. You can see here that we are threading inside the lumen just a Prolian stitch just to keep the lymphatic wall open and prevent the collapse of the walls, and for the easy visualization of the channel. Here we are placing the stitches. This is super microsurgery. So I'll just fast forward. You got the idea. So you can see that we do the tying at the end after placing all the sutures, just to make sure that we'll not make a back wall stitch. So you can do your place your sutures under direct vision without any visual obstruction. So we tie the knots at the end of, as you can see, this is the trick. Okay, and then we want to test we want to do the patency test to test the anastomosis, whether it's functioning or not. Using the endocyanine green lymphology, you will see the dye flowing from the lymphatic channel into the venous system, and the veins are filling, and this is also by endocyanine green fluorescent test. Okay, and here are some clinical results. We can see this patient preoperatively. She had her right upper limb involved, and then after the 1 week after doing the surgery, she had the upper extremity 5% reduction rate above the elbow, and below the elbow, the reduction rate was 100%. And then post-op 2 months, the reduction rate was 100% above and below the elbows. Regarding the vascularized lymph node transfer, it is the newest addition in lymphedema therapy. We have vascularized versus non-vascularized, no accepted mechanism. There are 2 theories behind doing the vascularized lymph node transfer. We have the sponge or the pump theory, which states that the transferred or implanted lymph nodes will act as a pump. They will suck the lymph and then divert it into the venous system. And also there's another theory that says that these transfers lymph nodes will generate the formation of new lymphatic channels. This is what we call the lymph angiogenesis theory. But it's probably most likely that it's a combination of both. Usually it has excellent results. There are different flaps that can be performed for the sake of doing the vascularized lymph node transfer. The most commonly done one is the groin flap, which is based on the superficial circumflex iliac vessels and the medial artery from the circumflex femoral artery. The groin flap has the advantage of having a hidden scar, reliable anatomy. Multiple lymph nodes can be included in this flap, and it can be harvested with an abdominally based flap when you're doing breast reconstruction. So you can do it 2 in 1, like breast reconstruction and lymph node transfer. However, it has a number of disadvantages: small donor artery, short pedicle, and the patient can sometimes have an iatrogenic lymphedema of the lower limb. With this, the studies have shown that this can be avoided by doing a reverse lymphatic mapping and avoiding those essential lymph nodes. Other flaps that can be done also, the submental flap, which is gaining popularity based off of the submental artery. It carries up to 6 lymph nodes. It has a good number of lymph nodes, reliable anatomy, the size of good size of the submental and facial arteries, ease of harvest. However, also it can have some disadvantages like possible damage to the marginal mandibular nerve, which can be avoided when done carefully, and platysma palsy, and patient can have a scar on the upper neck. This is a patient who had a vascularized lymph node transfer using a submental flap to the right ankle. The patient used to have cellulitis preoperatively like 30 times per year and have been symptomatic for the last 14 years. Then this is the photo after like 1 month post-op after doing a submental lymph node transfer to the ankle. So we can see the reduction rate above the knee was 42.3%, below the knee 86%, and above ankle 60%. However, in post-op 2 months, these figures were a little bit reduced, but still better than it was preoperatively. Above ankle, it was 15% reduction rate. Below ankle, above knee 15%, below knee 60%, and above ankle 65%. Also, less commonly or other less commonly utilized flap include the omental flap, which has a large number of lymph nodes. However, it lacks the cutaneous component, which is essential for flap monitoring, so we cannot monitor the flap. It also it involves entry into the peritoneal cavity, and we don't want that. It can cause adhesions sometimes, and the long-term consequences are unknown. Also, supraclavicular vascularized lymph node transfer is being done a lot, and especially in the MD Anderson. David Chang is a big fan of this flap, and it is based off the transverse cervical artery. It's a thin flap with a hidden donor site. However, it has a less number of lymph nodes, and it has the potential damage to thoracic duct and supraclavicular nerve. Also, thoracic vascularized lymph node transfer is another flap which is rarely done. It has also the risk of iatrogenic lymphedema. That's why it's not preferable to do that flap. In terms of recipient site selection, in upper limb, we can use the axilla. We can place the flap in the axilla or the elbow or the wrist. In the lower limb, we can use either the groin, the posterior knee, or the ankle. The decision is based on the location of lymphedema and whether the recipient vessels are available or not. The cosmetic appearance and the surgeon's experience, all these play a role in our decision making. So when the patient comes to your clinic, to my clinic, what are we going to do? In the initial visit, we'll do history and examination. We'll do a circumference differentiation. If we are suspecting lymphedema and we want to intervene surgically, we'll do a technician scan. And the patient, based on that, the history, physical, and the technician study, the patient will be graded from 0 to 4. Patients from 1 to 4 will need surgery. For grade 1 and 2, we'll do a lymphography study. If we have a functional lymphatic channel, the patient will have a 1 or 2 lymphovenous anastomosis side to end, and will be monitored for 2 to 3 days post-op, and then the patient can resume activity as tolerated, and will stop the physio and the compressive garment. And for grade 2 to 4,
دكتور فهد.
ايوه معك سامعيني؟ الو؟
ايوه دكتور فهد 2 minutes more if you don't mind.
ايه خلاص. طيب, for grade 2 to 4, there's no functioning lymphatics, so we'll do a vascularized lymph node transfer. So in sometimes when you followed up the patient, you will start to notice that there's a limited response. So in this case, when you have a limited response and the patient is not showing improvement, you will have to repeat your technetium study and do ultrasound. So most likely the patient in these cases will have a venous outflow obstruction and will need surgery to remove this obstruction. So in conclusion, lymphedema is an exciting field, many unanswered questions. There are a variety of tools, as you can see, which ranges from simple excision to super microsurgery with promising results. We need to have a consistent approach with critical evaluation of results. This is the only way to advance towards the ultimate goal. Thank you. So sorry for exceeding my time.
Dr. Fahad, thank you very much for this comprehensive and very challenging topic to tackle in less than 25 minutes. Jazakallah kul khair. By this, we conclude this session. I think there was a lot of comprehensiveness about all the topics that have been placed in here, and we will open the door for discussions.
Can I?
Please carry on.
Thank you very much. It is my pleasure to see all eminent radiologists and surgeons. We are on weekly basis together. I need to take, nobody with me to support me, but anyhow, if you don't mind, I will take this chance to welcome you and to raise one question related to your lecture, Dr. Arwa. And I think 2 weeks back I said, do we need to rediscuss our what we are practicing for axillary lymph nodes, especially post-neoadjuvant chemotherapy. I came across many articles, Dr. Mariam and Dr. Roa. They are saying, if you are going to give neoadjuvant chemotherapy, forget about hormonal. Now, it is better. And now I need a comment from all of you and Dr. Atahani to do not only FNA to confirm it is clinical, radiological, it is most likely the lymph node is involved, And they are advising not to take only like FNA to say yes or no, and to do clipping. Why? Clipping of the lymph node, because if the patient after the surgery, but retrieval of the lymph nodes post neoadjuvant chemotherapy in those who did clipping of the lymph node, the sensitivity and retrieval is more. I need your comment.
Yes, thank you very much. This is a very legitimate question. And part of my last slides, maybe I had to run through it quickly. It was talking about the concomitance between the clipping and the sentinel lymph node biopsy. Now, we know by heart that the sensitivity and specificity are the issue. We are trying to use all the techniques available and study it once, twice, thrice to make sure it's working for us. Clipping nowadays is very well approved. It's not only the clipping, it's the I-29 magnet sheets, all the seeds and everything. And there was a concordance between the clipped node and sentinel lymph node biopsy in more than 70%. But in another study, the clipped node was not the sentinel lymph node between 9 to 30%. What I wanted to say, yes, I am a strongly advocate for this, especially for certain subsets of patients. HER2 positive and triple negative patients that we know by and large, they will have, inshallah, a complete pathological response. فبالعكس, I totally agree with you. I think it's the approach to come, especially with the availability of the seeds of the 125 that has a long-term effect, visibility. And one more thing, clipping does not replace the standards for the post-neoadjuvant. Clipping does not replace the retrieval of 2 or more, use immunohistochemistry, dual tracer, and interpretation, even for isolated tumor cells. Yes, I totally agree.
Actually, it's not unusual practice. Well-known practice worldwide. The only thing about it, it's only when we are facing dilemma with a single nodal suspicious metastasis lymph nodes. But this is very rare things to do. The only thing, it's kind of because of the issue of the availability of these markers. Actually, it's always after the discussion whether this patient has a single lymph node clinically evident and radiologically evident. We can do that definitely, but we do not want at some point as oncology practice not to run out of clips. But yes, it's a well-known practice. It can be done. It's done few times in our hospital, but for very specific cases. But we can like substitute this practice once it's like requested, actually.
I see.
Yeah, Mr. Mustafa. Can you see those questions?
Yeah.
One of the questions about, do we usually clip the tumor bed during oncoplastic surgery for to help for radiotherapists to give a boost? Usually it is the standard of care. Any breast cancer, usually during the surgery, we have to clip. I know that an oncoplastic technique difficult to clip the bed because the margin is relocated. So usually what we can do, if the tumor is, the tissue is not relocated that much, we are clipping the posterior bit, the muscle. It will help the radiotherapist as well as the radiologist and follow-up imaging afterward. Question, yes, we are clipping the tumor bed with oncoplastic surgery. Dr. Fahad Jindan?
Yes.
Yeah, one question for you. Have you ever tried these procedures for lymphedema in an advanced cancer patient? possibly with a poor performance for symptoms relief?
What kind of procedures is she referring to? The physiologic procedures or the debulking procedures? If she's referring to the physiologic procedures, no, I wouldn't advise doing these procedures in such patients with limited life expectancy. For those, I would offer a more simple procedures just to relieve the symptoms, like the debulking procedures, like the Charles and the wedge excision, liposuction, the ones I showed in my presentation earlier.
Okay, I think the other questions related to the organizing committee, we'll keep it for them to answer. We'll conclude our session for today. So thank you very much for everyone. And it has been a long day. Thank you very much. Okay, we'll announce tomorrow morning, inshallah, at 9:30, we'll start our session. Thank you.